Gastroenterologists who are so busy and have accepted to be here these 2 days. We're extremely grateful to them. We also, I think, have a very interesting program, and having attended some of this program, I think it's not only exam oriented, but I think you get a lot of wisdom from listening to what is happening during these transactions. I'm sure it also has contributed significantly to improvement of knowledge in surgical gastroenterology, and here the pass rates are becoming extremely high, almost I think reaching 100% now. So I think all this is secondary to these courses that are there, and I'm extremely grateful to all the faculty, the pharma sponsoring this, and of course I think our GI surgical unit headed by GB is doing a fantastic job. And welcome again to this clinic. Thank you.
Thank you so much. Welcome to this 12th annual clinic. Actually, we missed out last 2 clinics physically, but we were connected virtually. And I again thank all the faculty for making it here. Can I request the president of IASG, Dr. Balla, to come and
Good morning, everyone. When GB rang me up a couple of months ago saying that he wants to organize this, I said he's most welcome. AIG has been at the forefront of a lot of initiatives, and the GI Surgical Clinics is one of them. And the IASG is very happy to support such activities. And to the younger colleagues who come here to learn, I'm telling you, this is probably one of the only societies which gives so much emphasis on training, and very senior people take time out to come and pass on some wisdom, whatever they have collected during their years to you. And all of you should make the best opportunity, make most of this opportunity. And this is being reflected in our results in the various exams. I want to congratulate Dr. G.V. Rao and Dr. Pradeep for setting up the whole show, and for constantly being at it. Even the clinics we used to have in the mornings, those are also a welcome addition to train young GI surgeons. Thank you very much. Thanks AIG. Thanks Dr. Nageshwar. Thanks everyone for being here. Thank you.
thank you, Balla. Can I request Dr. Pradeep, who is the senior consultant here, and also the past president of IASG, to come and address this group.
Good morning, everyone, and I welcome all the faculty and the students for this 12th session of the AIG PG Clinics. And this time, actually, we wanted to conduct these PG Clinics in memory of our old associate, Professor Venkatesh, who is not amongst us. When we were associated with him in all these CME activities of the ASI as well, and we lost him in the last year. And I know him for the last 30 years, and from undergraduate days, BBS days. After that, we were together at PGI Chandigarh during our MS training, and he was such a jovial fellow, a sportsman, and a very good organizer. He used to be a very good administrator, and he rose from the professor of surgery at Gandhi Medical College to DME, and then afterwards, when the state separated, he moved to Andhra Pradesh. And unfortunately, he had a illness, and he succumbed to the illness, and lost a great friend and a great teacher. And on behalf of the AIG and IASG, we offer condolences to the family here who is here, and may his soul rest in peace. So this session of the 12th PG Clinics, we were in memory of Venkatesh, we are honoring this.
Thank you, Pradeep. Actually, as Dr. Pradeep has indicated, actually these clinics go in memory of Dr. Venkatesh, who's been very closely associated with us. And we have Dr. H. Ramesh here, who has been very closely associated with him for a long time, both as a postgraduate in PGI Chandigarh. Can I request Dr. H. Ramesh to come and say a few words in memory of Venkatesh?
Ladies and gentlemen, Dr. Bhavani, Dr. Jaideep, I met Dr. Venkatesh first when I was a resident in PGI. He was a year junior to me. And despite our vastly different social and economic backgrounds, he was in a family of doctors and a rather wealthy person at that time. We hit it off rather instantly, and it was the beginning of a very long and enduring friendship. To the extent that he was practically best man at my wedding in 1984. When I was selected for MCH in surgical gastroenterology and I had to rush to Chennai to be there, to claim my seat, he was an important part of the process of organization, because he actually traveled ahead to Delhi. He booked my ticket to go from Delhi to Chennai or Madras as it was then. And then he waited for me in the station as I proceeded from Chandigarh to Delhi by train. And my train was 4 hours late, and I found him asleep on the bench on the platform. And really an amazing character who always put on a facade of, of not making a fuss or being concerned about anything. He seemed to be very casual. But once you ripped away the mask, he was a very warm, friendly, concerned, sensitive human being with whom I interacted a lot. He moved up and we moved down. We became clinicians. He was in administration, and as Dr. Pradeep said, he rose up the echelons of administration. I'm certain that if his ill health had not intervened, we were looking at a potential health minister for the state. I really, I was also fortunate, and me and my wife were fortunate to have lots of interactions with the family, especially Dr. Bhavani and Dr. Amrita, his daughter. In fact, Dr. Amrita used to rather grill me with a lot of questions in those days, and that was always it was a pleasant memory for me. I really wish to extend from my family and from the entire IASG family our condolences, and may his soul rest in peace. Thank you.
So to add to all this, in fact, I was the one who probably knew Venkatesh the earliest among everybody. We were together at Kannur Middle College. He was a year junior to me, and I think what Ramesh said is absolutely true about the facade he had of casualness, but the seriousness inside. He subsequently became an DME, Direct Medical Education, which is the highest rank one can achieve in the state of the combined state of Andhra Pradesh, and subsequently went to, when it was divided, to Andhra Pradesh. And we used to have frequent interactions at that time because of administrative problems. He would ring me up and ask me, this has happened, what should we do, and things like that. His father, in fact, I was probably also, we knew senior, his father, Dr. G.V. Raghavulu, was the administrator. He was the Demon HO of the state. And his mother was, Saraswati, was also a well-known gynecologist. So he came from a rich lineage of doctors, administrators, and continued the tradition. We miss him today, and I think I'm extremely glad when GB told me that these clinics are being dedicated to him. I think they deserve to be. He was a true gentleman, a great administrator, and I think a very humble son.
Can I request Dr. Bhavani Venkatesh to come and join us for the lamp lighting ceremony? As a token of appreciation, I think we'll just give a small memento to Mrs. Bhavani Venkatesh. Thank you so much. Actually, I think we'll start our academic session now. I request Dr. Mahesh, who has been coordinating this, and Dr. Rohit, who is here, to start the proceedings.
I would like to invite the first batch, Rachan, Praveen, Ashna, Jayant, and Niket to come up. May I request Dr. Sudeep Shah, Dr. Jashwant, Dr. Balla, and Dr. H. Ramesh, if they can come up the podium. Pratap, sir. Ramesh, sir. We'll have two cases to be discussed in 1.5 hours time, sir. The first case will be for an hour. They have already examined the patient, so they will present the history, physical findings, and the discussion will go on. We'll keep that for 1 hour, and then we'll present a case capsule, which will be for half an hour. We would like to request the faculty to stick to timings. We'll give a ring, sir. We'll give a reminder. Sure, sir. We'll do that. Thank you. You can start.
Good morning, everyone. I'm Dr. Rachan from Asian Institute of Gastroenterology. So I'm presenting the case of 57-year-old male, resident of Darjeeling, West Bengal, who works in the income tax department. AIG 10 days back, and with chief complaints of lump in the left upper quadrant of the abdomen for past 3 to 4 months, significant loss of weight and loss of appetite for past 3 months, and melena for past 1 month. Informant being the patient himself. According to him, he was apparently well 4 months back when he went for the routine checkup to the local practitioner, and he underwent ultrasound, and he was told that he is having some mass in the left side of the abdomen, which is a very enlarged spleen, for which he was and he was not investigated further, and he was started on oral medication twice daily for 1 month, and which he took for few days, and then he stopped. Following that, he started noticing lump in the left upper quadrant of the abdomen for past 3 months, which was insidious in onset, and there was no significant change in the size of the lump since then. There is no change in size of the lump following associated with food. There is no change in the position of the lump with the posture, and there's only it is associated with slight heaviness in the left upper quadrant and early satiety. Also, patient complains of significant loss of weight from almost 15 kg, from 68 to 53 kgs, which was significant. There was unintentional weight loss, and there is also significant loss of appetite from almost one plate of rice per meal to less than half, or just one fourth of the plate per meal, but he is still able to tolerate the solids as well as liquids. And he also complains of melena for past 1 month. Also, occasionally he complains of evening rise of temperature, which was around 19, occasionally once or twice per weekly for past 1 to 2 months, and which is around 99 degree, for which he is not taking any oral medication. It is not associated with profuse sweating. It is not associated with malaise. It is not associated with any chills or rigors. This is the present illness. There's no history of abdominal pain. There's no history of any back pain or any dragging pain or any pain referred to the left shoulder. There's no history of nausea or vomiting. There's no history of altered bowel habits. There's no history of any urinary complaints. There's no history of any blood transfusion or in previous hospital admission. There's no history of hematemesis, abdominal distension, or jaundice. There's no history of easy bruisability or any epistaxis or gum bleeding. There's no history of recurrent URTI. There's no history of breathlessness, cough, hemoptysis, bony pains, or any recurrent headaches. There's no history of altered bowel habits, or there's no in the past medical history, he is non-diabetic. There's no medical risk factor. Only history of pulmonary COX 20 years back, for which he took ATT for 6 months. There's no surgical history. And the present treatment history, I underwent 2 units of blood transfusion after coming to AIG. And personally, he is mixed dietary pattern, is non-alcoholic, is ex-chronic ex-smoker. He took for just 1 to 2 years. 1 pack per year, which he stopped 30 years back, and the normal bowel bladder habits as well as the normal sleeping pattern. And in family, there's no in such present there's no similar illness in the family. There's no malignancy or malignancy related death in the family. His mother and father died at due to elderly age, and that's it, sir.
You said that there is no alteration in bowel habit.
Yes.
And yet you said for 1 month he is having melena. Isn't melena an alteration in the bowel habit? It is, isn't it? So you can't have 2 conflicting statements in the history. So be very careful. Melena you had already given.
Yes.
Now to say no alteration in bowel habit doesn't match.
Okay.
So summarize your history in 1 sentence.
57-year-old male, hailing from Darjeeling, and with the chief complaints of lump in the left upper quadrant, associated with early satiety, significant loss of weight, loss of appetite for past 3 months, melena for past 1 month, easy fatigability, and occasional evening rise of temperature for past 1 to 2 months, past history of pulmonary COX, and current history of 2 units of blood transfusion.
Based on the history, what are you thinking of?
I would like to give a differential diagnosis.
No investigation. What do you think of when you hear this?
Please take off your mask.
Just a little bit before that, could I have one clarification? You mentioned that he went to a physician for an ultrasound. They told him that there was a spleen. And then he had all these symptoms?
Yes, sir.
So he was completely asymptomatic. He was told there is a spleen and then he fell ill.
Absolutely.
That's interesting. Yes. So you have a spleen which is pre-existent and now there is illness. So you know that there's a spleen. So when you give your differential diagnosis, there's a statement of fact. Please use this fact and then please give your differential.
I'm thinking of malignancy as etiology here. This patient probably has some malignancy. Yes, probably a malignancy is what the patient is suffering from, and my differentials will be maybe a carcinoma stomach. Then I'm suspecting gastric cyst, then a splenic, lymphoma of the spleen, then a body or a tail mass of the adenocarcinoma of the body and tail, the pancreas, or
How often do you get such a large mass in a carcinoma of the tail of the pancreas? How many times have you felt a mass of a CA pancreas in the tail?
less like this, but the body and tail is what.
Usually it is not palpable. The tumor is not-
Why are carcinomas of the body or tail less likely to be palpable?
Tail is less likely is what I told, but body and tail both large mass.
If it's an adenocarcinoma, they don't reach that size to produce palpability, by which time they may have metastasized. Yes?
One stage, yes, sir, they can be palpated.
If you wish to talk about a body tail mass and a palpable mass, you can think of other possibilities rather than adenocarcinoma.
No, Sudeep
You
gave you a
already
hint.
know.
He gave you a hint.
You already
Please.
know it's a spleen.
Yeah.
I didn't give much importance to his terminology and not base my differential diagnosis on what his organ of this thing was. Wanted to give a differential. Then
No, if the patient tells you that a physician told him there was a spleen,
He seems to be an
do you want to
educated man,
complete-
isn't he?
He's an income tax officer, so
Income tax
hopefully he's
officer.
educated. Do you really want to ignore this?
form of the spleen also is my differential diagnosis.
Okay, so now assuming that he's correct and it's a spleen,
Yes.
right? What are the causes of splenomegaly, and can you get tumors at sites other than the spleen, which are associated with the causes of splenomegaly?
Differential
And which
diagnosis
produce
of-
melena? And which produce
Yeah, you look at the differential diagnosis of a patient who's got a massive spleen or enlarged spleen with melena,
And blood transfusion.
blood transfusion.
Significant melena.
Diagnosis becomes more focused.
Would you like to add anything, madam, to the differential diagnosis?
I would also like to consider a retroperitoneal mass. Sir.
Be loud. You are not audible. None
Sir.
of you. Right.
Can they just raise the volumes
Hello,
of those?
hello, hello.
mic? No, I think their mic volume has to be.
Hello.
They can share a mic.
Hello.
Yeah.
Sir, I would also like to consider the possibility of a retroperitoneal mass like a lymphoma or a sarcoma. Sir.
So if I were to ask you a specific question,
Yes. Sir.
that you have a splenomegaly, right? What is the differential diagnosis of splenomegaly? And very specifically, can any of these cause tumors at a site other than a primary splenic malignancy? Two questions. So would you give me differential diagnosis of splenomegaly? And any of these differential diagnoses can give you a tumor at a site other than the spleen.
Lymphoma, sir.
Diagnosis of splenomegaly 1, 2, 3, 4, 5, 6.
Lymphoma, myelofibrosis, Kala-Azar, malaria, non-cirrhotic portal hypertension.
Why do you want to say non-cirrhotic? Splenomegaly
It's
is
not
any
important.
portal hypertension.
Sir, portal hypertension. Lymphoma, sir.
Not portal hypertension. You've not seen melena with portal hypertension?
Yes, sir. Malignancy.
Have you seen malignancy with portal hypertension in any patient?
Yes, sir. Yes.
Where?
HCC.
Where is the malignancy?
Sorry, sir.
No, you said you saw malignancy with splenomegaly. Where was the malignancy? In the spleen?
No, sir.
Then where was it?
HCC with portal hypertension and then causing splenomegaly.
Ah, okay. HCC with portal
Portal hypertension.
hypertension and causing splenomegaly. Okay.
the Sudeep question forward? So you have a splenomegaly with melena is one option in this differential diagnosis. The other thing is that the spleen is an innocent spleen, as it just picked up by an ultrasound, but then he has other conditions causing melena. And I'm not sure you have covered the
Splenic flexure mass, sir. Unlike
splenic vein thrombosis producing melena. Fair enough. I mean, it can happen, but I don't suppose a large bowel malignancy can produce melena. Can it?
no, sir. It's usually hematochezia or a change in alteration of bowel habits, sir. He doesn't have any history of alteration except for melena.
Are you suggesting that a transverse colon mass or a mass in the splenic flexure must only produce hematochezia and not melena? Is that a...
No, sir. If he has constipation and there is a delay in the bowel transit,
Yeah.
he can present as melena as well, sir.
I think if you had to look at the organs, you pretty much summarized all the organs, except that, as Dr. Ramesh Adnari said, to postulate that it is a distal pancreatic mass would then have to be a cystadenoma or cystadenocarcinoma or something like that. And then you would have to then try to answer why there is melena. So you need to, after all, when you're asked about the provisional diagnosis, it's just a kind of a reasoning power that is being tested, that you are able to reasonably reason out why these symptoms occur and then make a large canvas of possibilities, which you will then proceed to narrow down as you examine or you investigate. So I don't know if you really use that canvas. If you,
I think they can go to the who is presenting the examination.
Myself. On examination, patient is conscious, cooperative, well-oriented. His ECOG performance status was 1, height of 172 centimeters and weight of 55 kg with a BMI of 18.6. He is well-built and poorly nourished, and there was pallor, no icterus, no cyanosis, no clubbing. Lymph nodes were palpable on both supraclavicular area. On the left side, measuring 2 into 1 centimeter, firm and mobile. On the right side, the 1 into 1 centimeter, firm, mobile lymph node was also palpable. And there was a palpable right axillary node as well, 1 into 1 centimeter, central group, and which was also mobile and non-tender. His vitals, heart rate was 92 per minute, blood pressure was 124/72 millimeters of mercury in the right upper limb in supine position, respiratory rate was 24 per minute, and he was febrile. Oral cavity examination, caries tooth was noted, and there were 2 tooths missing on his left upper premolars. Rest of the oral cavity examination was unremarkable. On abdominal examination, inspection, the visible fullness was noted over the left hypochondrial region. Umbilicus was noted to be central and inverted. There was restricted movement on the left upper quadrant compared to the rest of the quadrants of the abdomen. There were no scars or sinuses, no visible pulsations or peristalsis. There was no renal angle fullness. Hernial orifices, there were no definite cuff impulse noted, and external genitalia appeared to be normal. On palpation, there was no local rise of temperature or tenderness. A hard, non-tender mass was palpable in the left hypochondrium, extending to the left lumbar region as well as to the epigastrium, medially extending up to the midline and laterally up to the left anterior axillary line, measuring 12 centimeters horizontally and 10 centimeters vertically. Fingers could be insinuated between the mass and the left costal margin. The mass was not moving with respiration, and there was limited horizontal mobility. There was no vertical mobility. It was non-tender. On head raising test, the mass became less prominent, suggesting upon intra-abdominal mass.
The history time is over. Now you are an examination.
No other mass was palpable, and there was no umbilical nodule. On percussion, dullness was noted over the mass. Liver dullness was percussed in the right fifth intercostal veins, and since the lower border of liver was not palpable clinically, we percussed the liver span to be 11 centimeters. Renal angle was resonant. Shifting dullness was present. On auscultation, there was no broe, no venous hum, and normal bowel sounds were heard. On digital rectal examination, there was no mass, no blue shelf. Rectum was empty, and the gloves were not stained with motion or blood. Other system examination, cardiovascular system, S1, S2 heard, no murmurs noted. Respiratory system, normal vesicular bright super sounds were heard bilaterally, no added sounds or crepitations were heard. Skull and spine were essentially normal. So,
How did you demonstrate shifting dullness?
so we percussed the flanks initially, and it was quoted to be resonant. So we asked the patient to shift to the opposite. Initially, we percussed on the right flank and asked the patient to shift to left side, and we waited for 1 minute. And when we percussed again, it was noted to be resonant. So, and the dullness shifted to the other side, sir.
Where was the dullness first?
We percussed on the right side first, sir.
So you had only right side dullness, no left side dullness.
The dullness was noted over the mass, sir.
So there was dullness on both sides.
Yes, sir.
And then you shifted to the side. What happened to the dullness?
The dullness shifted, sir.
Became resonant.
Yes, sir. On the right side became resonant, sir.
So basically you are demonstrating shifting resonance. You are not demonstrating shifting dullness. Show shifting dullness, you must bring the patient back into the original position and show that the dullness has returned back to that. That is shifting. Most people we do only shifting resonance. Something that is to be remembered. Not that it's a very great importance, but just tells you there is some free flow. Okay, so now you have got your finding. What are you thinking of in the findings based on this? What is the organ of origin and what could be the cause of the swelling in that organ or other organ?
So from the examination finding, I am ruling out of splenic mass because there is no movement respiration and I could insinuate the fingers between the mass and the costal margin. So eliminating the splenic causes and considering the
A
possibility.
gentle suggestion is don't rule out first. You say he's asking you what do you think. You say what you think, and then you have the option of being questioned. What about the spleen now? And then you have the option of bringing that answer into play.
Okay.
You don't have to exhaust all your options straight away.
Yes. So now I'm considering the first possibility of a gastric mass, sir.
Would a gastric mass move with respiration or not?
No, sir.
Would. Gastric masses would move with respiration. Correct me if I'm wrong. Other
Could move with respiration.
Could should move. Usually it moves because it's in contact with the diaphragm, the fundus. So it will move. So the gastric muscles don't move would be a.
Why don't you sort of counter the question that's asked? Do all gastric masses move with respiration?
I don't think.
Why would a gastric mass
not move
with respiration?
If there is a local infiltration or a posterior fixity, it is
posterior
unlikely to
infiltration
move.
is there to the pancreas, it may not move with respiration.
Or if it's a physically large mass, in which case it may not be so easily, the movement may not be perceived.
Yeah.
Not only that, based on your finding, you said that you can insinuate your fingers between the swelling and the costal margin. So even if it's a gastric mass, obviously it's not in contact with the diaphragm, so it need not move.
Move, sir.
So you can, all gastric masses do not move with respiration.
But also the gastric mass will sit, usually such a large mass, will sit on the aorta. You will get transmitted pulsations usually, and you said there no pulsation. So that again is something that you have to keep in mind.
Okay, sir.
So when you have very large masses in the abdomen, you may not be able to demonstrate all the clinical signs. So the moderately enlarged masses will show you everything, including bloatability, blah, 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 movement with respiration. But when you have a very large mass which is occupying almost the whole entire left abdomen, you may not be able to demonstrate these signs.
Yes.
If I got you correctly, you had axillary as well as cervical lymphadenopathy.
Yes, sir. Right axillary and bilateral cervical lymphadenopathy.
Do you want to add that to what you're finding in the abdomen and give a comprehensive differential first before you come? Would you expect a gastric mass to give you an axillary or a bilateral cervical lymphadenopathy?
For a gastric mass, we expect a left axillary and a left supraclavian node, sir.
How would you stitch everything together?
I would consider lymphoma as a
And
possibility,
a
sir.
little before that when you find these findings, you have suspected splenomegaly, lump in the left hypochondrium, history, notes. Is there anything you want to add to your general examination other than the standard palacynosis clubbing? Because you've not mentioned anything other than the standard features, which would be the same for varicose veins or breast lump. So anything specific you'd like to add?
No, inguinal lymphadenopathy, sir.
No, lymphadenopathy is part of the deal. You mentioned in the history that certain things weren't present. Are there examination findings which would corroborate that? So when you have hematolymphoid malignancies, are there any other signs and symptoms that you're looking for?
Any petechiae, bruisability.
Excellent. Yeah, so you need to mention specifically that this is not there.
Okay,
Where do you look for petechiae?
Upper limb, sir.
No. Where is the first spot where you see? It's actually on the soft palate. So make them say ah and look, that is where the mucosa is thinnest. and that's where you actually get to see the petechiae.
On the eye,
And you look for
whites of the eyes you will see.
easy bruisability. So
Exposed body areas.
petechiae, purpurae, ecchymosis. You know the difference between the three? Yeah, so I mean,
Okay,
this is
sir.
a little more advanced exam, so we won't get into that, but please remember these terminologies.
Yes, sir.
Why would a left axillary prediction be in your gastric neoplasm? You said there is a left axillary.
She
and
mentioned left supraclavicular.
no, but she said left axillary as
No.
well.
Left axillary and she's right.
No, I would like to know from her why she said.
So left axillary lymphadenopathy, palpable significant left axillary node could be an iris nodule, sir.
But why he is asking left? Why not to the right? That's the question.
Because the thoracic duct drains to the left side at the junction of the left IJB and the left subclavian.
Supraclavicular can reflect down to
To the left axilla, sir.
left. You don't get. So with that, the question now, with the lymph nodes, should you like to revise your diagnosis?
Yes, sir. I will also consider the possibility of a lymphoma, sir.
Yeah, wouldn't you have considered that as your first diagnosis with the history of liver, history of loss of appetite, loss of weight, and then these findings which don't match.
Melena usually does correlate with,
Why could there be melena in a patient with lymphoma?
if he has any coagulopathy or a platelet disorder, then he can have melena, sir.
Coagulopathy, it's the platelet
Platelet
deficiency. Many of
deficiency.
them will have platelet deficiency and they can have.
Melena, sir.
So hence the petechiae, purpurae. See, everything links together.
Yes, sir.
So you have to give a whole picture.
What kind of lymphoma are we talking about?
Non-Hodgkin's lymphoma, sir.
Can that involve the bowel?
Yes, sir.
That can produce bleed.
It can cause melena, sir.
If you have a non-Hodgkin's lymphoma in the stomach, exactly what H is saying, that there will be melena, loss of appetite, easy fullness, is eating only 1/4 plate compared to before. So all that fits in, and along with the lymphoma. Everything fits in. So
So one doubt, sir. Can non-Hodgkin's lymphoma in the stomach present as such a huge mass, sir?
what is it?
Can an NHL of the stomach present as such a huge mass, sir?
Yes, we have seen NHS present big masses.
Okay, sir.
That's an emphasis of the Waldeyer stain intraoral examination. Your friend did mention it, but better to emphasize that whether there is a tonsillar enlargement, which is a component of
Okay, sir.
So lymphoma, you have said, stomach, you said is not spleen. You seem to have gone away from spleen. And what else would you think of in this?
In ureteroperitoneal mass, like rare DD sarcoma, sir. Sarcoma. That may be lower down in the line,
Why
sir.
would the sarcoma cause
Melena, that is the,
unless it is eroded the bowel?
that is a rare presentation, sir.
Or of course it could be a pancreatic tumor. Still, what experiment
See,
said,
normally when you have a left hypochondrial lump, which you have ruled out spleen as a possibility, what are the two other common things which present as left hypochondrial masses in your experience? Most common, which you must have seen. It will be either pancreatic tail mass or gastric. So think of those two as the first one and two possibilities. Very rarely, splenic flexure carcinoma also can present in that area because you have to explain melena also.
Yes.
I think time is for clinical examination. How will you proceed to manage this case?
the investigation that they're going to ask for.
Morning, sir. Sir, I would first like to review any previous records if he has, sir.
We don't have it available, let us say.
Since the patient is presenting with mass,
Start presentation. It is not available, let us say.
first I would like to do blood investigation, sir. CBC, because patient has history of blood transfusion, and also he has weight loss. I would like to know the hemoglobin, HB, PCV, and also then I would like to know the renal function test, sir. Urea, creatinine, there is a huge mass. We might later need a CT scan. The CBP has come up. The hemoglobin 6.1, sir. Patient is having severe anemia. Total count is slightly elevated at 13,500 and platelets borderline, so 1.2 lakhs meter cube. I would like to know a renal function test. They look like they're in normal range, sir.
Are you happy with just a CBC as a hemogram? Can the hematologist give you some more information?
Yes, complete hemogram would be better, sir. Because
Anything
patient is having
else
anemia.
Besides that, especially when you got multiple lymph nodes.
Peripheral smear, sir. Peripheral smear. Mild degree of anesthetic microcytic hypoplamic with the normal macrocytes target sensing. Neutrophilic leukocytosis, hypersegmented neutrophilia, and mild thrombocytopenia.
What does this suggest to you?
Patient, can I just?
Hemogram shows anemia,
Yes,
mild thrombocytopenia.
Yes.
What next you want?
What does it suggest to you?
Multiple, actually, there is hypersegmented neutrophilia, sir.
Yeah, that's fine, but
Infection. And
more important, look at the first line.
anisocytosis
First line, microcytic hypochromic.
with normocytic.
So that means that patient is losing blood
Yes, sir.
and the
Acute and
marrow is
chronic.
trying to produce and so
Acute and
a
chronic.
little immature cells are coming into
Yes,
the
sir.
circulation and therefore you're getting this picture.
Yes.
Okay.
Acute and chronic blood loss.
Yeah. Suffering from chronic blood loss. Yeah. What else do you want now?
Yes, sir. Target cells are seen, sir.
Even the anisocytosis is very mild.
Yes.
Therefore, there is no obvious evidence of hemolysis as far as this picture is concerned.
I would like to know RFT, sir, next.
Normal. Projected.
Yes. My next would be liver function test. Patient. Sir, patient is presenting with a huge mass, sir. Two things. One thing mainly is that we might plan for CT scan later. So we will require creatinine levels, sir. That is the main reason I would like to do RFT, sir.
Okay, LFT is projected. So
LFT, the albumin level is 3.1, sir, and there is a reversal of albumin globulin ratio, sir. And INR is slightly elevated, 1.28.
okay, what next?
Rest looks normal, sir.
But is it within acceptable limits or not?
Yes, sir.
What is the acceptable limit of your INR elevation?
1.2.
1.3 is what we keep as acceptable. So 1.28 is okay. You can do a procedure with that. You can do a liver biopsy with that.
How do you explain this AG ratio reversal?
Patient is having malnutrition, sir. Basically, he has been having weight loss from past 3 months.
You'd attribute it to that. Any other differentials? All the cause of AG ratio reversal?
Don't just because of fall of albumin.
Infection, sir.
So see, here you are finding a high globulin.
Globulin.
So it could be because of your lymphoma.
Yes, sir.
That the globulins have gone up.
So chronic liver disease, malnutrition, one set, and chronic blood loss itself can cause a lowered albumin and an increase in the globulin.
Next, what would you like?
I would like to do ultrasound of abdomen, sir.
Anything else before that? Routinely, we tend to do it. Would you like to know the viral, normal viral markers which we do? HBsAg, HCV, and HIV, because they can all cause
Lymphoma. Lymph node
enlargement masses. So it's a routine. So they do it. Chest X-ray.
What if in the exam, the examiner asks you, instead of ultrasound abdomen, chest X-ray, why not straight away CECT chest and abdomen?
Ultrasound abdomen will give us a gross idea of what system is involved, what organ is involved, and what could be possible pathology, sir. And sometimes.
So you see this report here, there is a mass connected to the stomach. Okay, that's the report.
Yes, sir.
So will you stop with this or you'll again go for CECT abdomen?
Here I would like to go for CECT abdomen and chest, sir.
How often you have stopped with only ultrasound abdomen and not done CECT in such a case? Ever?
No, sir.
So now the trend is changing to not repeat, do chest ultrasound abdomen, chest X-ray, because anyhow you will be planning to do a CECT chest and abdomen in these cases. So just remember that some people still stick to chest X-ray and ultrasound abdomen, but there is an alternative. Anyhow you are going to do a CECT abdomen and chest. So it's not a wrong answer to say I'll straight away do upper GI endoscopy and CECT.
But logically,
Yes, sir.
if you have got a stomach mass for which an endoscopy has been done or biopsy, the ultrasound shows you ascites, multiple lymph nodes, secondaries in the liver, then a CT scan is superfluous. But if you don't do it, the oncologist will do it. So that is because, and the reason they do it is not just clinical, there are other reasons why they do it, which I won't mention because that is not part of our discussion here. But the answer to that question is that if you have approved stomach with multiple secondaries in the liver and ascites and or ascites on ultrasound, a CT scan is really superfluous because already this is a metastatic disease. There is really no need for a CT scan.
Just as an aside, can you name some conditions in your surgical GI practice where ultrasound gives you more information than CT?
One gallbladder stones, sir. Gallbladder stones.
Radiolucent gallstones.
Yes, sir.
Any others?
Yes.
Also, in the sense when you're ordering investigations, to keep one or two funders in mind is that you go from the simple to the complex, you go from less expensive to more expensive, and you go from less invasive to more invasive in that sequence. So that could be one logic which you could use to justify doing an ultrasound before you do anything else.
An interesting question. Where does ultrasound help you more than CT?
I think that I'm very interested in hearing your answers.
Gallbladder stones, liver simple cyst, hemangioma of the liver. When we apply the Doppler, that will also be, which will be more helpful.
In a hemangioma, are you sure your ultrasound will give you more information than CT? See, you be careful, no? Because by CT we mean contrast CT.
See, in all the conditions which you have mentioned, in the end, if you see, your radiologist will write, correlate with CECT.
So essentially, when you're looking at
cases.
textures, for example, liver fibrosis, cirrhosis, you'll get more information. Radiolucent gallstones, and when you have a lot of artifacts, so if you have people who have coils, for example, stents, you get a lot of information because you get a lot of artifacts on CT and which you will not get in the ultrasound. So a good sonologist is really your friend.
So you have seen the ultrasound report. What do you think based on the ultrasound report? Projection again.
The last line I couldn't read. So basically, it's originating from the body of stomach walls, extramural mass lesion, large lesion in the It's adherent to the posterior wall of body of stomach with the varicose.
So what do you think is the possibility or possibilities?
There is one thing I was considering because it is arising from body of stomach, large lesion as a gist cell. But with the varicose,
What is the varicose? You say gist, but you say thickness in the walls of the body of the stomach
Yes.
and an extraluminal mass lesion.
Yes.
Both happen in gist? Thickening of the wall?
arising from the wall and extending extramurally, sir.
So can you correlate the findings, large mass, adherent to stomach, with varicose? What is varicose mean on ultrasound?
Uh,
Hair has got into the tumor.
yes, sir.
How will it get into the tumor? That's a small ulcer or perforation in the tumor open towards the lumen.
Tumor.
So you will get the fact that there is no
Yes.
cavitated lesion.
So
you will get
necrotic cavitatory lesion communicating with the lumen of the stomach. That's the impression based on what you got in ultrasound. So what do you think?
It could be a large gist, sir,
Yes.
with internal
Yes.
necrosis and
So what will you do next?
I would like to do contrast and CT of just thorax and abdomen.
Would you like to do a contrast and CT as the very next investigation?
Endoscopic biopsy.
See, this is the problem. You have committed yourself. I will do a contrast and when I question you, immediately you change and say I will do an endoscopy. Now, we all would like to do an endoscopy because it's arising from the stomach, and you can get a histology, isn't it? So be what you see. The examination is not different from what you do in the outpatient. In the outpatient, the next investigation we'll order would be to send the patient for an endoscopy and then give him a CT form telling him after the endoscopy you get a CT scan. So we will do if you have to do one first, we will do an OGD first. So that is what you should also think of.
So that's the endoscopy. What else do you want on endoscopy?
I would like to have a biopsy.
Speak into the mic.
Sir, I would like to have the biopsy, sir.
No, but wouldn't you like to have a little definition of what is that on the endoscopy?
Yes, sir.
You just saw 3 photographs, which means nothing. So you have to find out what the endoscopist has actually seen. So now you should first say, I would like to see the report, or I would like to see a video of the endoscopy so that I can make an idea what it is. With 3 pictures, you can't make a comment. All you see is a growth. You don't know what the growth is, where it is. You don't. From the OG junction, how far is it? From the duodenum, how far? Nothing is seen. You want to see this. What does it show?
Okay, there is a large ulcer prolific growth, sir, in the body along the lesser curvature. So I would like to take biopsy from this growth, sir. So the biopsy shows adenoma with high-grade dysplasia with suspicious foci of invasion. So not very confirmatory, not confirmatory of the malignancy. High-grade.
What next?
I would like to do a contrast analysis CT scan, sir, chest and thorax and abdomen.
Will it clarify your biopsy?
No, sir. It's a large mass with high-grade dysplasia in biopsy. So if it is operable, would like to.
Normally, do you get a high-grade dysplasia as a diagnosis when you see such a large mass?
No.
I'm a little astonished that you're already thinking of surgery when you have some unresolved questions in this case. You have a mass whose histology is not established. You have a mass whose extent is not established, whether there is extragastric involvement. And you have a mass with a patient who has some lymph nodes elsewhere in the body. And without factoring any of these, if you say that my plan is to do a CT and if it's operable, I would operate, it suggests to me that you have completely forgotten about the patient and you're looking only at the mass. That's my concern.
So that's precisely the thing. What else could you do?
I would be happy to repeat the endoscopy. if that is
Yes. I think you should be happy to repeat the endoscopy, and you should tell the endoscopist to take what is called as a well biopsy rather than multiple biopsy at various, because obviously superficially the biopsy is not giving you a diagnosis. So you want a well biopsy. You take 6 biopsies in the same spot. So you go deeper. So now you are likely to have reached the tumor and you will probably get a positive.
On endoscopy, if you find a lesion and the initial biopsy is inconclusive, the standard answer always is repeat deeper biopsies. Okay. If necessary, by EUS guided deeper biopsies, if facilities are available.
Do you think this mass is unrelated to the lymphadenopathy?
No, sir.
What is the easiest thing to biopsy in? Which is in your control, where you don't, unless you are an expert endoscopist?
Lymph node biopsy.
Which one would you do? Axillary or cervical?
Cervical lymph node, sir.
Which cervical, right or left?
The left cervical lymph node.
So tell the full, see, this is what the thing. First time you tell, if you are told that 3 questions would not be asked. First said, I do a left cervical lymph node biopsy, but it's the largest node, it's 2 centimeters. You do not spend an FNAC before the biopsy. In FNAC, you can get an answer within 6 hours with the probability. That shows you adenocarcinoma. You really don't need to do
Any other?
cervical biopsy or the gastric biopsy. Isn't it? So,
Prefer an FNAC or a biopsy?
Biopsy would be more specific, sir.
No, the question was FNAC or
I
biopsy.
would do first FNA, sir. It is easier to perform, and sir will get early result.
So that's how we should answer.
actually, I would have probably done the FNAC in the outpatient even before the first endoscopy because it's so easy to do. You know, endoscopy has to come fasting, maybe the next day. By that time, you will have an answer already from this, if it is there an answer. I would have done it even on the first day itself.
So repeat biopsy has been done or not?
No, sir.
No.
FNAC of the node,
Today schedules.
No.
Today he schedules.
It's
He scheduled for today.
for
a schedule for today. Okay.
Okay. So
Okay.
you want CECT?
Yes.
Okay.
Perhaps as well, and in practice, it's customary for us to explain to the patient what is your plan of action. So you can actually spell that out. You can tell them that the ultrasound showed a mass in the relation to the stomach. So I wish to, first of all, define what this mass is, get more information about the mass. Also, there is a problem with your glands in the neck. So I probably will do this test from here as well to know whether these two are related or unrelated. So it keeps the patient in the know. It also tells the examiner that you are seeing a real patient. You're not talking about this theory. Still, the way you say this, you can actually justify most of your approaches. Each one may have a subtly different approach, which is all acceptable, provided you are carrying the patient along.
What would not be acceptable is first to do the CT scan before the endoscopy, and second, without telling what that supraclavicular node is or defining it, to say that I will plan for surgery. These two would be unacceptable answers in this scenario.
Correct.
The rest you could go about in any of the ways, and most of us would accept it. But these two, most of us will not accept.
The CT could be sort of, I could accept it, but not the cervical lymph node.
Yeah, that I think you should address, because that makes it inoperable. You should not be operating that. So, what do you see on the CT?
These are the plain axial images, sir. On we could see a large mass.
Just a minute. Is it a plain axial view?
The early one was plain.
Early one
Oh,
was,
the earlier one. Okay.
yeah, earlier one
contrast.
was plain, now contrast.
Okay.
We can see a large enhancing mass in close relation to the posterior wall of the stomach with hypertense areas and cavity, sir. Air cavity.
Is it enhancing uniformly?
No, sir. Non-uniform enhancement, sir.
So where is it enhancing?
Peripherally.
Only
Peripheral
peripheral. That is why you have the necrosis in the center.
Yes.
No, there is no blood flow. It is all necrosis. How is the pancreas?
Pancreas looks normal, sir.
Normal, yeah. So it doesn't seem to be arising from the pancreas. There's a plane between that and the pancreas. Our pancreatic tumor is ruled out. Okay.
Liver free fluid, sir. Any lymph nodes?
Are there any lymph nodes?
I thought you were talking in the beginning about some spleen in this patient.
Yes, sir. Spleen normal.
Don't you want to at least
Yes.
comment about whether the
Spleen
spleen is enlarged or not?
Spleen is normal, sir.
Okay. Do you have any significant lymph nodes?
So this
No,
is CCT abdomen and chest. The
Yes.
minimum you are supposed to say
Chest
is when you are going through the chest. Is there any evidence of
Just look normal, sir.
lung secondaries or pleural effusion? In the abdomen, the minimum you are supposed to is describe the lesion, spleen, rule out spleen, then any liver secondaries, any lymph node secondaries, any ascites.
No lymph nodes, sir. There is no free fluid. Liver, there are no lesions in the liver. Spleen is normal.
So in this cut, what is important for you to also comment? It's a large tumor in the stomach. So would you like to comment on something else? You can see it very clearly. Go or cut down or up. Just move it down. Up. Yeah, hold it there. What can you see there very clearly? There does seem to be a small lymph node, but something else is very clearly seen. You must always look at the crura of the diaphragm, especially in a stomach tumor which involves the lesser curve, and see whether the crura are involved. Because if they are involved, then either you have to give some pre-op treatment or you have to excise the crura at the time of surgery. So here you can see the crura on either side of the aorta. There seems to be a lymph node on the left side, round next to the crura, but the crura itself seems not infiltrated directly by the growth. That's something that you should note.
So what's the CT impression?
Large mass arising from the posterior wall and
Impression.
I would consider it gist of stomach itself.
So why do you think it is just not CS stomach with the extraluminal component?
Non-uniform enhancement. Non-uniform enhancement, sir, with central
Go back to the
necrosis.
endoscopic. Can you go back to the endoscopic picture?
With necrotic areas and gas within, sir.
You met many gists with axillary and cervical lymph nodes.
Rarely possible, sir.
How often have you seen extensive lymphadenopathy in a GIST patient?
Not.
Or any lymphadenopathy in a gist patient. What is your surgery for gist of the stomach?
Sir, if it is small, we can do veg resection, sir.
Why do you do a nodal clearance?
No, sir.
Why not?
Unless there is a positive lymph nodes.
Have you seen? No, so why do you not? So why is it not standard to do a nodal clearance? In a gist?
Because rare.
They do not spread to the
yes, sir.
nodes.
Lymphomatosis
Yeah.
is
While
rare.
neuroendocrine tumor, other tumors, adenocarcinoma, you'll always do a nodal clearance, correct? No? So then that itself tells you that just don't go to nodes.
Oh.
Yeah.
Can it still be a lymphoma?
Yes, sir. It could be a lymph node, sir.
Or is it just GIST and nothing?
No, sir. Gist is my first primary diagnosis, sir. It could be lymphoma, but no other lymph nodes in the abdomen, sir.
I mean, personally, your primary diagnosis to fit in everything that you're seeing. Yeah. So axillary nodes are usually pathological, cervical nodes are usually pathological. They're large, 2 centimeters in size, and you have something. Could these all be nodes which have formed a nodal mass eroding in the stomach, or this that is not possible on
Doesn't
the
look
CT?
like
A nodal mass?
no. Sir.
So if your impression is gist of the stomach with no obvious spread to lymph nodes or lung, what next you want to do? It's still not biopsy proven.
Can we just see the CT again? Would you like to see the characteristics of the mass on the CT and describe it a little more? Yeah, here. So suppose I say this is not coming from the stomach and this is the lymph nodal mass. What are the points in favor?
The surface is irregular, sir. So it's like multiple lymph nodes which would have combined. So the surface looks irregular. Peripheral enhancement, hypodensity at the center.
So it could well be a lymph nodal mass which is infiltrating the stomach.
But ultimately, what this tells you is that even after the CT, you don't have a diagnosis, and you really can't manage this patient now unless you get a biopsy which guides you in one or the other direction. So you need those biopsies. You need the biopsy of the stomach. You need the biopsy of that lymph node, and then only you can actually decide what you have to do, because the treatments are going to be different. So let us say that the biopsy from the lymph node shows tubercular focus, okay, granulomatous changes. But the stomach biopsy shows features of suggestive of GIST, and they do an immunohistochemistry, and it is CD117 positive. So you got two diagnoses now. This is tuberculosis, and this is GIST with CD117 positive. What are you going to do for the patient? Because we have to discuss now theoretically, because we don't have the biopsies here.
We'd like to start the patient on ADT first, sir. Like the patient ADT.
How will you administer the ATT? What drugs will you administer?
So 6 months course with the 2 months of HRZD and 4 months of HRD, sir.
And then what will happen after that? And meanwhile, what do you expect this gastric tumor to do, considering that there is melena and a hemoglobin of 6 grams? 2 grams have probably a couple of grams have gone up on blood transfusion. So you have a
large mass, sir. I would like to start the patient on imatinib, sir. After
so you would give ATT plus imatinib.
Yes.
Or now, would you like to see whether there are other signs of active tuberculosis in the patient? Whether there's pulmonary tuberculosis, whether there's sputum is positive, would all that make a difference to your management? Is it possible, in other words, is it possible to operate a patient who has cervical lymph node tuberculosis? Can you operate the patients first up and then give the ATT? Is that a feasible proposition?
we can start the patient on isoniazid HRE, sir, and they say like we normally within 2 weeks the patient will be negative when there won't be active tuberculosis. So we can go ahead with surgery if we are planning for upfront surgery, sir.
Let's ask the last gentleman sitting there his opinion on this. What question H?
We will start him on ATT, sir, and in consultation with the TB expert, pulmonary medicine consultancy. If they say clearance for the surgery, then we can plan surgery.
So you would operate, so 2 weeks ATT, and then you're going to operate this patient. Is that what you're trying to do?
What Dr. Ramesh sir is asking is, what's your plan?
Yeah, so that your plan is to operate after 2 weeks of ATT if the pulmonologist clears.
Yes.
That's what I understand.
Yes.
How many of you would operate this patient straight away? Please raise your hands in the audience also and in the faculty. How many of you would like to operate this patient after 2 weeks of ATT if it is tuberculosis? Or 4 weeks of ATT, let us also say. How many of you would like to operate? Or forget the tuberculosis and you're only the mass. How many of you would like to operate? We have a few hands up. I would not like to operate this patient straight away. This is huge mass. CD117 positive, I said. So ideal for neoadjuvant hematomegaly. Okay, 6 months.
I
think
just like
there
to be
is-
the devil's advocate here.
Yeah.
Ramesh, how long would you want, you're not going to switch he's going to be the candidate, not you. How long would you want the neoadjuvant therapy to
6
go on?
months and reassess.
And then if you find that there is poor response, then when would you start reassessing the patient? Is
I would
the
ask him
response
to come at 3
imatinib
months.
guaranteed?
I would ask him to come at 3 months and I would be examining him clinically to see if the mass has regressed in size, get an ultrasound to see if the mass has regressed in size.
I'd like to be a devil's advocate and say that this is an unusual mass which, though is huge in size, does not seem to have any vascular or organ involvement and provides the potential for an upfront surgery, and that opportunity should not be lost.
No, but
because the response to imatinib is not guaranteed. It takes a minimum of 6 months, and many patients actually go out of.
The standard of treatment today would be that such a large mass with necrotic areas, when you operate, you're going to rupture that tumor, there's going to be spillage of tumor. So you would like to give, to prevent all this, neoadjuvant imatinib for 6 months and then operate. That would be my approach, and that is what is the approach generally advocated in the guidelines.
Sir, I disagree with you. A patient of GIST presenting with severe anemia, which clearly appears operable. I'm not saying there's no role for imatinib in GIST as a neoadjuvant.
No, sir, not
But in clearly
operable.
I think we can agree to disagree. I think the candidates are very abused. They all will wish
they'll
their
be
FCH
confused.
exam goes like
But I
this.
would like them to see standard guidelines. Please see NCCN or ESMO guideline and then follow, not our opinions. Our opinions, we have not done research on this. So
I think we can move on, sir.
You can do that.
Both of you have good points.
Sir, can I ask one thing? Sir,
Yeah.
if we are starting on imatinib, then what is the ideal time to see the response of?
3 months you should examine the patient, but you have to give it for a total of 6 months if the response is already there, because then it will shrink. We have seen 20 centimeter imatinib shrink to 6 centimeters after 6 months of imatinib, and then we have comfortably operated them laparoscopically also, and then the patient has been put on post-op imatinib for 3 years, as the oncologists nowadays put, and these patients have done well. And I must say that upfront operation, often the tumor ruptures because these are all necrotic tumors, and when you give imatinib, the anemia, the bleeding will stop because the tumor responds. The anemia will also become all right. You have to just give iron replacement by either intravenous or by oral route.
What if the tumor doesn't respond to imatinib?
If the tumor doesn't respond, then you have to operate. Then either you can discuss with the oncologist whether you would like to try a second line of treatment or operate.
No, they're molecular markers. You might have to increase the dose, so you have to see whether there's a chromosome 9 mutation. See the many
Then
intricacies.
see the dog1 mutation and
Yeah.
everything.
No, I just want to, as a clinician also, I think you should try and make a distinction between the large mass, which seems operable, and the mass with other satellite nodules in the abdomen. Those are an absolute indication for no surgery. There, even if the primary is resectable, then you want to place the patient on neoadjuvant imatinib. But this is not a usual situation. Many of these tumors will be infiltrating the pancreas, will have a lot of attachment to other organs. But if it does not, then I said maybe.
But I would still follow the guidelines and go with imatinib and see the response, because it seems to be a reasonable way to approach these.
I think the guidelines, NCCN says that we should repeat PET CT after 1 week, starting imatinib to see
that is that they have
That we move to the case capsules. We are running short
so
of
they have put that. PET
We'll be
CT.
very interested in the final diagnosis on.
Have you got any biopsy diagnosis at all?
Repeat biopsy has been done, sir. We are waiting for the biopsy report, actually.
So it's most likely to be an adenocarcinoma from you.
No, we
No,
don't.
we-
See, adenoma is the worst possible diagnosis. So,
No,
we
but
don't know
just-
what this
we
is.
just wanted to discuss just because we couldn't discuss both in the time. That's why we took up
It's easier than lymphoma to discuss.
discuss.
This patient came back just 2 days back, sir. So we are just working up.
Okay, okay, agreed.
We'll move to the case capture.
Yeah, caps.
In the CT scan, you are not getting any classical subepithelial mark. It's a diffuse thing. And to have such a diffuse gist is very unlikely. I'm not inclined to believe that this could be a gist.
Yeah, we agree with you that with the biopsy of an adenoma with dysplasia, more likely to be an adenocarcinoma is probably you're right. Or maybe even a lymphoma, because poorly differentiated adenocarcinomas can be difficult to differentiate from a lymphoma on biopsy.
No, we discussed it as just based on ultrasound and CT
That's what
findings.
we had to choose one diagnosis in
One
the time to
diagnosis.
discuss. So we thought everybody discusses CS stomach, so we thought
Yeah.
we'd go for GIST.
Such a large exophytic mass with central necrosis, with air in the center of the tumor, most of the time will turn out to be GIST.
And also bleeding.
Yeah, with bleeding.
So
So
turns out to be
I think
very
we'll go
often.
to the case capsule.
Project.
One last point. If you are suspecting one of the suspicions is lymphoma, then probably if you have a large lymph node, better than an FNA is a true cut biopsy or a excision biopsy.
By the way, I just want to, since he has brought up this, there is a paper in the latest British Journal of Surgery which suggests that percutaneous biopsies of GIST followed by imaginative and resection, there is a higher percentage of seedling of the tumor tract and recurrence of the tumor. So they have suggested that the biopsy should be from the endoscope as far as possible. So this paper has just come. It's a single paper, but I just want to just point out. Yes. Could you read it out, because we find it difficult to read it.
So we have a case of 70-year-old female resident of Telangana and homemaker. She's a homemaker. Came with complaints of colic abdominal pain for 1 month. Coming to history of presenting illness, a patient was apparently all right till 1 month back, following which she developed colic abdominal pain, which appears 30 to 40 minutes after taking food and subsides on its own. Pain is associated with borbogamy sounds and which also subsides after some time. For the past 1 week, the frequency and intensity of the symptoms increased, and the patient had to take medications for the symptoms. There was no history of abdominal distension, constipation or diarrhea, no history of vomitings, no history of fever, no history of hematemesis, melena or hematochezia, no history of jaundice, no history of altered bowel habits, and no history of loss of weight or loss of appetite. A patient has no history of similar complaints in the past, and patient does not have any medical risk factors and no past surgeries. Coming to personal history, patient's sleep, appetite, bladder and bowel habits are normal, and she takes mixed diet, no addictions, and family history is nil significant. Coming to general physical examination, patient is conscious, cooperative and well oriented, moderately built and moderately nourished, ECOG performance status of 1, blood holding time of 30 seconds, and BMI of 22. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema, and her pulse rate is 68 per minute, BP is 118 over 72 millimeters of mercury, and respiratory rate is 16, and patient is apoptotic. On per abdomen examination, on inspection, abdomen is flat, umbilicus is central and inverted, all quadrants are moving correspondingly with respiration, no scars, sinuses, engorged veins, visible peristalsis or visible pulsations, the hernial orifices are normal. On palpation, abdomen is soft, non-tender, and their liver and spleen are non-palpable, and no other palpable lumps, and her hernial sites are normal. Coming to percussion, liver dullness is felt at 50 intercostal space, and liver span is 13 centimeters in midclavicular line, and flank is tympanic, shifting dullness is absent, and fluid thrill is absent. On auscultation, normal bowel sounds are heard, and distal rectal examination, patient is not well. Other system examination, respiratory system, normal vesicular breath sounds are heard, and bilateral air entry is equal, and no crepitations or added sounds. CVC is S1, S2 normal, and CNS no focal neurological deficits.
Carry on. Finish the case. So we have 15 minutes only.
So to summarize, a patient came with complaints of colic abdominal pain, sir, for 1 month with a recent increase in the symptoms.
Whatever blood test, ultrasound you have done, that we will stop.
So based on the case capsule, what is the likely possibility? Any one of you?
Most probably a bowel pathology, most probably a small bowel pathology. Patient is having colics. I would like to know the site if he is able to localize exactly where it is. It's periumbilical or hypogastric or even.
So your impression is
a bowel pathology
causing
pathology.
subacute obstruction.
Yes, sir.
So what would you do?
Sir, I'd love to get a ultrasound abdomen at the first place as a part of continuing of clinical examination. I'm able to
See, if your impression is subacute obstruction, how often ultrasound helps in such situations?
for any mass X-ray abdomen.
There was no mention of any mass, no. How will ultrasound help you?
X-ray abdomen supine to see
If at all
the.
you want, you could have said abdominal X-ray, erect supine to know the bowel pattern. Or you could have straight away said CCT abdomen.
For that, I'll do RFTs. Before
Yeah,
that, I'll do,
I would agree with the candidate that my first investigation would be blood test and an ultrasound. You want to know what I would expect in the ultrasound? With the high sensitivity probes that we have now and the high frequency probes, they are able to tell us about bowel thickness, and they can sometimes pinpoint and say the terminal ileal loops are thickened, they are matted, or there is some sign in the cecum or in the ascending colon.
Sir, in the present
I would do.
I know this.
Would an X-ray be appropriate?
Exactly. I think
if you did an X-ray, what X-ray would be important? Who was the answering the question? What X-ray would you do?
I would do a supine abdominal X-ray in this patient.
What would be the
To see the level of dilatation, like which site of, in case if it is small bowel, it is the proximal small bowel more dilated or the distal loops are dilated.
You would like to see if there's dilatation in the first place.
Yes, sir.
If there are gas-filled loops,
Yes,
and if so, then
where is the site of dilatation?
how would you determine the site?
So if it is on the left upper quadrant, is the more the bowel loops are more in the left upper abdomen.
So you don't think that a patient can have malrotation and have a different location? Is that location the key, or is it the type of the gas pattern that could give you a guideline?
Also the features of the small bowel to more prominent valvular conventers suggest more proximal intestines, and less features, more distal small intestine, ileum.
You would first like to know if there's gas in the colon.
Yes.
Isn't it?
Malrotation, again, most of our phonologists comment specifically upon that, especially when the SMV SMA relationship.
Yeah, Ramesh's point is valid that an excellent ultrasonographer is able to get a whole lot of information that they were not able to do before. But having said that, I think Puneet's remark is also true that, you are not going to be able to clinch your diagnosis based on ultrasound.
You want to
anyway.
clinch a diagnosis
So-
nowadays, contrast enhanced CT is the investigation.
I think
I
that
don't
I'm not
think any
sure
of-
I would agree. Ultrasound is today an extension of clinical examination.
Sir, I agree with
and
that.
Therefore, I would.
Yeah.
So a question, sir. Because in clinical examination there is no abdominal distension. That's why can we
speak into the mic?
So,
It is basically it's quite appropriate for you to say that there is not much abdominal distension, so I did not think of an abdominal X-ray, which would lend you to the point of the examiner asking you, is an abdominal distension an integral part of intestinal obstruction, or does it depend on the level of obstruction? So you would then expose the patient. Now, if you have a an examiner who is rather keen on ultrasound because in his practice he finds it very useful. He probably has a excellent ultrasonographer who gives him more information.
Done.
Then you says yes, I would be happy to do an ultrasound. So you don't have to stick to your guns and argue the point.
You ultrasound any?
Yeah, the complete blood picture was normal.
Okay, have the blood test, please. We can see that so we can finish that.
I also don't think we should ignore things like urine examination and stool examination. They seem to be lost from our practice. But if there's a good pathologist, you might find something like ascaris, which will solve your problems in a lot of people.
X-ray has been done, sir. There are no air fluid levels.
This is the ultrasound. Anything you?
Trochoic mass lesions in the right lobe of liver, 10 into 9 centimeter with multiple other similar lesions in both lobes of the liver. Rest of the features are normal. Rest of the organs.
Speak loudly.
Rest of the organs commented are normal. No comment on the bowel specifically. Like to ask the ultrasonography radiologist if he was able to examine the same or any difficulty.
So, why are you now interested in the bowel when there is such a clear lesion in the liver?
Symptomatology is colicky abdominal pain.
Absolutely. So you are now thinking that these two could be linked. There could be a malignant mass in the
Yes, sir.
bowel, which is causing subacute obstruction, and that is a metastasis in the liver. So that's what you're thinking, and I think that's a correct point that you're thinking. So,
What next?
what next?
I would like to see the creatinine report if it is normal.
Normal.
Saying I'll do RFT because I may be thinking of a CT scan. After ensuring normal renal function, I would do a contrast enhanced CT scan. That's good enough. I think no examiner is going to, hold you to it.
So what will you do?
On the other hand, it's also important to notice that when the liver is chronically diseased, and the creatinine is 6 or 7, the nephrologists say, go ahead and do a contrast enhanced CT. We will dialyze the contrast out later. Anyway, he's got chronic kidney disease. So both are applicable. Please remember.
Next, I would like to do a contrast enhanced computed tomography of the chest, abdomen, and pelvis for.
Can we have the CT scan, please?
During the liver lesions, would you consider giving oral contrast to a patient with a suspected bowel obstruction?
In this patient, I'll consider giving a oral contrast because
That's
as of now, he's currently not in obstruction based on clinical examination. I would consider.
I am informed, I learned this many years ago from the radiologist, that it is not a good, wise thing to do, give oral contrast
What are the types
during
of oral
diagnosis of
contrast?
intestinal
To
obstruction.
Answer that question. What are the types of oral contrast you can give?
That's a good question.
But now mostly they give negative contrast.
Yeah,
which is
negative
just water.
contrast is the only thing
Water
acceptable.
itself is a good.
Water
They
is
use
the only
water
contrast.
now. Most of them negative. It's called a negative contrast.
Positive contrast, it will obscure the picture at the level of the obstruction. And if it's an acute intestinal obstruction and there's gangrene, even the lack of the ischemia of the bowel will not be well, appreciated because of this contrast in the bowel. So they don't want contrast; they want only water as the contrast.
So in an undiagnosed case, CCT is only with IV contrast.
And oral negative contrast. Water.
Oral negative also, a lot of people do it as a later procedure.
Yeah, a second procedure.
Yeah.
Axial sections of CT abdomen, the lower lung fields, no effusion. Large.
Be loud.
Yeah.
None of the backbenchers will hear you.
An arterial phase. We go back again.
The first thing you need to do is catch the person with the clinical examination of this patient.
Arterial phase.
The liver is almost up to the end.
A large heterogeneously enhancing well-defined lesion in the right lobe of the liver with peripheral enhancement.
Which phase are you looking at?
Arterial phase.
Yeah. Are you seeing anything else in the rest of the liver? Go back slowly a little bit.
Multiple.
So the multiple lesions, smaller scattered lesions in the rest of the liver, enhancing on the arterial phase. Yeah.
Yeah. See an enhancing heterogeneously appearing lesion in the probably small bowel.
Is that the small bowel?
More down. Yeah, here too we could see a enhancing appendix mass lesion in the most probably a terminal small bowel.
So it's difficult for you, we accept, but now you have a bowel enhancing lesion, multiple arterially enhancing liver lesions. Give me one diagnosis.
Neuroendocrine tumor. Small bowel neuroendocrine.
So the impression is neuroendocrine tumor of the small bowel with liver mets.
What is the commonest tumor of the small bowel? Malignant tumor, sorry, not specified. Commonest malignant tumor of the small bowel. Is it a neuroendocrine tumor or is it an adenocarcinoma?
Neuroendocrine tumor.
Adenocarcinoma is the commonest tumor, am I right?
Neuroendocrine, sir.
Huh?
Small bowel carcinoids.
Neuroendocrine is considered the commonest tumors.
No, I said malignant tumor. So,
big spectrum. So, okay, let's stick to this.
So, if you say
neuroendocrine, show us the venous phase, then we can continue the discussion.
Continue this. So, if your impression is neuroendocrine tumor with liver mets, what next would you want to do?
come on, man. This next step should be.
I think
you have to prove the tumor, isn't it?
Yes.
So you have to get a biopsy. Where are you going to get the biopsy from?
The liver. The liver.
Yeah, the huge mass in the liver.
What information do you want on the biopsy? Do you want to give someone else a chance, or first gentleman, you're not said anything since?
Sir, first of all, I'll get a baseline serum chromogranin A levels.
Okay, that proves it. What are the tumor markers? Immunohistochemistry? Is it just chromogranin A?
No, sir. In biopsy, I'll like to know the differentiation level.
Yeah, but the question is, what are the other immunohistochemistry marker besides chromogranin for a neuroendocrine tumor? Some of them might be chromogranin negatives. Synaptophysin. What does that prove to you? It's of neural origin.
Yes.
All right. Then
neuron specific enolase.
No, so these two should be good enough for you.
So in biopsy, I like to know the differentiation level. Along with that, I like to know the grade of the.
How do you know the differentiation?
If there is a gland formation is there, so
is that the way in a neuroendocrine tumor?
No, sir. The differentiation level is seen with the presence of glands.
No. There are two things which you do specifically.
Sir. One is Ki67 and one is mitotic figures.
Excellent. So how would you divide based on mitotic index and Ki67 into G1, G2 and G3?
So well differentiation is graded into G1, G2, G3 in which...
it's well differentiated G1, G2, G3 is?
As per the 2017 guidelines WHO. So it is G1, G2, G3 in which less than 2 mitotic figures and Ki67 less than 3, and after that 3 to 20, 2 to 20 and Ki67 3 to 20, more than 20 for both G3, and then there is poorly differentiated and another is the min answer.
Very good.
How will you manage, let's say if it's confirmed as neuroendocrine tumor with liver mets?
So
grade 2.
Yes, sir. So for grade, it's based upon this CT findings, sir. So it is type
Are
2.
you happy with only a CT for a neuroendocrine?
No, sir.
How is DOTA
Galliums-
better than a CT?
So it will additionally pick up the one. It will tell us about the additional lesions which are not picked up by the routine CT. Secondly, it will also tell us about the somatostatin receptor positivity if it is there in all. And if it is there, then we can apply this as in our therapeutic treatment plan also in form of octreotide or in form of PRRT. And this lesion is, there's a neuroendocrine liver mets, type 2 liver mets are there. One is the predominant and other are multiple lesions and G2 tumor. So for this, for this, one option is the resection of the tumor is one of the option. A resection of the primary tumor along with the lymph nodal resection along with the main primary tumor, the solitary lesion, the largest lesion in the liver, we can tackle it with either the resection or either we can target with the locoregional therapy in form of TACE.
You don't have a multiple choice here. I see you.
Yes.
Yeah. So what is your option, sir's question?
Yes.
Please answer him. What is your option in this patient?
Yes. So because so first I like to after because 70 years old female, so I like to know the physical performance. I'll get the PSA fitness and everything. Then I'll like to consider the resection of the primary tumor along with the regional lymph nodal dissection. And because considering the age, I'll not go for the major hepatectomy. So in this patient, I like to give the locoregional therapy. That will be the best option for this patient.
I would agree.
What do you mean by locoregional?
Locoregional therapy in form of TACE we can give, or hepatic artery just TACE or TARE, both are the options.
So,
and
see, in the exam, when such a case is presented, it is assumed that you are discussing the management of this case, not some other assumed case. In this case, what according to you is the plan of management of the liver lesions? Primary you said you want to do resection lymphadenectomy.
Yes.
That is acceptable.
Yes.
What would you do to the liver secondaries in this particular patient?
Have you seen a lot of TACE for NET in your center?
No, sir.
So there must be a reason why they don't do TACE.
We
What are
don't
the
do TACE for
alternatives?
NET, no?
In this patient,
G2.
One, so put that into your equation as well. There's a reason why you do that.
so the G1 tumors or is
What are all the options? And
all one.
You got a taste for a large neuroendocrine tumor.
What
That's
does the G1 tell you? What does the G1 tell you? What is the prognosis you will tell the patient?
It's a good prognosis, sir.
Good means what?
If
If you do nothing for the liver and you do something for the liver, is there any difference in their survival pattern? Could you avoid their, pulse? Can you feel their pulse itself and tell you? They really need that. That's one thing. Another thing is did you notice he had two things? Why did they do two things? Did the FDG report?
Yeah, they had given Dotanak also.
The PET was FDG and DOTA.
So it
Interpretation from
so in
a whole lot of theory, but you're not applying the same thing in practice.
if for G3, sir, and if it then the FTG avidity will be more as compared to the DOTA avidity, and also we are looking at the Ka60 for G3 tumor. We'll look for the G. dual trace. Because if there's a dual, they okay.
This is one of the few malignancies where bowel net is one of the few malignancies where the primary resection does help you. So there is even prophylactic. Here this symptomatic. So you suddenly were misled by that, and you're not. You were saying lymph node resection and all that. So it's important to actually resect the primary. They get very symptomatic because of the primary. So the liver, they may live a completely 70-year-old may live a completely normal without doing a taste. Probably better without a taste, possibly.
So the treatment of this patient is bowel resection, lymphadenectomy, plus management of the liver lesions. So management of liver lesion with this dual tracer PET, what do you think?
What are all the options? List 1, 2, 3, 4. These are the
At
things
least
I can do.
tell the options at least.
Yes, sir. So one of the option is it is a non-functional tumor, and it's a non-functional tumor, and there is no
The
local.
therapeutic options are A, do nothing.
Yeah.
B,
One is just surveillance.
B.
Secondly is octoptide.
is PRRT.
Long
C,
acting, long acting,
long-acting octoptide.
Yes.
And C is PRRT.
D,
and,
liver-directed therapy.
Yes, sir.
Okay, now please answer, sir, which of these four you choose and why.
For
Yeah.
I'll for this.
When such a question is asked, invasive modalities, costly modalities versus some simple modalities, you should go in that order. So the bare minimum is observation. The next treatment, before you decide on costly treatments for such a lesion in an elderly patient, the bare minimum you can answer is long-acting octoptide and see how she behaves.
But you said it is not active. But you see the second paragraph, the liver lesions are intense GA68 rotate uptake. So that means it's highly active.
Well, what he meant is it is not giving a carcinoid syndrome.
That's okay. It's not giving carcinoma, but it is active. So the Dotanac treatment will work because it will uptake.
Dotanac will work, but for most non-functioning tumors in such an elderly patient, most of us are
I
not
think
advised.
most of the many of the surgeons here who do liver transplants and do liver resections regularly, even in a 70-year-old patient, they would be able to resect that right lobe lesion fairly comfortably, I think. I feel. I would leave it to the rest of.
So the thing is, here is a 75-year-old lady who is presenting with one complaint.
70 or 75?
70.
Ah.
70, I mean, I don't think it makes much of a difference.
No, there is a difference. No, sorry. Between 70 and 75.
We are digressing. We are digressing, please.
No, and she's come just with the complaint of colicky abdominal pain. She's lived with these huge NET meds for a fairly long time. And we've got one of the options is observing. There is a sense in just doing a simple resection, relieving her of the pain, and then deciding what.
We are running a
The consensus generally in NET meetings is that you need to know the rate of progression of the disease in order also to intervene. So for a start, observation and a serial scan, and take care of patients who become symptomatic and who progress. even if they are G1, rather than to across the board apply one therapy or the other for G1. The current knowledge is not set in stone. It's going to evolve. Currently, the data that has emerged so far suggests that G1 patients will have comparable survival to normal population, which means that therapy has to be carefully chosen. You just can't say, let's do this. So that's the question that Dr. Puneet had asked, which you should have asked.
I think before we conclude, I just want to clarify the GIST management. Majority of us surgeons, irrespective of the size, if the GIST appears operable without any involvement of surrounding structures, we choose surgery as the first line of management. If any of the surgeons here disagree, let us know.
Primary, I think you're right. Everybody would agree with that.
Can I close? Any comments to the students?
Thank you. From the audience, any comments? From the faculty?
From the faculty.
Any comments? Or any questions from the students? Also welcome one or two questions. If you have a burning question to ask, you're welcome to ask.
Thank you, sir.
Thank you.
Thank
Sir,
all the
it was a
faculty.
gastric
We'll move on to
carcinoma.
the next section. Request Shashendra, Govind, Kiran, Sagar, Matthew and Sonali to come on. Faculty for this case would be Dr. Rajan Saxena, Dr. Biju, Dr. T. Yadav, Dr. Vikram. Yeah, we can start.
Sir, our patient is Mr. Somadatta, 47-year-old gentleman from manual labor from West Bengal. He presented with pain upper abdomen for 2 months, followed by yellowish discoloration of eyes and urine for the past 1 month. History of present illness: patient was apparently normal 2 months back, and he developed pain right upper abdomen and upper abdomen, which was moderate to severe in intensity, continuous dull aching pain, radiation to which was radiating to back, and there was no association with relation with food intake. Followed by after 1 month of pain, he developed yellowish discoloration of eyes and urine, which was progressive and which was associated with clay-colored stool and pruritus. There was no prodromal symptoms. There was no vomiting, no history of vomiting, hematemesis, melena, no history of any prior pain episodes in the past, prior pain episodes, no history of any fever with chills. There was loss of weight and loss of appetite. But which was not documented.
Excuse me. Can we have the slides running, please, with the presentation? Project the slides also along with the presentation is going on.
These are cases which are examined by the students, so they have to give the history.
Coming to fast history, there are no comorbidities. There was no surgical history. Sorry, for the, I mean, I'm just continuing the presenting complaint. For the same complaint, patient presented to the this hospital, was referred from local hospital to higher center. Later on, he presented to AIG, where he underwent an endoscopic procedure and a percutaneous tube placement. And now the symptoms are coming down. His pain is also coming down, and the jaundice is, I mean, yellowish discoloration is also coming down. Past history, no.
So before you proceed, based on your presenting complaints, what do you think you are dealing with?
Sir, I would be probably dealing with the obstructive jaundice, which is malignant in origin. Since it is associated with pain preceded by the pain preceded the jaundice, can be a carcinoma gallbladder.
You don't have to give your diagnosis. What you are dealing with, you said that most likely to be malignant obstructive jaundice. Now, what questions would you ask? What did you inquire?
We will inquire about.
What did you ask?
Sir, there was no history of any cholangitis. There's no history suggestive of any cholangitis like fever with chills or rigor. There was no history of any vomiting, no hematemesis, no melena, or associated loss of weight and appetite. There was associated loss of weight and appetite. And
in a patient like this, when you were talking about pain for 2 months,
yes, sir,
you did not tell anything about the progress of the pain, except that when the pain started going to the back side, is it since the beginning, or it has changed in the pattern of the pain, change in the character of the pain. So this is very important in a patient where you are talking about starting pain, first thing pain,
yes,
which starts about 2 months back.
Yes, sir.
Then jaundice, you said about 1 month back.
Yes.
So what happened in these 2 months?
The pain is persisting, sir, which was relieved with medications only. And after admission, he is saying pain has come down.
No. As are not.
You understood what Dr. TD told. Huh? You identify the symptom 1, 2, 3,
yes,
mode of onset,
yes, sir,
progression, what stage it is right now. These 4 things has to be very clear after you. And what was the character of the pain?
The pain has dull-liking type, which was moderate to severe intensity, sir.
It's again controversial. Dull pain, how it can be severe? You said there is radiating to back. When pain started, there is a significant correlation when you are saying that pain is now radiating to the back, which was initially, it was since the beginning, or it has started later on in the course of the disease process. This is very important question. When we are talking about pain and jaundice, this is very important to know the pattern of the pain, progression of the pain. I am saying, patient, you said that patient has started with the pain, dull aching. Then you are saying it is severe. Then you are saying it is going to the back. When pain started going to the back, was since beginning pain was going to the back?
It was from the beginning, sir.
So how much painkiller he was requiring?
He was requiring IV analgesic.
Since beginning, day one.
I mean, once the patient presented with pain, that time he
Your
required
history is patient started with the pain. When he started requiring IV analgesic.
So basically what sir is saying is that you need to build up on your whatever you're presenting complaints, you describe it well, which you did to a certain extent, but in a much better manner. So this is pain, then pain was followed by jaundice after this, and he came to a higher center. We'll proceed further. Now, what questions did you ask?
in history, presenting in the
history. On inquiry.
Sir, whether the character of the pain, the character of the jaundice, whether any.
Tell us.
Yes, sir. Sorry. The pain was in the upper abdomen, which was moderate to severe with radiation to back. There was no association with food intake. Followed by he developed jaundice for the after 1 month of development of pain. The jaundice is also progressive for the past 1 month and associated with clay color stool and pruritus.
Come and you use association carefully, okay? When you have a fever and chills in real time,
Okay, do a jaundice patient as a clay colored stool real time? It's not real time association, no? Okay. Dysphagia with pain is a associated pain. When you are swallowing, there is association. Okay, fever, at that time patient has fever and he has chill. It's associated. Okay, but jaundice is not associated. No? So you have to split up that and tell. Use and better.
There was no vomiting, melena, or hematemesis. No history of fever with chills and rigor. There was associated loss of weight and appetite. So for which the patient patient attended local hospital. Later on, he was referred. Where here he underwent an endoscopic procedure and a percutaneous tube placement, followed by the jaundice has come down.
What about the jaundice pattern?
Just progressive.
How you came to know that it was progressive?
Patient was saying actually that that yellowish color was deepening in color day by day.
So that is the only way you can understand that jaundice was progressive. When you are thinking of obstructive jaundice, or there are other ways also by which you can understand that this was progressive.
The color of skin deepening of means after jaundice progresses, the skin also become yellowish.
In a country like ours, in our color, it's very difficult to see that how much it is jaundice is progressing. What are other very important ways?
Other mucosal surfaces like.
So what about pruritus?
Pruritus is there.
How much it is now? How it started and how much it is now?
The pruritus, it was there initially. Now it's not
before
there.
endoscopy. Listen the question,
Yes,
please.
sir.
All these questions are very important. You are talking about pain and jaundice. So if the patient is having pruritus to start with and it is progressing, we say patient is not able to sleep. Whole night he is having some problem. Sometimes it requires urgent palliation. So this is very important question to know about the progression. As I asked about progression of the pain, same way it is important to know about progression of the jaundice, and most important is pruritus. So these are the questions you must ask the patient.
I missed to ask whether it was disturbing the sleep.
Yeah. So that is very important.
Anything else in history?
No.
So I'm really this is that you did not ask any etiological history, because at the end of your history taking, if I were to ask you what is your differential diagnosis, because based on your onset, duration, progress, you said that it is most likely to be an obstructive jaundice, most likely to be malignant. At the end of your history taking, if I were to ask you what is your differential diagnosis or what are the probable causes of malignant obstructive jaundice, what answer would you give? Because you have not asked anything in history as regards to etiology.
Sir,
Isn't it? Got it clearly? The patient with jaundice, what are the questions you ask? If you put your medical gastro mind, what are the questions you will ask in the patient with jaundice? All chronic diseases present once upon a time like this. Okay.
I asked about to establish the diagnosis of polystatic jaundice. I asked about.
Hold on. The question is very clear. Can you come down to an etiological organ specific localization by history alone? And what in the history is going to help you? How will you distinguish between biliary etiology and pancreatic etiology based on the history? You have said nothing about that.
Only pain can be the characteristic.
You could have asked some questions to the patient to get to the clue whether it is biliary in origin or it is pancreatic in origin. What would those questions be?
Character of the pain, sir.
Yeah.
Recent onset.
So what happens to the pain character? So what is difference in the pain when you are thinking about pancreatic pathology producing pain and jaundice, vis-a-vis you are talking about biliary pathology producing pain and jaundice?
Pancreatic pathology, the pain will be, progressive with the with progression of the, with the duration of the illness, sir.
So that would be also in the biliary. What will be difference in the character
it would be constricting type of pain which is radiating to the back.
Okay, tell me what is your differentials at the end of this?
Malignant obstructive jaundice, probably carcinoma gallbladder or a carcinoma head of pancreas.
Why do you say carcinoma gallbladder? Yeah.
The pain, the pain preceded the jaundice, sir. Actually, it's a painful progressive obstructive jaundice, and the pain preceded the jaundice. Sir, that is an against point. Yeah, that's an against point. So that's why I would like to keep the CA head of pancreas also.
So CA head of pancreas because it's radiating to back. Why it is not stone disease?
No, one more simple question, Chetan. How often have you seen carcinoma head of pancreas starting with pain as the first symptom?
No,
then why should you think of that? That's what we are asking you. Have you tried to distinguish the etiology between biliary and pancreatic? The character of pain in a biliary etiology. Most carcinoma gallbladders have associated gallstones.
Yes.
Did you try to get any past history of?
He didn't have any past history. I mentioned, sir. He didn't have any.
What did you mention?
He didn't have any previous history of pain.
Which pain? You have to
categorize it. No,
characterize it. Be very
Any
clear.
past, sir.
Each etiology you have to distinguish and rule out. That is only how you are going to defend your give your differential diagnosis and defend the your diagnosis.
So again, when you are talking about gallbladder cancer and you are saying that because of the back pain, I am just shifting my diagnosis, it's also not correct. That's why I said in the beginning, what is the progression and what is the change in the character. So even in gallbladder cancer, we'll have nodal metastasis in the celiac group, and that can produce. So that's why it's very, very important to know how pain has progressed and how there is a change in the character of the pain. Rather than just putting one thing, then you say, so now what is your first diagnosis?
Carcinoma gallbladder.
Carcinoma gallbladder. Why are you saying that?
Short history of painful obstructive jaundice. The pain preceded the.
So pain has preceded. That is important.
And patient percutaneous drain placement. Percutaneous 1-2 placement can be because it suggestive of proximal obstruction can be, sir.
So endoscopy has been tried.
Yeah.
But it has failed. And there was a percutaneous tube placement.
Yes.
So
that could be true.
Yeah.
That could be true for a hyalocholage carcinoma as well. So why have you nailed gallbladder cancer as the first?
That means you know the case. That is the impression the examiner will
have somebody spiked you.
Hyalocholangiosia, that jaundice pain is typically painless progressive jaundice.
So that is also progressive. Yeah. But can it be painful also when?
It's a large mass. I mean, due to congestive hepatomegaly, there may be dragging pain sensation can be there.
The character of pain will tell you what is the cause.
Due to lymph node metastasis, pain can be there, sir.
The differential diagnosis, the problem happen now why these questions are coming because you have to select your keywords in the diagnosis, okay? And so what are the keywords you should have selected? Obstructive jaundice, malignancy, and the differential reason for it. So otherwise, after 5 minutes, somebody will ask, why can't it be benign disease? So you not explain the obstructive jaundice part at all in the diagnosis, you are never given reasons. Okay, you're not committed that part. You're not committed the malignancy part. So you're directly starting to commit the third part, which is going to carcinoma gallbladder, hilar and all. So the questions which are related to part 1 and part 2 are going to pop up right now. This is what is happening now. Okay, understood, no? So this structured, you select the keywords, try to explain obstructive jaundice, malignancy, and then differential diagnosis of 1, 2, 3. Okay, that's how you should have proceeded.
Okay, go ahead.
Go to examination.
Examination, patient is conscious, cooperative, well oriented to time, place, and person. His vitals are stable, pulse of 80 beats per minute, BP of 130 millimeter mercury, and respiratory rate is normal. There is mild pallor and icterus. no generalized lymphadenopathy, no supraclavicular lymphadenopathy, and no pedal edema. He is moderately built and moderately nourished, and his SGA status of A and ECOG of 1. On systemic examination, coming to per-abdominal examination, on inspection, abdomen is normal in contour, umbilicus is central and inverted. There are no scratch marks on the abdomen, no dilated veins, no scars seen. There is no visible mass. Bilateral hernial orifices are normal. And on inspection, there is a PTBD tube which is noted on the anterior abdominal wall subcostally in the mid-clavicular line. On palpation, there is no local rise of temperature, there is no tenderness, no hepatomegaly, no splenomegaly, no ascites, and GB is not palpable. Bilateral hernial orifices are normal. On percussion, there is a tympanic note and no free fluid. And auscultation, there is normal bowel sounds heard. On PR, it is normal. There is no clay-colored stools and no pelvic deposits felt, and also there is no melena. After systemic examination, on respiratory system, it is normal. There is normal vesicular breath sounds heard. Cardiovascular system is also normal, and no focal neurological deficit.
Your patient age, please.
Sorry, sir, 47-year-old male.
You need not mention anything else in the rectal examination. All that you are interested in only is the deposit.
Prostatomegaly is not there, sir. There is no prostatomegaly.
You should mention that, because that will have bearing on therapeutic part.
Yes.
So how wiser you are at the end of your clinical examination?
So post clinical examination, I know patient is having he's moderately built and nourished.
No. With regards to the differentials, he gave 2-3 differentials. Na?
Yes, sir.
So do you stick by that, or you want to eliminate some, or you want to narrow down your differentials?
So again, I'm thinking in terms of malignant etiology as a cause of obstructive jaundice. Mostly higher up because there has been a PTBD which is done and endoscopy has failed. So mostly a higher level of block, either
that we agreed upon.
Yes.
But he gave differentials. He gave some. So what do you think it would?
So I would like to keep CAGB higher up, CAGB neck, followed by hyla.
CAGB neck.
CAGB, sir, carcinoma of the gallbladder, most probably arising from the neck.
Why?
Because there has been an intervention in the form of PTVD that has been done.
But why CAGB only? It could be hilar cholangiocarcinoma.
Yeah, my second differential would be hyla.
How do you know it is PTBD?
Sorry, sir?
How do you know it is PTBD?
The tube which is there.
So tube with a bile in the upper quadrant can only be PTBD?
No, sir. But the it's a thin tube which is
Thin tube can
How
be
many
only put in the
PTBD? How many PTBD tubes do you have?
once.
One. You still want to reach out to diagnose the hilar block, hilar cholangiocarcinoma. By probability, is it a hilar cholangiocarcinoma or CAGB?
Probability
With subhilar block.
would be CAGB would be the first probability.
And how often do you see a subhilar block in CAGB?
Usually it is at the hilum usually.
So there's something missing here. There's
More
something
so,
wrong.
its gallbladder is not palpable. So if you are making a diagnosis of carcinoma gallbladder and you are deciding without any imaging that it is neck lesion, gallbladder is not palpable.
You would expect a lump.
Yes, sir.
Your tube is not in the gallbladder.
Tube is not in the gallbladder.
So it's inappropriate to say. And second important point.
We don't know whether it is in the gallbladder. Do we know that it is in the gallbladder?
From the position, I can.
Position was told that it is subcostal. You told
Yes,
patient is
subcostal in the
subcostal.
mid-clavicular.
So it's not a normal way that you put a tube in the from the intrahepatic tube from the subcostal, because you said liver is not palpable. You also told that there is a gallbladder is not palpable and there is no scratch mark on the abdomen. So that might be after admission scratch. It's very difficult to accept that patient was having pruritus, whole body and progressive jaundice and no scratch mark, whole body in the general physical examination also. So more so, every time suppose endoscopy fails, there is no other reason for the endoscopy to fail.
Can be because of the
So
difficult.
it cannot be 100% true that suppose because endoscopy was tried. So when you will see a lesion, when you do endoscopy, and when you go straight away for PTBT?
It could be, we don't know, but the whole presumption, because it is a PTBD has been done, that is why it is being presumed that it is a proximal malady. And that is why you are trying to fit in CAGB and second differential as Hyler. There is no lump palpable. So it's basically a presumptive.
Because when you are going for any intervention, you always have some imaging in your hand.
Yes.
You don't go straight away to the intervention.
That's what.
Yeah.
So
that's
basically,
why- yeah.
Exactly. So that is why the whole thing they are presuming that it's a proximal block because they say that it's a PTBD. So that is not right. So that is why again going back history differentials is very important. Okay, now we go on to the next segment, that is how would you take it further? Who's the next person? So now this patient is there. We are not very sure of what it could be. Only we know that it's a malignant obstructive jaundice. So what this patient has come to you now, how do you want to take it further?
I would like to do first routine blood investigation, complete blood picture and liver function.
Please don't tell this. Complete blood picture, routine blood investigation has no meaning in current. You tell what exactly you want to do. There is a form in front of you, tick. Okay. Do you have a form called complete blood picture?
What do you mean by complete blood picture? You just enumerate what investigations you want.
Hemoglobin and platelet count.
Will it help in your diagnosis? What sir was asking, what will you do to do the diagnosis?
To confirm your diagnosis, what investigations you want?
First do
USG abdomen.
What all you want to you expect to see in an ultrasound abdomen in a history like this and examination like this?
I would like to locate the site of obstruction, whether it's proximal or distal, and any free fluid, any lymphadenopathy near the lesion, and any space occluding lesion in the liver.
So basically you want to see where is the site of obstruction, proximal dilatation,
yes.
How is the liver, whether there are any lymph nodes, ascites. That is what you want to see. So let us see. This is the USG finding.
Liver normal in size and counter, parenchymal decotexture normal, and central ISBD, and CSG and CPD are dilated. Gallbladder polycystitis with cholelithiasis with moderate increase in gallbladder wall thickness, and loss of fat plan with the liver. And pancreas is normal in size and counter, parenchymal decotexture is normal, no calculi, no peripancreatic edema or fluids, and no collections. Spleen and rest of the brain normal, no evidence of ascites, no lymph node.
So based on USG, what do you feel it could be?
There is a thickness of GB with loss of fat in the liver, probably CAGB with obstruction at the hilum.
There is actually a lot of fat line with the liver, the gallbladder. You get in normal ultrasound, you get that finding. Fat line with the liver is lost or it is there. Is there any fat line with the liver, gallbladder?
Do you normally get a fat plane?
Yes.
Get a fat plane? And would you have a dilated CBD in the face of a hilar block? Read the ultrasound report very carefully.
ESD and CBD is dilated, not fitting with the gallbladder.
So basically this is not helping you anyway. Though they say there is thickness in gallbladder, it's not fitting because your complete CBD is dilated,
yes,
along with CHD dilatation. So what do you want to do next?
So I think more important is when you were asked a question, what you expect in a gallbladder in a ultrasound, you should start from above. Liver, size, echo pattern, space occupying lesion, ISBR. This is very important. Sometimes we talk about hypertrophy, atrophy, fatality is present. Then you come down, then you talk about gallbladder, any stone, thickness of the gallbladder and dilatation. Then you talk about common bile duct and common hepatic duct. Then you talk about lymph nodes. Then you talk about fluid. Pancreas you left because this was your second differential diagnosis. In your ultrasound you don't see pancreas at all.
Right.
So you can see the pancreas also, and then lymph node, and then free fluid, then spleen, then even vascular, portal vein thrombosis, suppose it is there, you can find it out. So many important information. You are asked a question. Here we are going fast, but in examination, if you say only 3 things in the ultrasound, immediately somebody will ask you, can I see all those things?
there is one point is that the gallbladder thickness is not mentioned as being differential
Yeah,
in different
it's uniform
parts.
thick.
It's uniform.
Uniform
That's
thickness.
important for
Yes.
diagnosis of.
How is the diagnosis based upon this all? With the history and all that at this stage?
Pardon, sorry.
What is
So
the
based on your
diagnosis?
USG findings, what do you think could be your diagnosis?
Carcinoma gallbladder.
Why it is
Why? What in USG tells you that this is CAGP?
No, you are diagnosing carcinoma gallbladder with the obstructive jaundice.
Yes.
So is it fitting to carcinoma gallbladder with obstructive jaundice?
GB thickening will fit, sir, but
Just tell yes or no, then
CSD.
explain.
Just the sir said that GB thickening, to qualify it as malignancy, the pattern of thickness also matters. It is uniformly thick. Here it is uniformly thick.
They didn't mention the uniform.
So that's why you should say that thickening alone you are making your diagnosis just based on thickening.
It could
So
be
thickening can be in chronic cholecystitis, thickening can be in the acute cholecystitis also, thickening can be in xanthogranulomatoous cholecystitis. So all these things, until unless all these important points about the thickening, there are 3-4 points which we will discuss later on. If they are not present, it's a very difficult.
besides
to
this
say-
USG, as Dr. Biju rightly said, what is there to tell you that there is obstructive jaundice? What is the cause of obstruction? Is it telling you?
There is only point
Is
in
it telling
favor of
that this is obstructive jaundice?
IHBD is there, sir.
Okay. But where? Up to what level?
Up to distal CBD.
Okay. So that is why it is obstructive jaundice, correct?
Yes.
So now you tell what is the differential diagnosis based upon.
Based on this,
First, I will put the
What
carcinoma
it is
pancreas.
and what it is not. Both you have to tell.
Carcinoma pancreas with.
So see the pancreas finding. Is it carcinoma pancreas?
But in ultrasound there is a.
You
No,
have to tell now.
they have
Is it?
mentioned normal.
It may miss the lesion.
When they have mentioned normal,
with whatever its
then you cannot
limitation.
say carcinoma pancreas. There is no other features suggesting of carcinoma pancreas. There are other things which can produce lower CBD obstruction also.
Why
So that-
can't you think
this-
of a
this
benign
typical history-
condition in this?
This typical history and this ultrasound finding, forget about all the intervention. What is your straight away diagnosis?
Distal CBD obstruction based on history, probably malignant obstruction. So periampullary is my first
You
problem.
went to the carcinoma gallbladder and they totally diverted the discussion, no?
No, it could still be a, see, there is gallstone.
It could be.
There,
Yeah.
it could
That
be a
is why I
mini-
asked
it
why
could be
it is
mini-
not choledocholithiasis. I'd asked him.
And
Okay,
one
so
more-
what next investigation?
No, just one more point you need
Yes,
to
sir.
remember. This patient is also a person where ERCP failed. The ultrasound report that you have in hand, you must remember in this patient the ultrasound ERCP has already failed. Now you need to review your diagnosis again. What is the likely cause of that?
So would you like to see the earlier ERCP report? That will suggest that why ERCP failed. Did they try to cannulate, cannulation failed? Are they cannulated and something else has happened? Or any investigation which was done before ERCP? That might suggest that why ERCP failed.
Yes, I would like to do previous endoscopy or ERCP.
CRCP we don't have, sir. We have endoscopy.
No, the ERCP, it's important to know, could they not enter the duodenum? Could they not enter the papilla? Did they enter the papilla and go into the bile duct? And then at some level it was blocked, what level it was blocked? These are the things that the ERCP report you must ask for even in a failed ERCP. So each of them will give you a hint.
So they don't, means the patient has lost
Patient
it.
does not-
So he does not see,
Does not know whether it is
does not have the ERCP. So now what next you would do? This USG has not helped you much. So now what next investigation?
I would like to do MRC, please.
Directly? You want to do LFT first?
I would like to do LFT
After MRCP or before
Before MRCP.
Before MRCP. Okay, this is LFT.
Total bill will be 12, sir. Direct is 6.8 and SGOT SGPT is 165, 126, ALP is 761 and albumin 3.6, sir. NR is 1. The right now obstructive type of jaundice with mild elevation of SGOT SGPT, mild phalange. And I would like to do MRC.
So do you have any contribution from this Now what next?
MRCP.
Why you want to do MRCP?
Stop. I would like to locate the cause of obstruction and
Cause of obstruction by MRCP?
site of obstruction.
Site of obstruction already told ultrasound. What information extra? You have seen the ultrasound report.
Yes.
Okay. You tell a very specific information. You are likely to get an MRCP beyond this ultrasound.
I will on site of obstruction and
so you want to confirm that is in the lower end. Be very specific.
Yes.
Don't guess.
Yes.
Ultrasound showed site of obstruction is in the lower end.
Yes.
Correct? You want to confirm by MRCP.
Yes.
Are you sure you are talking correctly? You want to confirm a site of obstruction in the lower end by doing an MRCP.
side wing endoscopy if possible.
Don't keep on jumping. Sir is asking you very specific thing. What is the aim of MRCP? With what objective are you asking for an MRCP? You want to, your answer is what?
I would like to confirm the site of obstruction based on.
You want to confirm the site of obstruction which the USG says that it is most likely to be lower down. That with that objective you want to do an MRCP.
Yes.
So don't jump to side viewing. That means what the examiner will feel that you are not very confident and sure about what you are saying. Okay? Be very firm and very clear.
You are not looking to see the lower end obstruction. You are looking to see if there is going to be any findings to suggest why the lower end is.
What investigation you will choose at this stage? Is it MRCP? What is your worry? You forgot all the history and examination finding. What is your worry? You are now concentrating on the biliary system or something else?
I would like to know the lesion and.
No, don't forget. We are working up a patient with a suspected malignancy. Okay. You are selecting an imaging where you are talking about a technical sort of imaging. Is it that at this stage required?
Yes.
What is required?
Tripasic CT abdomen.
So that is important. When your first diagnosis was carcinoma gallbladder based on the history, and then your second diagnosis was your pancreas. In both the cases, our second important thing to get maximum information is contrast enhanced CT scan.
So you want CT scan first or MRI with MRCP first?
But before that, we always do a chest X-ray also in a patient of suspected carcinoma gallbladder because it's a very aggressive disease. So suppose there is something suggest that there is a metastasis, we don't proceed further other than going for palliation of jaundice. That is also the last case. Also, it was being discussed. So basic investigations are very, very important.
They have already displayed the MRCP. Can you answer the question? Did it help you at this stage?
Can you read it out for us? Yeah.
Yes. There is a bilateral dilatation of intrahepatic biliary radical and CHD and distal CBD, sir. And gallbladder is not visible, sir.
Can you describe the terminal end properly? The terminal end.
There is sudden narrowing of the terminal end.
Smooth.
PD is visible, sir.
So is the tapering smooth?
Yes, sir, smooth. Shouldering.
Yes.
It is outside the wall of the duodenum system. It is not terminal ends.
You have to comment it very scientifically. You have to tell no anatomy.
Yes.
What is the status of the bile duct? Is it dilated? Not. Where is the structure? What is the nature of the structure? Is it a long structure, short structure?
Yes.
Irregular or regular? Pancreatic duct is seen or not seen? Where it is inserted? Abnormal junction is there or not?
Yes.
You have to tell all this. No?
Yes. There is a dilatation of CBD up to the distal supraduodenal part of the CBD, and there is a smooth narrowing of the CBD and small stricture, short stricture, and PD is visible. It is not dilated, sir. No, sir.
You mention about that.
Yes.
And what else?
and bilateral AHBIT is there, hilum is intact.
Something abnormal is little bit abnormality is seen, though it's not totally affecting, but something is seen just after making confluence coming down. So that is also one of the things which is important. More so when you are doing MRI, MRCP, you don't directly do MRCP, you do MRI also. So it is important also to know the MRI pictures and many features suggestive of the whatever your differential diagnosis are there. This can be seen in the MR picture rather than you see the. You should not ask. Some investigation has been done. Suppose that is not the first investigation and you are describing, then you could say that I would like to see the MRI picture. If it is CMRI, if it is has been done, then I would like many things can be seen in the gallbladder also.
Yes.
Making the first diagnosis carcinoma gallbladder, second carcinoma pancreas, multiple things can be seen other than only MRCP. You could see.
Now can you read out this MRI? So basically you ask for MRI with MRCP. So what does you?
On the reconstructed images, did you notice one thing? That there is a big gap between the lower end of CBD visible and the pancreatic duct.
Can you show the cross section?
You notice this?
Pardon?
The difference between the lower visible end of CBD and the pancreatic duct. Yeah.
There is a gap between the site of obstruction and the pancreatic duct.
So what does it tell you?
Picture site of obstruction, C8 of pancreas.
Picture at C8 of pancreas.
Yes. PDC, pancreas. Distal CBD growth, distal CBD.
You are not interested in that. And what else is normally visible here? There's some more finding.
Hmm.
You notice some filling defects above that.
In this image, there is no filling
in this area. Better seen here.
That was what I was trying to say. And the left duct is unusually longer, much longer than what is it expected. So that also gives some indirect evidence that something is happening on the right side of the liver. And you are seeing that there is a abnormal confluence. So when you are describing, you are not even thinking that there is abnormal. So you could go in a sequence wise. We are not just looking. Can you make a diagnosis? You are looking at how can you read the MRI scan also. So CMRI picture, can you show the CMRI picture? I was suggesting that if you see the CMRI picture, go down please, next CEC. Yeah, CMRI.
Does it show anything more?
Can we go down to CMRI? Yeah. So these pictures. Yeah.
There is a mass lesion in the GB fossa, sir, with the irregular fat planes, irregularity over the mass. And
is it better than only MRC? So many things are seen in the gallbladder. Are you able to see multiple? Can you now describe that what is happening?
Thickening of the gallbladder with local fat standing, sir. And
what about the thickness of the gallbladder? What about the lumen?
Lumen is compromised, sir. Lumen is feasible, but is compromised.
So why it is compromised? Because gallbladder wall is so much thickened.
Yes.
So you can measure the thickening also. And what about enhancement?
It is a enhancing, sir.
What is your diagnosis now?
You select from your differential diagnosis and tell the diagnosis.
Carcinoma gallbladder.
How will you explain all?
Could not explain obstructive jaundice, but because of distal CVD
This
also
MRI with MRCP is suggestive of carcinoma of gallbladder with
This area which is present here in this picture. So it is just left and right, this joining. Just below this you are finding.
So what is definite? There is a mass in the gallbladder.
Yes, sir.
So between three and all that, what is it? Carcinoma?
Yes, sir.
You are unable to explain the obstructive jaundice?
Yes.
That's what sir is telling. What is the point?
It is a narrowing with the mid CVD, just below the hile.
So my question would be, do you think only direct encroachment or encasement of the common bile duct or compression from the neck is the cause for the carcinoma gallbladder with obstructive jaundice, or there are other causes of the obstructive jaundice in a carcinoma gallbladder? You are saying no, I am not able to explain that.
Lymph nodes, hilar lymph nodes.
Nodal, not only hilar you are not saying.
Nodal mets at the SDL. Pericoidocal lymph nodes.
Pericoidocal lymph nodes or other lymph nodes, only pericoidocal. So you have read the lymphatic drainage of the gallbladder.
Retropancreatic lymph nodes.
The retropancreatic lymph node is huge. Any other?
Hold on. In this situation, would you ever consider retropancreatic node? Look at it very carefully. I gave you a clue that there is a sizable gap between the pancreatic duct and the plane of the block. So would a retrocoilodocal node, a retropancreatic node, do such a thing?
Unlike, I'm not sure.
What is the cause here?
Near mid CVD there is a narrowing, there is a compression.
Compression is there, all right. What is the cause of that compression?
that is you just said. What is the cause of compression? You said it.
Lymph node mass.
And then where is the primary?
Gallbladder. Gallbladder. Carcinoma.
So basically, if you have to explain, you would say that this is most likely to be a CAGP with lymph node compressing, giving rise to the dilatation of this. Okay, now what next do you want to do for this patient? Would you want CT scan or you are happy with this to plan your further management?
I want to see type A CT abdomen.
You want CT scan? Why? What else do you want to know? With what objective do you want to do a CT scan?
Stop. If the radiologist is available, so I would like to discuss a tricytic MRI, sir. So there is no need of CT abdomen.
Radiologist is available. Why radiologist should not be available? You have
Vascular invasion.
So you want to know the whether the
invasion.
resectability for assessing the resectability. You want to know that is why you want to do a CT scan because based on this MRI you cannot make it out.
Yes.
Okay. Since MRI is already done, what will be the best investigation next? Is it CT?
Is it CT scan or something else?
The MRI is already done. You wanted to do an MRI. We told the CT is the first one. Now the MRI is already done.
Yes.
You have. Now will you again stick on to CT or something else?
PET CTs.
So it's better to say that I will do a PET CT scan because we know that gallbladder cancer is very aggressive disease, and if we want to rule out the metastasis, which are usually not picked up in contaminant CT scan, and that CT scan also had all the cuts, only vascular problem, vascular, when you are planning a vascular resection, which usually in CA gallbladder people don't do it. Then you plan good contaminant CT scan. Otherwise, PET scan, and PET scan also had CT scan. So everything you can see in the PET scan in one go. And what are the things you will find extra? What are the things you are looking at which are present on PET scan, which might be missed on
distal meds,
Which distal meds? It's not a.
peritoneal meds and
What are the? Have you seen the pattern of the metastasis in gallbladder cancer? So what are the 1, 2, 3, 4? These are the areas where PET scan and CT scan or PET and CT scan and MR might not pick up, but I will be able to see them. What are those important areas?
Instead of CT, after PET CT. Okay, you be very specific to the question. What are the things you are going to get apart from MR and MRC in a PET CT in this patient?
distal meds.
Where? Distant where? Sir is asking name the sites. One, first.
Start from
Liver
primary.
meds.
Primary, will it show anything?
Yes,
In PET CT?
uptake in the primaries. And
Taken?
primary and lymph node
May.
metastasis.
It may.
Yes.
But if it is positive, then it's diagnosed. Next. It can show activity in gallbladder, correct?
Yes.
It may show. Next, what it will show?
Metastasis in the liver.
Where
Both
They
lobes
made
of
the
the liver.
question. They made the question very clear. What is it that you may not see on an MRI
No, other
or a CT scan,
Sir, other
but will
person-
show up on the PET CT?
You want to answer the next person?
No, that there are two people have not.
Who have not? These two have not answered, no?
You tell us.
Sir, in PET scan highlighted for in intracaval nodal mets.
So
Any
I want to
activity?
equal group of lymph nodes are better picked up than the CT
No,
scan.
no, sir.
Next.
If there's activity in there, it could indicate.
Okay, one.
That is
Second,
one.
Second, any distant lung or any other mets, sir, lung mets or bone mets.
Lung metastasis.
Lung
Third.
mets. Third, sir.
1, 2, 3. Go on telling. What? Any other?
Third, sir. Any other distant brain?
What about supraclavicular group of lymph?
Okay, brain and supraclavicular. Any other distant
So
mets, sir?
third, fourth.
Third, sir.
What about peritoneal dissemination?
Yes, sir.
Is it better picked up?
No, sir. Peritoneal mets are not well picked up in PET, but a large omental caking.
Better than, but there are multiple times it is better picked up than the CT scan. What about bony? Bony metastasis.
Bony mets and lung mets. Yes.
So these are the important areas. One is lymph nodes in the autocoil area, even celiac group of lymph nodes. If you see the activity, if you see the compare with the gallbladder, and then you see the supraclavicular group of lymph nodes, then you see mediastinal lymph nodes and lung metastasis and even peritoneal mets. Though if you compare to staging lab, it will be inferior, but it is better than the CT.
so anyway, they have got a CCT scan done.
Yeah.
Can you read it for us? Yeah.
Yes, it's a CCT arterial phase.
Go slow little bit. There.
There's a hypo enhancing lesion in the heterogeneous enhancing lesion in the gallbladder, which is engaging the right hepatic artery. That vascular lesion I would like to see once more.
What else?
And there is a percutaneous tube I could see, which is coming down into the CBD.
Could not see a lesion close to the aorta.
Like to see.
Okay, we are waiting for the portal venous page, okay?
Can you guys go up? The right portal vein, just after the bifurcation, it seems to be involved by the tumor mass, sir. Then
Well, it involved, it seems to be okay, maybe little bit of this thing anterior, just good, one uppercut, please. Yeah. Come down, please.
You are looking for it or just an accidental finding here?
No,
What was there in the MRCP?
Based on your MRCP findings, do you anticipate or do you expect it to?
Yes, sir. Because there's a mass that is involved in the there's a lymph node mass that is involved in the CBD. So the right pedicle will be close near the GB. So
What was the finding? Dr. TD that time gave a hint. No, what was the
He
finding in
told something.
MRCP which predicts this?
He told something where you would expect this to happen. He made a statement on MRCP that something is unusual.
Right side ducts were crowded, left side ducts were very long.
Long and prominent, and that is why you would expect this to see this.
Yes, sir.
What is the diagnosis?
Go a little bit more down.
Diagnosis will be CA gallbladder with involvement of the locally advanced CA gallbladder involvement of the right.
Involving what? Do you think the overall scenario?
Yes.
You have a carcinoma gallbladder here? Malignancy, obstructive jaundice, carcinoma gallbladder was his diagnosis.
Yes, sir.
He explained the entire scenario, including level of bile duct obstruction, okay, as well as the nature of the lesion in the gallbladder, as well as the atrophy, epitrophy. Okay.
Okay.
All this you explain.
Yes, sir.
With your diagnosis.
Yes. So there's a carcinoma gallbladder which is involving the lymph nodal, peritoneal lymph nodes which are causing a mid-level CBD obstruction, and the right portal pedicle, the right pedicle is involved, causing the right lobe atrophy.
Where is the right pedicle? Right portal vein, both anterior posterior are involved here.
No, the right posterior.
So why? Then you explain this scenario. No, what can happen?
Right portal pedicle was okay, right anterior was looking little bit, but right portal pedicle was not involved. Right, yeah, that's why I told you that right portal vein seems to be okay. Right anterior is only at one point it is looking this thing. Posterior is okay. You can see the posterior coming down properly.
Okay. Very good. Yeah, I was.
Yeah.
Stop.
Don't try to fit into. So based on their CT, what do you think it is?
You have not seen the lymph node. Lymph node is coming, it will have to go to a what to call group of lymph nodes. You have to come down and see the lymph nodes, see the other vessels.
Yes.
So, and there was a plane between the abdominal wall, was not looking very good. Then involvement of duodenum, hepatic flexor, all these points are very important when you are talking about gallbladder cancer, because of its proximity with all these organs and aggression of the tumor.
So what is your diagnosis? We'll ask the second person. He's not answered now. So what is your diagnosis now? Forget this.
Looks like a locally advanced PA gallbladder with the involvement of
loudly
with the involvement of more than 2 organs based on the CT, as well as local lymph node involvement.
So what do you want to do? What is your plan?
I would like to take
loudly.
Yes, sir. I would like to get a CA99 level and see what is the level.
How does it help at this stage? What is your purpose of getting the CA99?
Not for the diagnosis, but for just if the levels are more than 100, then I would get an.
Still you are thinking of benign pathology.
Hold on. Without knowing the levels of CA99 and with this imaging in your hand, what do you think is the resectability?
Not.
See, I asked you a very specific question. Based on this diagnosis, what is your plan? What do you want to do for this patient? I agree that you would get a CA99, but before that you tell us what are you planning for this patient? What is your plan?
Plan is to preoperatively, plan is to decrease the.
That has been done. PTBD has been done.
Yeah, still the LFT is around.
PTBD has been done. It is draining well.
That LFT
to
might
go
have
for-
been before PTBT.
450 ml of bile is being drained every day. What else?
Considering it's an advanced disease. we
Yeah, what do you
have
want to do?
Go for a chemotherapy ahead.
Chemotherapy in palliative setting, or you want to give it as a neoadjuvant? What is your plan?
Chemotherapy as a neoadjuvant.
As a neoadjuvant.
So assess for
So CT scan had been done at this stage, seeing all the things. You do want to have a PET scan, or you think you have read some reports of PET scan useful in gallbladder cancer, especially in this setting, or you can straight away go to chemotherapy.
PET is needed, sir. PET CT is needed. To know
Be
the
clear,
extent.
please.
PET CT is needed before considering any management options. C for other.
So that we have
dissemination.
already discussed. So definitely we will do a PET scan, especially in this patient where everything is you have seen what is the local extent of the disease process.
So assume that PET CT has been done now and it shows the same findings.
Same findings, then it becomes a
Chetan,
neoadjuvant.
Yes, they were pointing out that the portal vein was involved. I was talking with Sadiq. I felt the portal vein was normal. They're actually written that as normal.
Yes, yeah.
No, portal vein was
Portal
not
vein was not
involved.
Look at
Yeah.
it. Anterior component was little bit dissing in one cut. Otherwise, portal vein was looking okay.
So now what is your plan? PET CT has been done.
Then it becomes a locally advanced disease. Then neoadjuvant CT would be an option after preoperative drainage has been done.
Do you want to give a chemotherapy neoadjuvant setting?
On a neoadjuvant setting.
So are you sure that PET scan same finding, patient is resectable and you will go for neoadjuvant, or something else can be done and which will define whether you are going for neoadjuvant or you are going for palliative chemotherapy?
Diagnostic laparoscopy, retrocable or retropancreatic lymph node assessment, then go ahead with the plan.
So staging
accordingly.
laparoscopy
Staging
is
lap.
very important when you are planning even for the neoadjuvant therapy
Yeah, sure.
because then here at this stage you decide that whether you are going to have a neoadjuvant therapy or really you are going to have what percent of people will have peritoneal or surface metastasis when PET scan is normal. You have read staging lab reports.
You're not clear about management.
Yeah.
You want to do a diagnostic laparoscopy and finish it there.
No, sir. Staging laparoscopy, assessment of the retropancreatic and retrocable lymph nodes.
Then if it is negative,
If it is negative, then also I'll plan for the chemotherapy since 2-3
so
organs.
you are
are-
doing a staging laparoscopy. That is done like that in carcinoma gallbladder.
If either way your decision is going to be the same, that you take the patient to neoadjuvant therapy, then why do you want diagnostic?
Before a neoadjuvant, at least to have a
It is not going to make a material difference to your decision. That's why that's what
tissue
you said.
biopsy.
Either way you will give neoadjuvant therapy. What do you want to do?
You already decided surgery. You are not you are not committed about what is the actual management. This is a
Tissue.
jaundice patient at this stage on PTBD, carcinoma gallbladder. And what are you going to do next? You are not committed still. Are you going to do resection? You told no. Then you are talking about neoadjuvant therapy.
So before that, I need to have tissue biopsy considering to go which direction. So for that, in case staging
So
laparoscopy.
what
might
makes
be-
this patient inoperable at this stage?
There is no vascular involvement. I mean,
What makes you tell inoperable?
He is not negative. He is asking you any findings that suggest that the patient is prima facie.
multiple organs involvement, duodenum, hepatic flexure, and CBD, which involves multiple resections.
Those
That might
findings makes it inoperable?
not inoperable.
No, if you make it, let us say, in any criteria which makes it inoperable, is there any point in making it a neoadjuvant therapy and operate?
No, sir. Right now,
You are not committed still. Still, you are not committed. So, what is your plan? Are you going to operate this patient or not?
The patient and patient's relatives are with you. They want to know what are you going to do next. If you say chemotherapy, they are asking you, do you after post chemotherapy, are you planning to operate? Means are you going to give it in neoadjuvant setting or are you going to give it in a palliative setting? If you are going to give it in neoadjuvant setting, what are you going to do? What are the chances of it getting operable?
Sir, I would like to explain to the patient bystanders that I would be doing a staging laparoscopy, send a frozen from the lymph node biopsy, and see whether the CT findings are correlating with the.
Excuse me, if you're going to do a diagnostic laparoscopy, which node do you want to biopsy?
Retropancreatic.
So you want to do the retropancreatic or the interaortocaval lymph node? You can see on the CT report that D1, D2 is already infiltrated.
Yeah.
For you to do a cauterization,
So basically,
it's very difficult.
this is most likely to be an inoperable case. So I would like to give, because the patient is young, a chemotherapy in palliative setting. Prior to that, I would want to get a tissue diagnosis.
And it will be better if you can do US guided biopsy.
Okay.
Because of the settlings and all those things. And then make a diagnosis. And then if you want to do CA99, you can do it to monitor the response of chemotherapy.
Right.
Now, upper GI scopy.
Yes, Dr. Sadiq wants to make a point here.
Actually, I'm a little disappointed the way the things are going. You see a large gallbladder lesion, which is involving, if you read the CT report, other organs. You know, what we expect at this stage from people doing GI surgery, that this is advanced, locally advanced, perhaps inoperable, and poor prognosis gallbladder cancer. This is what you should at least be coming out with. Rather than thinking about staging lab, some centers like Dr. Biju may do extended resection and things like that. But what we want to know is, looking at this scan, you have come to a diagnosis, you've come to make a assessment that it is locally advanced with multiple organs involvement. The likelihood of this patient going for any definitive curative surgery is very, very unlikely. And you have to start making plans for a palliative treatment approach for this patient. The RCP which was projected, after so much of discussion, you came to realize that there is a mid-CPD block which was staring at you. And we didn't want to look at it. We were looking at lower end, looking everywhere else, but the staring finding was being missed. Similarly, you are talking of neoadjuvant therapy, and prior to that, you should have a biopsy. And that suddenly, after much afterthought, somebody said, I also need to do a biopsy. So this approach, you have to have clarity in this. You know, this is exactly what we want to get people to start thinking about. Assess the lesion, come to an assessment in terms of what the next plan of action would be, and go stepwise in getting to that goal, what you have established by the.
So I think Dr. Sadiq has summed up very well. So we move on to the next case capsule. Yeah. But I think history should have also been better, and the interpretation of imaging. And at this stage, you have to be very clear and precise. Yeah, this is inoperable CAGB. I would be doing this. Prior to that, I require a tissue diagnosis.
Let me make one more comment here for the examinees here. If a patient comes to you, it is not a must that I will definitely do something for the patient regardless. There are patients who are untouchable. There are patients where if you touch, you will make them worse than what they have already come with. You have to have that fine sense of discrimination. How far do you want to play the ball? Beyond the field. There's no ball, no ground to play. Now 9.9 out of 10, this patient of carcinoma gallbladder, by the experience that we have accrued here, is going to be far from being resected. And your entire focus is concentrating only on resecting this patient, anyhow in which. That is not a correct. As a competent surgeon, you need to draw a line. I will go this far and no further. And you seem to be unaware of that. You are hell bent on resecting it by neoadjuvant therapy. You were always ignoring the finding that ERCP failed. And then also you were considering your clinical decision one after the other. You are not trying to correlate the two things. What is being shown on MRCP? What is the history giving you out? You have to put everything in one perspective. And then realize, are you going to do something worthwhile for this patient? Or simply keep money by keeping the patient gone? It is very poor palliation policy if the patient spends the rest of the time of his life in the hospital after having a diagnosis. Never practice.
Okay. Case capsule here.
Case capsule.
So what Dr. Sir is saying is that as a part of palliation, this PTBD should be internalized at a later date. So you should put in this case capsule here. So you start with this side. Govind.
Patient is a 37-year-old female, a resident of Andhra Pradesh, who is a homemaker, came with chief complaints of recurrent episodes of fever with jaundice for the past 10 to 11 years. The patient gives a history of recurrent episodes of fever associated with chills since 10 to 11 years. Fever is associated with dull right upper quadrant pain, and jaundice, which lasts for 10 to 12 days, occurs every 5 to 6 months. Initially, the symptoms subside with medications which she used to get from a local hospital. Later, she underwent endoscopic intervention every 3 to 4 months and during the episodes of the fever. After 2 years of endoscopic intervention, patient underwent abdominal surgery, following which she was asymptomatic for 6 to 7 months and later developed recurrent episodes of fever and recurrent symptoms again. She has been on endoscopic managed till now. No history of altered bowel habits, no history of abdominal distension or dyspepsia, no history of loss of weight and loss of appetite. Past history: patient had history of blood in the vomitus at the age of 13 years, for which she underwent endoscopic intervention twice at the age of 13 and 18. And the post-abdominal surgery, she never had any episode of hematemesis. She is a known case of hypothyroidism on thyroxine 125 micrograms. She is not a known case of diabetes mellitus, hypertension, and coronary artery disease. So coming to personal history, her sleep and appetite are normal, bladder and bowel habits are normal, she consumes mixed diet, and family history is not contributory.
So going quickly, what is your diagnosis?
So I think that at the age of 13 years, she had some hematemesis, which was probably non-cirrhotic portal hypertension, for which they have done some surgery.
So what is your diagnosis in this patient?
Symptomatic portal biliopathy, sir, maybe.
So it is a portal patient in the case of portal biliopathy.
Yes.
And
non-cirrhotic portal hypertension, for which some surgery has been done. And
so what do you think, which surgery must have been done?
Hold on. Hold on.
Yeah.
What makes you think this is non-cirrhotic portal hypertension? Which is the pointer towards that in whatever history you have presented. How do you make that diagnosis non-cirrhotic portal hypertension?
There are 13 years of presentation with just hematemesis, for which she was on endoscopic.
Is cirrhosis forbidden at 13 years?
No, sir. But after that, she has not shown. She has been well. The cirrhosis. She has been well preserved after that, and there are no other features of cirrhosis, persistent cirrhosis. I mean, she seemed to be well till this portal biliopathy.
How many years does diagnosis is she living now? What is her age?
At 27 years.
She's 37 years. It's almost 24 years.
Yes, 24.
Diagnosis. It's impossible for a cirrhotic to live that long.
I mean, it would worsen. There would be decompensations.
Yes or no?
It is possible, sir, but no, I don't know. I think it's not. It would be very unlikely, sir, because cirrhotic patient would have a. I would like to correct myself, sir. Cirrhotic patient would have recurrent decompensations and would not be presenting like
the
this.
whole issue is all cirrhotics decompensate. They don't.
No, sir.
So patients with alcoholic cirrhosis, leaders who have stopped alcohol and they've lived for 30 years after that without a single intervention. No decompensation, and then they come back with HCC.
So
all kinds of combinations are known. So don't draw a line. No, it's not possible. And you commit yourself to a diagnosis by saying this is non-cirrhotic portal hypertension. Very likely. But then there are other exceptions also. Portal hypertension, yes. You stay here, portal hypertension, portal biliopathy, you are doing fine. The moment you commit non-cirrhotic portal hypertension, you have put your foot in the mouth.
One more important point you missed is that she tolerated the surgery well.
Yes.
So in support of your point, you can say that patient was operated and she has tolerated the surgery. That surgery well, there is no any point in the history suggesting that she had any type of problems after the surgery. So that will support your thinking about maybe it is more points give to you to say that this is probably non-cirrhotic portal hypertension.
Yes. Okay. So moving ahead. Next, what do you think which surgery must have been performed?
So most probably she has undergone a shunt surgery.
With what
With
objective?
or without splenectomy.
What is with or without splenectomy? What shunt surgery must have been performed?
Most probably should have undergone a proximal splenorectomy.
So proximal spleen with it's with splenectomy. So basically, most probably she has undergone a PSRS surgery. What was the aim of the surgery?
Patient had recurrent episodes of hematemesis. So it was the aim of the surgery was to take care of the upper GI bleed,
Upper GI
of the
bleed.
esophageal varices which were there.
That was the aim of doing the surgery. She never had hematemesis. She only had intermittent jaundice.
She was
She
being
had-
treated on endoscopy
She
multiple times.
post-abdominal, she never had hematemesis. Prior to that also, okay. So was that the primary aim?
I think you did not listen that there was a history of bleeding.
That's what I.
But
Okay.
there was history of bleeding, but
So-
not for that purpose endoscopy was being done. You see the other points that
So
was
basically, okay, to take care of hematemesis and what else?
There's no history suggesting hypersplenism. I'm not sure.
What else? What else was the aim of surgery? One is to take care of the hematemesis part, okay. Second,
Any growth, if there was any shunting of the growth in 13-year-old.
she's 37 years now. Now she's 37 years, na?
You're talking about the first surgery which was done, sir, at the age
No,
of.
no, no. See, very clear question.
Yes.
Why she was operated? She had a history of bleeding. That
Yes, sir.
gives you a clue that she had probably portal hypertension.
Yes.
Otherwise, whole history would have been different. After that, she was having problem of jaundice and recurrent jaundice and fever. For that, endoscopy was being done.
Yes.
So why the endoscopy was being done for recurrent jaundice and fever?
They would most probably suggestive of cholangitis secondary to portal biliopathy.
That was the reason it was being done. There might be stone formation also.
Yes.
So that's why that was the reason why repeated endoscopy was done, and that was the reason to take care of recurrence of the same problem. Probably shunt surgery was done. And why did you say that without splenectomy? Just for the curiosity purpose, I want to know.
Sir, actually, I was talking about the surgery which she underwent at the age of 13.
Can I come in here? There's something more about this surgery. Look at the history carefully. She was fine for 6 to 7 months after surgery, and then she developed jaundice. This is an unlikely behavior. So it's quite likely that she underwent a devascularization procedure with splenectomy. That's why the portal biliopathy continued to progress. You had not lowered the portal pressure. Okay, and she must have had before the surgery some pointers that there's something wrong with the biliary tree, some sludge is forming or something is there. It doesn't form in such a short period of time.
Because post shunt surgery, do you expect the portal biliopathy to develop?
In case of any shunt thrombosis,
Unlikely. So what sir says is that maybe at that particular age she must have undergone devascularization surgery, and now she's manifesting with portal biliopathy.
For patients with portal hypertension who underwent a surgery at childhood, what is the commonest surgery history you get? Is it splenectomy, devascularization, or shunt surgery?
usually it is splenectomy with shunt surgery.
Shunt. Get like that? No, significant
Spleen.
proportion comes with a history of splenectomy only. Okay, what the sir was okay, what is the indication at that time? What would have been the indication for surgery at that time?
Hypersplenism would have been the indication. She had 2 episodes of hematemesis.
Will the presence of scar, type of scar, determine the surgery done? What type of surgery would have been done? Next person. Had it been a shunt surgery, what would be the incision be?
Subcostal, left subcostal. Makuchi incision, left Makuchi incision.
And if DVASC?
Subcostal incision.
Upper midline or
yes,
this. So that will also tell you what surgery must have been performed.
Yes.
We go ahead.
Yeah, sir. Please.
Coming to general physical examination, patient is conscious, cooperative and well oriented, moderately built and nourished, ECOG performance status of 0, breath holding time of 35 seconds, BMI of 19.7, and pulse rate is 78 per minute, BP is 110/70, and the respiratory rate is
Okay, you
18
just
per
tell the
minute.
positive finding. We are all reading it. Just tell the positive.
Coming to systemic examination, abdomen is scaphoid, umbilicus central inverted, and L-shaped incision on the left side, healed by primary intention. And liver and spleen are not palpable, no other palpable lumps.
L-shaped. So shunt. Yeah.
Terminology be very clear. Is there anything called reverse Makuchi incision? You told like that, no?
Sir?
Left Makuchi something you told, no? Is there any incision like that? Left Makuchi. Yeah. Next slide.
No other positive findings. So liver and spleen are not palpable. Liver span is 15 centimeters.
Next slide.
Other system examination, normal.
Next slide. What you want?
So now what is the problem at the hand? Next person.
Now the stricture is become permanent and it's causing recurrent cholangitis symptoms. That's why she's having fever and jaundice. And we have to already shunts have been performed and collaterals will be decreased. Now we have to reassess whether there is periodical.
How do you know shunt has been done? How do you know?
Because of the history of the previous.
Yeah?
Previous surgery history. Shunt
Most likely,
most
or
likely.
may have
So
been.
what you want to do was the question. No, this.
So now what do you want to do? What is your plan? This patient has come to you. She's got recurrent episodes of jaundice. She has undergone surgery at the age of 13, most likely to be shunt. That is what you feel. So what do you want to do? How will you assess her?
Now I want to image her, see CT abdomen, look for the status of the pathology over there.
What pathology?
Shunts are there. Shunts is working well. Collaterals are there
No,
or
no,
not.
wait. What
See
you
the
what you
CBD.
want to do is you want to do imaging. Okay. All these are part of liver disease, no? Liver portal hypertension.
Liver and
Okay. So your first investigation, a patient with liver and portal hypertension affected area is CT scan. That's what you want to do first. Any patient coming with a history of portal hypertension, your first investigation is CT scan. What do you want to do?
In terms of imaging,
PPT.
ultrasound.
Ultrasound. Why?
Plain ultrasound or something more?
Doppler, ultrasound Doppler.
You want to get a Doppler USG done.
Doppler USG.
What information do you want to obtain on our Doppler USG?
We can see the first to delineate. We can see the CBD where the obstruction is. What might be the level of obstruction?
No,
as
again,
well as
no. See,
collaterals.
this is wrong approach. Portal hypertension patient, you want an ultrasound. Okay. What are the things you want to do first? You are looking at the CBD first.
No, sir. Portal flow.
You have done an ultrasound yourself, or go and see ultrasound. What is first done? You put the probe there. What is the first thing examined in the case of portal hypertension?
To see for the liver whether cirrhotic.
No. We are talking of Doppler USG. The first thing you do in a patient of portal hypertension, which will tell you, yes, this is portal hypertension.
The reversal of the portal vein.
No. You have to see. You have to see ascites. You have to see liver. Existence of portal hypertension by seeing other thing, collateral. Last only you come to CBD, no? You see the ultrasound whether it is done, all these things. Okay. Why it is important? Why it is important? All these problems can be predisposing for cirrhosis. The patient can have cirrhosis right now. May have.
Liver measures 18 centimeter, enlarged in size, and shows mild coarse ecotexture, no focal parenchymal lesion. Noted, marked bilobar IHBRD with echogenic sludge and calculi noted in the biliary radicals. Portal vein, chronic thrombus of the main portal vein with partial recanalization, patchy flow and few periportal collaterals, splenorenal shunt.
Okay, no need to read. So what has happened? What has happened here?
The shunt has been
The shunt has got blocked. There are collaterals reformed. So now, and there is a stent in place with multiple calculi. So now, how will you manage this patient? Next person. What will you do next? What is the diagnosis now?
In case of EHE, extrahepatic.
Coarse ectotoxis of the liver.
Yes, sir. Extrahepatic portal vein obstruction with
Loudly.
Tachosport proximal splenorenal
No,
shunt.
you're not answering the question. Liver is enlarged in size and shows mild coarse ectotoxin. Is the diagnostic of EHPO?
Patient
You
might
have to
have
tell it.
patient might have because of recurrent episodes of chronic long-standing obstructive jaundice and recurrent episodes of cholangiosis. He might have developed secondary biliary cirrhosis also.
You tell the complete diagnosis. No, first you diagnose, then go to your biliary system. Okay.
Yes.
First, what is the diagnosis?
Extrahepatic portal vein obstruction.
Complete diagnosis.
With symptomatic with status post proximal splenorenal shunt with shunt thrombus.
No.
Chronic thrombus of the main.
No.
That's it. Not the finding of a cavernomatous transformation of the portal vein.
Is it the finding what you get? Chronic thrombus in portal vein in ESPO in a 13-year-old child. A child who presented at 13 years with hematemesis, you assume that it is ESPO and this is the ultrasound finding you get. Rethink and tell. That's what sir was asking, no? And with a coarse ectotoxin.
And you see that the other next important few periportal collaterals. Is that a finding of cavernomatous transformation?
Can be. What will you usually get? Cavernoма formation now.
You get multiple collaterals on the gallbladder wall. You'll get the gallbladder wall will show collateral that is not seen here, and there'll be multiple collaterals, and you will never see the main portal vein in a cavernomatous transformation. That is the first finding. The first finding that you're seeing the main portal vein with the thrombus and partial decantation rules out a cavernomatous transformation. This is probably the shunt thrombose, and the thrombose is extended into the portal vein. What is the finding?
So put everything in proper perspective and tell the diagnosis.
No, there could be another explanation for this portal vein anatomy here that you're seeing now. If he has had multiple episodes of stent exchanges and cholangitis, the portal vein can give you similar behavior. Right? It is not necessary for thrombus to creep up. If thrombus would creep up, you would also see thrombus of the splenic vein and submitted. One of the two things. So that has not been mentioned here. So the assumption is that she has had multiple endoscopic procedures and the portal vein can undergo these changes after multiple endoscopic sections and particularly multiple episodes of polyps.
Okay, so now what? Basically, otherwise you would have asked a radiologist whether it's hepatopecal or hepatofugal, and that would also would tell you what is the etiology of this. Now, how do you want to manage this patient quickly? Last. How will you manage this patient? This patient has come to you. Shunt is blocked.
Sir, I would like to do
And
a CT scan. Shuntable veins are there.
CT angiography. You will do a CT protovenogram. Okay, you will do that. Okay, and they no shuntable vessels.
Now, why not upper GI endoscopy? That will show whether what is happening to the.
What are you trying to treat? We're not clear. What are you trying to treat?
Now we are trying to treat.
No, with a patient with coarse ectotoxis of the liver with a portal vein thrombosis. Okay, it's not what you see in ESP. What are you trying to treat by trying to look at the possibility of shunt? What are you trying to treat?
Now we are trying to.
So there is a biliary stricture.
What is the problem at hand? Biliary stricture.
Biliary stricture.
So what do you want to do?
Endotherapy, sir. I will
So
manage
biliary stricture is due to what? This biliary structure in this patient with this Doppler finding of thrombus with few collaterals at the hilum is due to what?
It is due to.
So your shunt surgery, you think this will tackle the biliary structure with this ultrasound finding?
I have to take MRCP also to see the
No,
biliary
you have the
anatomy.
ultrasound finding. Okay, thrombus in the porta, right? With few collaterals in the porta.
Yes.
You think shunt surgery will reverse your biliary structure?
No, it might be chronic.
But you are doing shunt surgery now.
If shunts can be done later on, later sitting, I can do a
No,
hepatic
no, no.
bypass.
I think don't stick to the shunt can be done. Shunt is already done. That you are not listening to anybody. So why at this time? We do upper GI endoscopy. Look for the very, she has not bled. Her only problem is
If he wants to do a shunt,
yeah.
what vein is he going to ask the
Radiologist to tell you
radiologist to see and tell whether it can be shunted?
which vein, what shunt are you planning?
Mesocaval shunt.
Mesocable.
Okay, well, shunt, how will you do? You don't know. SMV. SMV
I
status
get
you
a
do.
CT scan and see the.
So that's enough.
anatomy,
So
sir.
see, first, when the chronic liver disease side, front, liver disease side, whether the patient is okay for a shunt surgery or not, you are not decided. Second, whether shunt surgery is going to help the biliary structure, you are not decided. Third, the anatomy of the pattern where you, in a patient who already underwent PSRS, the shunt or salvage shunt, patient is suitable for not, that you are not decided. Before that, you are committed that I want to do shunt. This is the mistake happen. Understood? Even the diagnosis itself is in question now. Your diagnosis of PSPO.
Look at
And
the
based on what information are you presuming that you will be able to do a mesocaval shunting? With whatever we have so far, which information tells you that yes, it's possible to do it?
The angio done, see for the assess whether any shuntable vessels are available. If at all available, then you would do that. Otherwise, you will manage this patient with endotherapy. Yeah.
why see the collaterals are less. The esophageal varice is just grade 1. So that means that there is not severe portal hypertension.
You can go for
at the moment. You can even see, since she requires every 6 months
upfront biliary.
upfront biliary stricture surgery.
You could.
Upfront can be done with all good equipment and
Then select centers and select hands and
can do it.
Provided there is not much collaterals on CT angio. Okay. Thank you very much.
Maybe fibro scan and liver biopsy might be required before you go contemplate this.
We need to close, sir. We are running short of time. Any questions? 1 or 2 questions we can take, otherwise we'll move to the next. Please take the mic there.
Step by step, what will we see? Just now, Biju sir told, first we will confirm the diagnosis, then I missed that. Serially, he told many steps.
The EHPVO, NCPF are also predisposing conditions for cirrhosis. Okay. So first you have to be very clear about the liver. What is the status and what is the expected progression of the liver disease which you are already seeing in this patient, question number 1. So that has to be cleared by fibroscan and other investigation. Second, upper GI scopy has to be done. Whether the patient actually needs a therapy of upper GI bleed, possibly no. In this patient at this stage. Third, the biliary stricture which you have, the shunt you are doing is for biliary stricture actually to facilitate the biliary surgery. There are less collaterals in that area, and with this already thrombosed veins in other area, it's not a good idea to perform shunt at this stage. Attempt for a direct surgery or go for a multiple endoscopic intervention and proceed and wait for the natural progression or stability of the liver disease. That's what at least I suggest. Okay.
Thank you.
This should be portal biliopathy. Recurrent cholangitis has come later. Bleeding is started first at 13 years. So in all probability there was a problem in the portal vein. So portal biliopathy is the first diagnosis which had led to all the endoscopic management and then later all shunt.
Ultrasound also, with respect to your question, you do a CT and confirm that what you are seeing thrombus is actually the portal vein. Many of the situations, there's a large collateral can be mistaken as a portal vein. Portal vein may not be seen. ESP, whatever, portal vein will not be seen. You'll see a narrow, long cord with a thrombosed collateral also, which can be mistaken as portal vein. That can also happen.
Thank you, sir. Thank all the faculty. We'll move on to the next section, next case. I would request Sonali Shah, the faculty, Shastri, Dr. Ashok Kumar, Dr. Puneet Dhar, Dr. Sadiq Sikora, Dr. Venkat Ram Reddy, and Dr. Naran Rao. Request all the faculty to come on to the stage. Yeah, you can start.
Hello. Can I just say before you start? No. Just remember a couple of things. That we are discussing a case. You're not presenting and we're not criticizing you. The second thing is, don't defend all the investigations. You have not done it. You're seeing what it is there. So if it doesn't conform to what you're thinking, you may say that it doesn't conform to what I'm thinking. So be a little more confident in what you're discussing.
I'll just add one more. You might see some difference of opinion here also. What I want you to take is the perspective there. When there is a difference of opinion, obviously it means there are more than one option and which may be equal in their solutions. So don't go with the confusion, which is definitely not. Yes, there shouldn't be any confusion. In medical problems, more than two opinions is not an uncommon thing at all. So you should be getting used to that kind of thing and take things in the proper perspective.
My case, 55-year-old female, resident of West Bengal, presented, who's a homemaker, presented with chief complaints of generalized body itching since the past 3 weeks and history of noticing yellowish discoloration of eyes since the past 3 weeks. History has been obtained from the patient and the patient's sons and reliable. History of presenting illness, patient was apparently all right prior to 1 year back when the patient experienced first episode of right upper abdominal pain, which he experienced post meal 1 hour after meals. It was not radiating in nature and the patient had to take medication, the details of which is not available, to relieve the same pain. This pain was not associated with any vomiting or any fever. Patient had gone to a local hospital where she was evaluated with an ultrasound, which was told to the patient had gallstones, and patient was advised surgery for the same. However, due to personal reasons, patient did not undergo surgery. Patient was asymptomatic without any pain for the next few months.
Can you just, based on this small history, can you pinpoint the possible problem with the patient and possible organ involvement and pathology based on this is small? You are bringing us to the investigation and then the relevant information may hinder your thought process. Just let me know.
So the patient has come with
and I will also correct you. The patient first you mentioned he started with the itching and after that you said the patient has pain into the upper abdomen. A year back, the best would be start from a year back and then subsequent symptoms, how frequently and when she develop, and correlate, and then we can proceed.
Sir, she has come with history of right upper abdominal pain, a single episode in 1 year back, which she was not a radiating pain and it was not associated with any fever or jaundice, but she had once non-bilious vomiting. So most likely, I'm thinking it could be, and it was a post meals, she said 1 hour after meals, a fatty meal she developed it. It could be a gallstone disease, sir, mainly a biliary colic.
or it could also be because it was associated with some amount of non-bilious vomiting that could be even gastritis, though she did not tell me it was more of a burning pain, or she could not characterize the pain, sir. That's what primarily I'm thinking of.
What I understand, you feel that the past history here back is not related to this present illness for 3 weeks, what you mentioned.
No, sir. I feel it is.
Okay. It is related. Okay. To go to the present history, then go to the past history. I mean, this past history, if it is significant, then you come to the past history, or you can start from past history and then you can say she remained asymptomatic for a year and then now she has presented with 1, 2, 3 for this much of duration.
Yes, I started with the past history only, sir. So since one. Sir, I can proceed. So
just a second. I think since morning we've been seeing everybody wants to give the diagnosis through the. I guess that's what the change in trends has happened, that all of you want to ask the patient what investigations you've had and then you want to put that in the history. So, one off it's okay, but from morning, every single person has tried to get the diagnosis in the history of the investigation. So if you, for instance, in this case, you had that patient telling you gallstone, so you can, if you know it also, if the patient is very bright and he's telling you, the aim is you will bias the examiner if you do that. So it's a good idea not to do that as a trend. So sometimes you might be in a corner, portal hypertension, it might be safer for you to say it, but I noticed that for across all, you just want to give the history of investigation. Before you've given the rest of the thing, you're giving the investigations out. You leave nothing in your hand. So you think that it might be easier for you, but actually it isn't, because the examiner now wants to take you in a different direction. So it might not be in your favor. Every patient will be investigated, yet you'll say, we went to hospital and he was investigated. This is one of the most useless histories since morning I've been seeing. You don't need to mention that. You give us the history, and in your discussion, you can develop that the patient did give a history of, or they're giving treatment history, or you think that this might go in multiple directions. So use it to advantage rather than give a history of from where the patient went from this hospital to that hospital, and then this investigation. He will be investigated, he will be medicated. Don't mention that. What we want to know is the pain was severe enough to need medication. That's good enough. You want to know it was severe enough to need hospitalization, to need medication. So we are grading the pain. We are judging that bit.
Following this episode, patient was asymptomatic for the next 5 months, wherein she did not experience any pain. Again, in December 2021, she had a similar kind of episode which got relieved on its own with personal medications. Patient was evaluated and told about surgery. So on a routine checkup in 3 months back in May 2022, she underwent a laparoscopic cholecystectomy. The surgery went on for 2.5 hours. There were no blood transfusions given to the patient during that time. But post-surgery, patient was told it was a difficult surgery due to the reasons were not told to the patient. And patient was also shown the specimen of gallbladder and the stones. And the patient was told that she might require another intervention in the higher center because she had some leak which the patient is not aware of. Following this, patient was in ICU for 2 days. She was conscious. She was started on liquid diet by the next day. Her intraoperatively placed drain was there in the right upper abdomen, which on post-op day 1 in the evening, there was around reddish fluid initially, which was just 50 ml. However, from post-op day, from the evening on post-op day 1, she started developing a yellow-colored fluid, which remained for the next few days for measuring around 300 to 400 ml in volume. Patient was shifted to ward on post-op day 3. She was started on orals. She was asked to go to a higher center and was told about discharge within 1 week. However, patient wanted to stay in hospital of her own accord, so she remained in the hospital for the next 2.5 weeks. During discharge, patient was told about the biopsy report being normal, and she was told she'll still have to go to a higher center for further evaluation. She was then referred to AIG in 1.5 months back, that is in June, on June 7th, 2022, wherein she was evaluated and then she underwent another procedure.
You forget the another procedures, what you have narrated, the past history of. What I understand, I can summarize for it, the 50-year-old female patient had history of recurrent biliary colic in the past for about 1.5 years. Subsequently, she underwent laparoscopic cholecystectomy, which took maybe normal time as per required. So what are the important history you ask in this patient after cholecystectomy, and you can interpret what could have possibly gone during the surgery, and that's why the patient was asked to go further surgery at a higher center.
One history we should ask whether it was an elective surgery or it was in the emergency setting, which the patient said she had routinely gone. She, for personal reasons, she had not gone till now. Now she just went for elective setting because of the biliary colic she had. The second history we take is if it's whether it's an open and laparoscopic, and for how long the surgery went on. Also, post-surgery, whether intra or post-operative patient knows about any blood transfusions being given, or the doctor telling the patient that the surgery had gone, there was some difficulty which was encountered during the surgery because of some infection and or any other etiology, and also whether there was any bleeding during the surgery. Also, the intraoperatively placed drain, what was the content, what was the color, and what was the volume of the drain, and subsequently whether for how long it has remained the same, and whether it has changed in color. You
have perfectly narrated so many things. Now, you tell me now what is the importance of pre-operative condition history in this patient before laparoscopic cholecystectomy, and what is the significance of pre-operative ultrasound in this patient? What would like to know to reach some conclusion whether she should have been operated or not, whether she would have required another investigation before laparoscopic cholecystectomy, or what would lead to possibly this problem during the surgery.
So pre-operatively, emergency setting, if she has come with any fever or pain, acute setting, it suggests that she might be suffering from acute cholecystitis. So surgery in this setting sometimes can give rise to, there is a more chance of injury to surrounding structures like bile duct or enteric duodenum.
Okay, so one, the history of acute cholecystitis, which can lead to higher incidence of failure of laparoscopic cholecystectomy and also chance of injury. What else?
The duration of the history.
No, one. Then second would be obviously would like to whether the patient has mild pancreatitis before the surgery and she was operated during the same setting. Or ultrasound, you would definitely go back and see was the CBD was dilated, was there an associated CBD stone, or what was the condition of the gallbladder, which is inflamed, contracted, or any other anomalous finding which can have led to this. So now it is important to know, and I'll ask you the ultrasound what you did before surgery, before laparoscopic cholecystectomy at this point of time. Ultrasound before laparoscopic cholecystectomy. What was the finding of imaging, USG imaging? Which you don't know.
I don't.
Okay. So in your narration, you have not mentioned, you mentioned 400 ml of drain tube, which patient remained 2.5 weeks in the hospital. So you have not mentioned the nature of the drain. It was bile, it was blood, or it's bile and blood mix, or maybe enteric content, or it may be simple ascites, or it may be lymphoria, it may be chyluria. So what was the
patient
and what was the trend over a period of time, increasing, decreasing, remaining stent? Second, what were the other associated symptoms of the patient? What were the associated finding into the abdomen? I'm sure she must have been investigated even after surgery once she landed up at this complication that we will discuss.
No, sir, let the next person answer. You want to take next? The whole history is, the whole discussion is history only in this patient. So, anybody else knows the history or they don't know? No, so you want to respond to some of this information?
We have not seen the ultrasound report.
No, that's
Respond to so many things I have asked you. In addition to ultrasound, many questions were asked.
So can you just quickly tell that how the course went? So you told us that patient was in the hospital, ICU for 2 days, and in hospital for about 2 weeks because didn't want to go home. Patient had bile which became golden colored and 300 to 400 ml per day. Any other questions you want to ask for this patient in this course? Then in this period now, post-operative period, you want to ask any more information. That's what he was asking.
Did the patient developed fever or
So fever.
amount of drainage, whether it
That she is 10, no?
over the time, whether it increased
Yes. Okay. Trend.
trend.
So can you tell what is the trend?
It was 300 to 400 ml, which persisted for 1 week and then gradually decreased, and it has been nil since past 3 weeks.
Next question is to you. This is nil for past 3 days, 3 weeks. What will you do now? Patient has problem. Possibly patient has some kind of injury. We don't know. But now it has stopped not draining for 3 weeks. What you will do as a consultant? Patient is asking doctor whether you should remove this. I want it, get it out. We will remove. It will image. What advice you will give to the patient?
It's still there.
You just tell me what advice you will give to the patient.
Sir, tube might have got blocked. So
What advice you will give to the patient? What? I'm not asking why it is not draining. I'm asking what advice you will do, or what you will do as a consultant if she comes to the super specialty hospital.
feature of cholangitis like fever or anything, jaundice. And I may suggest patient,
There is no
ultrasound.
fever, there is no cholangitis. Patient has no fever, patient has no cholangitis.
Ultrasound we can do.
Okay, so just
Did you mention ecolic stools? Okay. I think can we let them finish the history, then we'll because I think we might confuse.
Huh? Okay, can you just quickly complete the history?
Complete
Because
the history, yeah.
You
1
should let
hour
her
will
complete.
Yeah.
Or maybe since the time is short, summarize
the history.
summarize the whatever you think are the salient features which you found in the history. I think that would let us proceed further.
So in June, when that she was having the intraoperatively placed drain, that time she had mild loss of appetite. She didn't have loss of weight. Okay, so actually when she came back, she was evaluated and a second drain was placed, which drained. Though this drain had started stopping, the intraoperatively placed drain, the other drain started draining around 100 to 150 ml of the same yellow colored fluid, which persisted for 1 week, and then that stopped. Following which, patient said her appetite has improved. There was some loss of weight of 5 kg. She was passing high colored urine. Her stool's color was normal. It was unchanged. But she has started developing generalized itching during this period. Currently, patient does not have any fever. And she has itching as her main complaint with yellowish discoloration of eyes. Her stool color is normal with high colored urine. Yes, sir. 2 drains. Both are not draining anything, sir. Currently.
We finish the history?
so you tell now, what do you think is happening in this patient?
Probably the injury to the CBD is healing by the strictures.
There was the injury, or was it a cystic duct leak, or was it a minor duct leak? How do you make that conclusion?
With the previous surgeon, what he
give us options that most likely possibility is what is
There was nothing done, only the drain was. So how you can say?
it's a small leak, it means.
So what do you think he is asking it? Why not it is CBD leak? It's draining 400 ml per day. And one very important for the referring surgeon, he said clearly patient was told you need other surgery. You should go for a higher center. What does it mean?
You're presuming the surgeon knows what had happened. We don't know
the
that.
patient-
No surgeon will know that and do it intentionally. No, it's discovered only post-op probably. Was it?
Yes.
The drain was put right up front in surgery. Is that routine? Is that routine?
No, sir. No.
So one clue again. What he was trying to ask you. What are the clues you're going to look for? That's one clue. You only put a drain when you're suspecting something.
Again, what I want you to analyze is, you have to say that there is a long history of significant amount of biliary drainage. There was a difficult cholecystectomy and the surgeon suspected a problem. And the fact that this drainage went on for a long period of time tells me that there is more than just a cystic diabetes in this patient. Also, and then the second part is the patient had a collection because one drain blocked, a drain was placed, so there was the collection, bile drainage, and when the drainage stopped, patient developed jaundice and pruritus, indicating that there is a main biliary system occlusion. So you have to analyze. I think it sometimes seems obvious, but that's what you want to sort of channel it and come out with this and say why this is not this and why this is this, right? That's what we want to.
One thing I will add, the first drain might have not drained and stopped, and the second drainage would be because of some undrained collection, which was the first one not draining. That may be the another reason for putting another drain. And you mentioned the patient has some kind of loss of weight and appetite secondary to that. So that could be the another reason also, without stopping, but another undrained collection somewhere leading to this kind of problem.
The bile leaked stops. What are the consequences, or what happens when the leak stops, which is going on for about 4 to 6 weeks? Stop.
It can be the fibrosis. Due to the fibrosis, whatever the leak, it might be going into a stricture, or sometimes it might be there might be internal fistula by which it can go, or it might be due to a
So
drain.
how will you differentiate between the two?
Stool color, sir. If it is a
Acolic can become colic.
Would the faculty agree that if a drain doesn't drain for 3 weeks, they will still leave the drain green?
So what would you do clinic? That's a very good question. What would you do in the ward when the drain is not draining? In this case, you find the drain is not draining. You go on the third day. What would you do? As a super specialist, you've been called in. What would you like to do?
and I'll ask the patient about any discomfort, pain in the.
Good, but normally it will take a few days. So what are the quick things you want to do? Two things you would like to try. No features of sepsis. Would you like to, his question is, would you like to leave the drain in situ?
The question is very
Are
straight.
you expecting that it will suddenly open up there? When drains block, do they open up? Unless you try to declot it and cause another fistula, but they will not. So it's always a good idea to take out a drain which is not draining. But in case of a bile, because you might get collections, it's advisable to do some kind of an ultrasound scan. Don't wait for the sepsis to develop. So those two things you should do. We are trying to see how you would respond in a bad situation. You want to make sure before you discharge such a patient that you don't end up with the situation this guy had another leak. So both you should do, even if there's no signs of sepsis. But of course, if there's signs of sepsis, you have to be more aggressive.
And is this a good situation? 2 drains, both not draining, but in situ. Is it required?
No. It's useless. No, you should take it out. That's what he's trying to ask you. You should take it out. A drain which is not draining needs to be taken out. You might need additional drainage, but take out the ones there. It's going to cause more problems only.
It can cause a lot of problems, like it can erode an artery, and there can be a lot of
artery. I've seen drains eroding duodenum. I've done an endoscopy and found the drain inside the duodenum. All of us have seen lots of disadvantages. So do not expect, especially at a junior level, when you go, you're very hesitant to even tell the consultant that a drain is not draining. We should take it out. So you should be proactive about making sure that these are taken out.
Yeah, I think we will go on to the next. Now that we have a basic idea of what the patient had and what he had gone through, what exactly would you like to do now? Now you have a patient with Okay, we take it that
Everything is-
bond
is-
of time, patient is not in cholangitis, not in severe sepsis, and she has a drain which is not draining, and but mildly jaundiced, not in cholangitis. That is the situation. Now, what exactly would you like to do?
I would like to review all the previous investigations if it's available, sir. To start with.
What previous investigation? It's a
Which
case.
specific one you want which will change your management? So tell us those only.
The initial ultrasound abdomen.
How will that
See,
change your management?
No, don't go into a standard kind of answer. You know, I want to review all the investigations, but you should see how they would help you at this stage.
So in case
at this stage, you already have an idea. There was a residual fluid which is drained, which is bile, and which is also stopped. Now he's getting jaundice. How would the previous investigations help you now?
PPT.
See, for instance, if that history of weight loss and anorexia was gross, 20 kg weight loss. Now you're suspecting the original could be a malignancy. So then you are justifying in that manner. So that's what is. So you need to answer an algorithm now. What you want, which will change your subsequent management, or what is your thought process and how you're going to change that.
Patient had a weight loss of 5 kgs. That could be
So
secondary.
that's not important.
Not
Just give
very
you an
important.
example.
Though it was told
Every
that
single patient will tell you that
If
who
you
has a
want to-
biliary injury, who's been in the hospital, who thinks there's a doctor's fault, he will give you all that history.
Puneet,
So,
if he wants to review just one thing,
yeah, what
would it
specific
be?
thing would you want to review which will change your management? If not, we'll go on. It's better to go on. Don't get stuck with, because in the exam also you get stuck with this waste time in
if
this.
available-
Do not do that. If there's a specific thing you want, ask for that, and do not say I will review the. What I would suggest, a smarter way of doing it is, if the previous investigations, I will look at that. Otherwise, I would like to do this. See, that's a very smart way of coming across, because you can see all of us. If you say the history she started out with, I would have put differently, and I would still accept 3 different people. So there are ways when you started out with that with pruritus. Now you could have easily put it. A patient had a history, had a history of surgery following which. So the whole thing changes. When you told us pruritus, that's why there was a confusion what is going on. So don't lead on in a wrong manner. So you can choose to do. Ramesh will always tell you. A smart person can lead an examiner on, but you do it the wrong way. So if you want to say, you just want to get, somebody shouldn't say, why didn't you want to review? Just say, I would like to review the previous investigations. If not available, I will do this.
if available, I would like to review the operation notes,
Nothing
sir,
is available.
and
Now, okay, take it that no investigation is available. You have the patient as described. How would you proceed?
so I'll start with the basic investigation, sir. Hemoglobin, total
No,
count,
but I asked him for one thing which he could review if it was available.
histopathology.
No, it is the video. In such a situation, if the video of the operation is available, it should be reviewed, because you may get your answers, all your answers there.
Agree, 100%. Should always ask.
Start with the basic investigation, sir.
Say
Yes,
basic,
yes.
no.
Hemo-
I thought we've run through this several times every Monday, that don't say basic investigations as if you're trying to. So if you think that we might object to your saying, not saying the basic, say I will want,
So I have a very direct question to you. Forget the basic investigation. The patient has undergone lap cholecystectomy, land up this kind of post-operative course, likely to have a kind of some biliary injury and which has subsequently closed. Tell me the one best investigation which will lead to further, the establish the site of lesion and possible course of action.
MRCP.
To start with
Investigation.
MRCP. So the MRCP.
Stop. No ultrasound.
Only one question he was asked which can lead
technically,
to further
these are theoretical questions. In the field, we want you to go through the whole process. And I think what you need to tell us is that you want the hemoglobin to know if there's any, if it was early on vascular injury here, what is the level of anemia. The leukocyte count is specifically important, isn't it? So I think don't call it basic investigation. You want to know the patient is in sepsis or not right now, because that will change the kind of investigation you might do.
read this MRCP. Read among 5 people.
Come on, one of you read it, man. Come on.
intrahepatic-
Simple, straightforward MRCP.
Intrahepatic biliary radical dilatation, the dilatation of the common hepatic duct with the abrupt cutoff. Probably the part of eminent gallbladder is also.
Is that a gallbladder or just a collection of fluid?
Yes, maybe a small collection. Maybe a village which is collected, bilioma. Bilioma. Yes.
Anything else on that MRCP?
Right side.
This MRI MRCP is showing intrahepatic bile duct dilatation, both left and right hepatic duct. The confluence seems to be intact on these cuts, sir. But below that, there is a stricture seen. The distal CBD is seen, and also the pancreatic duct is seen, sir. That joining into the outside, probably a long channel. It's away from the duodenum. I would like to see the.
How does it matter now?
So do you want to do you want to see some pancreatic pathology here we're looking for?
No.
What is your intention to look for? What is more likely problem?
The stricture, sir, which is
So which you have to see if it is form a stricture, or which is the type of bismuth stricture. Is there any
Type.
associated bilioma? Is there any atrophy complex? And obviously here we cannot comment about the vascular injury, whether there is associated vascular injury. So there are so many things. So whatever available, just tell us.
it's a type. The confluence is intact, sir. Looks intact. It looks like a type 3 stricture.
Type 3. There's a long common hepatic duct seen.
Right.
Look at that length.
That you saw the distal CBD. So do we have a marker by any chance? I think if you're seeing the distal CBD, then where is the what are you not seeing a proximal CBD as well?
This is the confluence which is intact. This looks like the strictured part. Only the confluence is intact with the remaining. There's no stumps.
So then what is that between the cutoff and the hilum? What is that? What is that you just pointed out? What you pointed out, what is that?
That was the CBD.
That was the
There is still CBD, sir.
No.
The area of consequences, sir, immediately below the hilum, there is a strictured area, which is.
You have bismuth 1, bismuth 2, bismuth 3. No?
Because you can see in these cuts, it looks like the confluence is intact, but I could not see a common hepatic duct stump.
What is that residual thing between the hilum and the cutoff that you are seeing? I think
you are not sure.
The other guy said there's a cutoff, no? So can you just give the pointer to him? Tell us your interpretation.
Where is the hilum? First you show the left duct, right duct, hilum, and then whether the stump is there or not. So I think there is lots of confusion interpretation of the the hilar structure. What is the hilum? No, loud, please.
Left hepatic duct which is coming towards the hilum, sir, and this is the right, the anterior, and this one is the posterior, which is joined. This one.
So where is the
Compared to the
hilum?
cutoff is how much distance do you estimate?
Almost 2 centimeter more.
So what bismuth does it become?
This is E1.
Huh?
Type 1.
So I think in the formative assessment, a lot of you confuse the cholangiocarcinoma bismuth with this. Please go and read this properly. And you had a confusion between in the bismuth 5 also. Many of you gave wrong answers. So would you quickly, next guy, would you be quickly tell us what is bismuth classification? Quickly, very quickly.
Type 1 is the CBD, the distance, the CBD is more than 2 centimeters. Then if it is less than 2 centimeters, it is type 2. Then it is at the injury, the stricture is at the hilum, but the confluence is patent is type 3. And if it is at the hilum and the confluence is separated, type 4. Type
So if the confluence is intact but narrow, which one is it? 3 or 4?
separated.
Said that's why since you gave 2 extremes, where would you put which is narrowed but patent but narrowed?
There is some new classification given by some of the people sitting here, 3A, 3B.
Yeah, 5 is another place where many of you made a mistake. Yeah.
Accessory ducting.
So both are mandatory. What is the original bismuth 5? You must be able to enunciate clearly. You have to tell your junior what it is. Huh? You're quickly trying to shove it under the carpet. What is 5? Associated? Associated? Associated duct injury.
Accessory duct injury.
Accessory duct injury is type 5. Or with, yeah. And many of you gave the Strasbourg classification in bismuth for some reason. Strasbourg is for early biliary injury. Bismuth is for established stricture. The E of Strasbourg parallels the bismuth. So that's why I think it confuses you. But when you're asked only bismuth, you give only bismuth. Just give 1 to 5. So many of you have written a lot of history.
What do you think? Can anybody tell what is the significance of classifying here based on imaging? What is the significance of this?
Like reconstruct surgical changes.
What? Speak loud.
The management pattern changes.
So type. What is the management in type 1? What is management in type 2?
Type 1. And we can do end to side anastomosis.
End to side anastomosis. End to which end to which side?
The end of the to the bowel loop.
What do you call that? What do you call that? Oh, you're going to appear in the examination. You should not shy. You should be very clear and clarify.
Even though end-to-end anastomosis is advocated, that carries high risk of stricture.
Which end-to-end?
No, when you got a...
So will you do end-to-end in this situation? Which is the only situation where it is, if at all, recommended.
Intraoperatively when you're recognized.
Yeah. So don't even mention it now. Why mention it now and put your foot into the grave? Isn't it? It's a classic how putting your head into the lion's jaw.
What is it? What one is the approach? What is its significance? Suppose that if I write into the code, if patient go to the code, if I write type 5 injury or if I write type 1 injury and repair and patient zoom in the code, it has a different meaning. It's a different significance. In addition to the type of surgical intervention, it has many meaning. One, surgical intervention. Second, the outcome of the surgery, long-term and short-term failure, restriction date, further requirement of surgery, further requirement of non-surgical intervention. So there are so, and even the significance, importance of the
Hepaticoagenostomy, all the ducts to be trained.
Last answer this question.
So when you do a hepaticogynostomy, so we have to make sure that all the ducts are drained, because in type 4 there's hilum suppression. So we have to identify the anatomy correctly, whether you identify whether it is a trifurcation or a bifurcation of the
Briefly,
hilum.
you will drain both systems
Both the systems, yes,
separately.
yes, sir.
In 1 2 3, it's enough to make sure one and 2 you can just do a single anastomosis. And in 5, you might have to take a call whether you need to or not need to do that.
Yes.
So it's direct relevance, no?
And
So just
also-
give us that answer.
And also,
you,
I think
you need
it's
to
a
be
bad-
accurate about what the question is, what you're answering.
And also in any department, type 1 or type 2 would be given to a junior consultant also to do the repair. But type 3 and type 4 would require a senior consultant with considerable experience to do the repair.
So now this patient is there, you've got the MRCP. Now to plan the treatment of this, what all you need information and how will you plan out the treatment? So you have got MRCP. Is that good enough? Okay, go ahead and do surgery.
I will learn one more thing. Many things we have not discussed here. How will prepare the patient for surgery and what else information you need before going for the surgery.
We have done total count. Patient is not in sepsis. To start with, sir.
One total count?
No, it's normal. So 10,000. We have ruled out patient is not in sepsis. So I want a baseline LFT. Stop. So want a LFT. Want to know the patient's electrolytes, basic PT INR.
Electrolyte in this patient.
The patient was having active biliary, external biliary drainage for some time.
This for several weeks before. Now is up and about eating. Just pruritus is there. Some jaundice is there.
If the biliary fistula is stopped, then there is not required. Sir.
It's several weeks. It has already stopped. Why you are interested in PTINR?
The patient is developing an obstructive jaundice.
Why you are interested? It's the jaundice is there. Why in PTINR? Go and operate.
Because the fat soluble vitamins are not absorbed.
Go and operate. I'm not asking why PTINR is raised. Why you are interested before surgery? What is the PT? What is the INR?
If INR is abnormal, what is your implication? What is your action?
So if it is abnormal, then I would like to give a vitamin K before contemplating a surgery.
One implication is because of the obstructed jaundice.
Yes,
if
sir.
it's very long, it could be a liver hepatic cause also. If
Yes,
it's
sir.
not corrected by vitamin K. That's
Second.
and the action is of course.
What else? What else? One, if it is abnormal, one is you will get vitamin K. What else he will do?
All the fat soluble nutrients are not absorbed because of the prolonged biliary insufficiency.
What else you will do in addition to giving vitamin K? Suppose the theoretical question, bilirubin is 10 in this patient, SGOT-PT is about 200, and this patient PT-INR is significantly raised. And how will you prepare this patient for surgical intervention? And surgery is planned hepaticogynostomy.
She's not in cholangitis, so I'd like not to consider a biliary drainage. No, she's not in cholangitis. So give vitamin K, give preoperative course of antibiotics, assess the nutritional status. This patient is nutritionally impaired, sir.
To Percussion plasma.
One, how will you prepare this patient?
See the
Patient is jaundice, you know the patient has abnormal PT-INR. This patient, is going to have a major surgery. How will you prepare this jaundice patient for major surgery who is likely to bleed?
You hydrate her.
Reiterate my question. So here is a patient with type 2/1 bile duct injury, Bismuth type, with this LFT. Now, how would you decide this is the right time to do the surgery for this patient? What are the considerations? Then in this patient, you have to rule that out or tick that. So can you just go through the list?
Patient is having obstructive jaundice, bilirubin is raised. Patient is SGOT, SGD is 140 and 144. So patient is not having cholangitis. Albumin is
Not
pre-
having.
Sir, more than 1.5. I have to see at the normal for the institute, whatever.
What do you think?
40 is the normal. This is
Then it's
fourfold
more.
elevation.
Then more than it is in
1.5 times just now.
Yes, sir.
Now this is about almost 4 times.
Yes, sir. Then it is elevated. Then I have to see the nutrition status of the patient. Serum albumin is 3.4, and then patient.
That's an important. So when you say that this thing, we don't know what emphasis you're giving. The albumin, you must give a pause and say that this is. I'm looking at the nutrition because his question is, what are the prerequisites for a good surgery, for a good outcome? What all are you going to look for? You get the question.
Yes, sir.
So tell us those things.
Good nutrition.
One you said is you want to rule out cholangitis. Nutrition. What
Yes. Sir, PTNR is 1.34. The patient does not have. We can give vitamin K for the patient. Then
Don't forget the question. Dr. Sadiq asked you when to operate this patient. Patient has formed this surgery a month back. Patient has stopped leaking, formed a stricture 15 days back. What is the optimum time to operate this patient to have an optimum outcome and better long-term result?
once the external biliary fistula has closed and the stricture has developed properly, and that is after between 3 to 6 months would be an ideal time to operate of such a patient.
How long is this patient from surgery?
3 months would be an ideal time, sir.
This patient to continue to his jaundice to go up, when because now time is not 3 months. The jaundice bilirubin is 10. So you say, no, I want to wait for 3 months.
Since the stricture has formed and the patient is not having an external biliary fistula at this time, then this would be a good time to operate, sir.
So then, what were you trying to say earlier?
6 months they'll get secondary biliary. They
Secondary
can get
biliary,
biliary
yes,
cirrhosis.
yes.
Definitely 6 months is
A higher side, yes, sir.
How long is this patient from surgery?
Let's
3 months, sir.
No, this patient.
3 months.
3 months.
Yes.
Okay. Suppose it was 4 weeks from surgery and the same figures were there. Sadiq is asked, showing you. What will you think of, and will you operate, will you not operate?
4 weeks from surgery, there are chances that the CBD. No, sir.
See, don't try to go around the question and buy time. That clearly gives you away. He's asked a very specific, will you operate or not operate?
Yes, sir.
And if you do, then you have to say what are the caveats for that. Because it can't be without caveats, the decision to operate.
I will emphasize one more thing. In exam, we are assessing how confidence you are taking in decision. You are flexible. If he says I will not operate, then you will say I will not. He will say 6 months. Yes, I will 6 months.
Ashok, let's just finish the question. As Dr. Ramesh said, 4 weeks, the fistula has stopped, bilirubin is 10, and the values you saw them. So now, what is your plan for this patient? We need to take 5 minutes because this is important. Come on, if you are not confident, let's get on with the discussion. You want to do? Yeah.
So we usually operate, the optimal time is after 6 weeks. So if patient has this bilirubin level and no cholangitis, we rule out cholangitis, and then after 6 weeks we plan for surgical interventions.
I have to ask the question again. It is 4 weeks at this point of time. This is the lab value. This is the patient. What will you do today? You will say, I'll wait for 6 weeks. So you'll wait 2 more weeks for this patient?
So it takes around 6 weeks for the injury to evolve itself.
What exactly, when you say you mean evolve, what are you worried about?
If there's arterial injury, sir,
Finally. See, so long none of you talked about arterial injury. So if an arterial injury is there, you will have to delay the surgery.
So because when there's an arterial injury, the level of final fibrosis can extend upwards. Also, the chances of restricture rates post hepaticojejunostomy are more.
And also the collaterals to develop. You all want the collaterals to develop. So, you see it at 4 weeks, but then you have to evaluate whether there's an arterial injury. For that,
So if you're doing it early, you want to make sure there's no
CT
arterial injury. Otherwise, this is since it's a laddu. So why do we wait? Why is this wait there at all? Forget no arterial injury. Why are we waiting at all?
So if sir, she had
The funda, the philosophy. Yeah.
the sepsis, the inflammation also settles down, and during the same time, if pre-operatively, we can even optimize the patient nutritionally.
Right. So yeah. So basically, many of you answer that it's we are waiting for it to dilate. It's not for dilate. It's for it. Coincidentally, the dilatation is not important. It's probably the wall thickness and holding and the inflammation level. So we want an absence of inflammation and a decent hot. That's the idea.
one last question on the MRCP. Are there any unfavorable factors when you see the MRCP apart from the level of the stricture? Level of stricture is one thing. 4 and 3
Is there
and 4 are
anything
difficult.
else in the MR? So for instance, if you're doing a PTC versus an MR, how does MR score over a PTC? What are you looking at in an MR which you should look at?
The biliary anatomy, the aberrant ducts. Besides that, the liver.
Yeah, so the missing separated out, but that is very, very crucial when you're looking at an MR to look for any sequestered duct, which is
Sequestered
not
duct, which
which
you
is
will have
not
to
in
drain.
continuity. You'll have to drain.
And also, the lie of the left hepatic duct is very important on the MR. Many patients have a horizontal left hepatic duct like this patient, where the surgery is very easy because you get a long cut you can make. But sometimes the left hepatic duct will go vertically up from the confluence.
So the base of the segment 4 is very small. It's a much tougher anastomosis to expose. That's a very good point. That's one clue you get in the pre-op cholangiogram if your left duct is vertical or horizontal.
So, I mean, just now we are short of time and we've overrun that. I just want the emphasis of why we are asking again and again. You need to be able to tell that we need to see favorable factors. And if favorable factors are in favor of the patient, then surgery can be offered. If you have to wait, then you will have to also think of alternative procedures to do in the interim period, such as drainage of the biliary system by any means, so that there is no progressive jaundice, ongoing cholangitis, and synthetic dysfunction. So all these things you've made reference to in bits and pieces, but you have to put the clear picture together. No, so in this patient, I will look at the nutritional status, sepsis, type of injury, duration from that, and if all these are favorable, with preparation, again and again asking, patients should be well hydrated, should be corrected with their coagulopathy, and then undertaken for surgery, and have the best people to do that, irrespective of whether it is an easy or a hard surgery, right?
Surprisingly, this was one question which was answered the best in the formative assessment by 90% of you. I'm surprised that there's so much of a disparity in the practical bit.
So in this case,
case,
with a bilirubin of 10, if patient does not have cholangitis, we have to wait for another 2 weeks. And patient doesn't have cholangitis, we should do a drainage, sir. Or
You don't have to wait.
You don't need to wait, no?
Here, if there is no significant sepsis, patient is a good anatomy, so that means you can do a good job of drainage of this biliary system, and it's come about 4 weeks with jaundice, and you prepare this patient for maybe 48 hours, hydration, antibiotics, and vitamin K, and then undertake this patient for surgery. You don't have to wait for 6 weeks. That's why this question was
But
raised.
I would like to, at that stage, do a CT to see the arterial injury. If there is an
Rule out.
arterial
That was the
injury,
idea, to rule out
then
an
I would
arterial
wait.
injury at that stage. You don't want to do it in early. That's been established. I agree. I think we should go on with the
Sir, one more
case
last
capsule.
Significant AG reversal. So should we contemplate only to nutrition related or secondary?
So, AG ratio is not important. It's albumin value. I know a lot of stress has been placed in hepatology on AG reversal and all that. Look at the pure albumin value. You want to know good nutrition. there can be several reasons for, autoimmune hepatitis might have very high antibody levels, so you can have high. So look at if you think the patient is nutritionally able, this is a very long history and you think there might be a secondary biliary fibrosis or something, then it's a worry. Is that your question?
Yes,
no?
sir.
Yeah, so it's the albumin value you need to worry about and the level of your global subjective assessment of the nutrition. That is more important than AG reversals.
And sir, if
In current liver tests in hepatology, they do not actually use the term AG reversal. It's still a hangover from last century.
I will add one more thing here in this patient because of the jaundice. The enzymes are very high, around 150. It's very unlikely that the bilirubin will be coming very high. It will remain because of cholestasis jaundice. It will remain reasonably good in a period of time unless you wait for very long when the cirrhosis and other things start developing. It's the best time to operate, and you have only one bilioenteric, one enteric to enteric anastomosis, not going to create much problem with that.
Your doubt that whether we should do a pre-op biliary drainage? Is that the question?
No. Actually, I was confused whether with this significant AG reversal should we consider liver
Normally,
biopsy
with less than 6 months,
preoperatively.
in a benign condition, less than 6 months, you'll almost never get secondary biliary cirrhosis. So that's one. Even in established malignancy with complete obstruction, it's a minimum of 6 months to get secondary. So do not worry about. But you can have secondary sclerosing cholangitis. So if the history suggestive of multiple attacks of cholangitis, you can still have a more accelerated SSC kind of a picture.
And, in case of biopsy showing secondary biliary cirrhosis, the plan of management
It's a reversible. That's why nobody will give you funnily enough, till the 4th edition of Schlesinger, there was no entity if you looked in the index, there was no entity of secondary biliary cirrhosis. Many people still doubt that because cirrhosis means it's irreversible. Whereas this is secondary biliary fibrosis, probably more appropriate. So the treatment is, like you said, is the reversal only.
Correct.
So yes, you will reverse. If you think it's very advanced and there's a likelihood of varices have developed or something like that, you might do a pre-op drainage or something like that. Yeah.
Thank you.
So this we've published long back about this biopsy in biliary stricture. And you have to differentiate between cirrhosis and fibrosis. So initial phases, you will have fibrosis. And what we found in about 670 odd patients that we did, that you can get changes in the liver even as early as at 3 months. But the fibrosis aspect is reversible after drainage, and even cirrhosis patient stabilizes. So if drainage can be established safely with all the things considered, you should go ahead and do the drainage, not postpone it because you have either fibrosis or biliary cirrhosis. Only if there is significant portal hypertension, patient has severe coagulopathy and poor synthetic functions, at that time you may not undertake surgical repair and go for non-surgical methods of treatment like stenting and things like that if it is feasible.
Any questions from the audience, because we can finish off?
Just one point. See the slight collection you see there, residual collection, that could have both favorable and unfavorable issues. With that also you should remember. Unfavorable because there is a potential contaminated area, which is not a good thing to operate when you have a potentially contaminated area. On the other hand, it is much lower the subhilar level, and it can be a good guide to the area of stricture. So you should realize the importance of areas like this, how useful it is, and what bad effect it can have. Both are important.
And in an established stricture, please don't use the word end to side hepaticojejunostomy. Please always say side to side as a long cut, minimum of 3 to 4 centimeters. In the end, you can never get that side.
Yeah.
Yes, sir. The patient. Yes, sir. Yes, sir. The patient is
the normal.
Yes, sir. Patient is a 50-year-old male. Came with complaints of anorexia and loss of weight of 4 months and jaundice for 2 months. So patient was apparently normal 4 months back and developed reduced appetite and loss of weight of around 10 kgs in 4 months. So later, after 2 months of anorexia, patient noticed yellowish discoloration of eyes associated with high colored urine and not associated with itching, and there is a history of occasional pain abdomen. There was no history suggestive of cholangitis. Past history, patient has no significant past history, and personal history is not significant. On examination, icterus is present, and liver and spleen are not palpable, and gallbladder is not palpable.
From the history, what do you think the diagnosis could be? Like there is a typical history that has been given. What do you think the clinical diagnosis could be from the history? And
It looks like obstructive jaundice secondary to a malignant etiology. The patient is a 58-year-old from West Bengal. I would just like to know if he had any recurrent episodes of pain radiating to back previously. Based on history, I would place my diagnosis with right upper quadrant pain as a carcinoma of the gallbladder first, and the second would be carcinoma head of pancreas because of the significant weight of loss and anorexia which he has associated with the jaundice.
so
History,
not dilated. So of course, it's obstructive jaundice, malignancy that's accepted. So what do you put your diagnosis as? What do you think the first diagnosis can be from this?
You heard during the previous discussion, the question was that you should reach, obviously, jaundice is, you are evaluating a patient of jaundice. Secondly, second question would be the malignant or benign jaundice. If it's a malignant jaundice, then what is the possible level of block and what is the possible lesion in this specimen? Maybe you can pinpoint pathology based on the history, that would be fine. Otherwise, these are the two answers they have to answer this question.
In view of significant loss of weight and loss of appetite with pain, I would keep carcinoma head of pancreas as my first diagnosis. Also, because the patient is coming from West Bengal, I would keep carcinoma gallbladder as the second diagnosis.
West Bengal, because of West Bengal, you are considering carcinoma of the gallbladder.
So it's like a patient had 4 months history of loss of weight and appetite. So
15 kg,
so,
15 kg weight loss. It's a
yeah.
significant weight loss.
Can you
and
put
appetite.
CIDA pancreas as the first diagnosis with this?
Yes, sir. If he has significant weight loss and loss
Pain appeared first or jaundice appeared first?
Which one comes first?
In this patient.
sir, usually in a
In this patient, which come first?
anorexia and the weight loss had come,
And then,
followed by the jaundice, sir,
And then?
the pain.
so in pancreas, what come first?
So usually pain comes first in
Yes.
60 to 70% of the patients, sir. But
So
in
usually in the
one-third
pancreas,
patients,
pain will come, jaundice later, and obviously anorexia and weight loss. What happened in gallbladder cancer?
gallbladder cancer, the pain is a predominant risk.
So what are the things that you're suspecting at least? Just tell me what are the things that you suspect in this? One is CIDA pancreas.
Yes.
Second is totally CAGB.
Yes.
Which is the other one you are suspecting?
Hilar cholangiocarcinoma.
So just try to analyze and put 1, 2, 3 in these three things. So I mean, from what Sir has discussed, I think CIDA pancreas you have almost said no. So the other two things, what you can put as first, just think
So
and just
carcinoma,
analyze and tell what you
gallbladder,
can.
and hilar cholangiocarcinoma, I think.
Yeah. So
Gallbladder, except the patient is from West Bengal.
He
I
has
said
pain,
cholangiocarcinoma. Why
sir.
not
Sir,
cholangiocarcinoma?
usually in carcinoma gallbladder and carcinoma head of pancreas, there is significant weight loss and loss of appetite.
Any malignant pathology would have significant loss of weight, appetite leading to the loss of weight, sometimes unexplained loss of weight, even eating a normal diet, and significance, obviously, it's a
I
significant
think
loss
we
of.
covered this in the previous thing.
Yeah.
So I would accept what she said about gallbladder and pancreas. Hilar cholangiocarcinoma would come much lower because you don't get such profound weight loss. Itching tends to precede and all. I think this the case. Idea of the case capsule is not the history, but it's the investigation, right? Which you want us to tell us. So I think we should crack on with that.
Yeah.
So, no, before that, you tell me priority wise 1, 2, 3, what is the differentiate diagnosis so far based on this discussion? Pancreas first,
Yes.
GBC second, and then
Hylar
hylar third. Okay, what investigation will do? One investigation where you can establish the diagnosis. Only one investigation, differentiate among all three.
Triphysic CCT.
So the CT scan, do you have?
Why not just ultrasound?
Okay, let's have what she wants.
Okay.
So I think no, I would agree. This the Ramesh principle would hold because you've got significant weight loss. Your weight loss has preceded the jaundice. So amongst all these, there's a very high chance of getting a metastasis. So I think an ultrasound would be wise in this case because if you get metastatic disease, you're not going to do a very extensive workup. So given the scenario, you can actually change and sensibly say it. Okay.
No, the question was not to rule out the metastasis. It was how to.
No, I think we,
suppose that is a non-metastatic disease, which is the best investigation to establish the diagnosis.
What we need to stress is how they're going to do in the field. You know, that's what we need to stress in the exam. So I think we need to go that way as well. You want ultrasound or CT first?
That's already on the screen.
No, it's okay. It's okay.
It's a plain scan axial. It's a plain axial scan of abdomen. Can you please go up? The arterial phase. Lung window looks okay.
Chidira was one of the first people to have all these live played everywhere else. So you're on candid camera. You need to speak out in the mic.
Go down.
Yeah, keep telling what you're seeing in the liver first. See from above, below, come down. You're trying to see the level of obstruction. No? Start from the liver, where it is coming, trace the depth.
Here, hilum or some soft tissue. Near the hilum, sir, there is some soft tissue.
You were able to trace ducts only till the hilum.
Please go down.
Too much time you are taking.
Hilum, sir, I could trace the duct. Sir, intrahepatic biliary dilemma. Not yes. It's a portal vein look. Okay. LOPC5.
Yeah, once you said the hilum is obstructed, no? Can you say some
You
anything,
see,
any
I'll
significant
tell you
lesion or
because
anything?
we were working on three things: carcinoma, gallbladder. You see the gallbladder में कुछ है कि नहीं? You were seeing for the pancreas, there is nothing, and beyond hilum you are not able to see CBD. So it's very clear.
Gallbladder looks okay.
So agreed with you, no doubt.
Gallbladder looks grossly okay, sir. So basically, it's a hilar mass with upstream dilatation of the biliary duct. But I would like to characterize the mass based on the MRC.
So what else you will do for to one investigation CT you have seen? What else investigation you will do to offer any kind of treatment to this patient? He came from West Bengal. He is asking doc.
MRCP, I would consider, sir.
Why MRCP? CT has already given good information. Why do you want MRCP?
To characterize the mass well and the exact level of obstruction.
It is the hilum.
Characterizing mass is better on CT, no, not on MRCP. The level of obstruction is okay, fine. MRCP.
Suppose that if I ask you different way, what is the role of MRCP in established or suspected case of hydrocholangiocarcinoma? How it affects your decision making, treatment plan, something like that?
Anatomy, sir, how many ducts are there?
You should be very, don't be shaky. You should be very clear and loud.
A number of ducts, sir, how many ducts are there?
It's again for the bismuth staging, no, something like that.
Yes.
Okay. In CT, what else will you look at? You said the mass is the lesion at the hilum.
Sir, in the arterial phase, I will look for the any vascular invasion is there or not. Whether there is aberrant arterial anatomy is there or not, and status of the portal vein, atrophy, hypertrophy complex, lymphadenopathy, whether any ascites is there or not, in the lung window for the pulmonary nodule.
Anything is there? You can see anything, whatever you said.
In evaluating the vascular structures, is MRI better than CT?
Vascular structure, sir,
Want
CT.
to see all the vessels, na, is it not? Arterial anatomy and portal vein to assess them.
CT is better.
And one more point which you have to add for all the lists which you did, you want to see if there is any atrophy hypertrophy complex.
He mentioned. Yeah. So now the MRCP is there. Just see. Tell the level of obstruction now in this.
It is at the hilum with
Hilum separated or not?
yes, sir, separated. There is abrupt cutoff between the communication of the left system and the right system. Sir.
What is the stage of the disease?
Probably it is extending onto the left side, sir. So maybe it's a 3B, sir. This much stage 3.
What is 3B?
3B is the involvement of the common hepatic duct extending up to the left hepatic duct.
Hilum?
Hilum stage 4, sir.
Without going to the hilum, how it will extend into left hepatic?
I mean, hilum. The right side.
That's what.
Yes, sir. Primary and extension to the which side it is extending. In 3A, sir, it will extend to the right. In 3,
Yeah.
it will extend to the left.
So was बहुत clear है. Why you are confused? Same.
First of all, sir, I will look for the patient whether he is in cholangitis or not.
Patient has been already been given the history in all in.
Okay, sir. Hemogram.
Hemogram.
Yes, sir. Hemogram, LFT, RFT.
Yeah. Hemogram is normal.
LFT is fairly okay, sir. I mean, RFT. LFT, please.
LFT.
CA19.
Why do you want CA19 in this patient? It's a case of hyalocholangiocarcinoma. Patient has jaundice. What is significance of this in decision making CA99 at this point of time?
It does give a clue that disease might be advanced. It doesn't diagnose the disease, but
No. We know the diagnosis. No, we are not okay. So just for prognosis. You want for prognosis. Okay.
No, the problem is that the mildest of jaundice, if even subclinical cholangitis, CA99 will go sky high. So With jaundice, the value is not very much.
Okay. Sir.
Okay, next
Then,
what
sir,
is
I
your-
would discuss this CT again with the radiologist regarding the resectability of the disease, and I look at the nutrition of the patient as well. And if the Yes. Sir, sir, if
No,
disease seems resectable on the CT.
No, from you already seen the CT, no?
Yes, sir.
So you felt it's resectable or not resectable?
Yes, sir.
Resectable.
So what will you
Okay.
do? Which kind of surgery you plan, and what will you do before surgery, before you venture for resection?
Sir, CT volumetry
Okay.
I will get.
Okay.
and-
What kind of resection do you contemplate in this patient?
Sir, extrahepatic biliary resection with segment 1 and 4 excision and reconstruction.
Why not extended
Extended?
left hepatectomy?
If parenchyma can be preserved and if we can R0 resection, then
Okay.
it's an approach. Yes, sir. In CT, left artery, on the opposite side, right artery and right portal vein I would look, and especially main portal vein.
Yeah, I think so. That will be based now on which side it's extending, right?
What are the determinants? So it's a question. What are the determinants to help you choose? And if in doubt, what would you choose?
Whether the left lobe is atrophied or not. If it is atrophied, then we have to remove it. In this case, it is not atrophied. So, if possible, preserve the parenchyma. So segment 1, 4, and the extrahepatic biliary.
What is the atrophy usually due to?
Biliary, if portal vein is involved, then the atrophy will be faster.
Any of the vascular involvement?
Vascular involvement.
In addition to the block, you're more likely to get.
Yes, sir.
Okay, any other question before we end the session?
Especially in the biliary injury, please ask. There are a lot of people here to answer that. That's one of the places in the exam that's you're almost sure to get one case of that. So if you have doubts about, lots of times you have doubts that I said this and they said this and no, okay. You can close.
Please use the mic there.
So again, I just want to
Just walk up to the mic and ask.
say this again, that from subsequent batches, we need to have more definitive and confident answer. No, don't beat around the bush. When a question is asked, don't repeat the question, repeat the investigations and then answer the question. You've been asked a question, answer the question. Don't try to go roundabout way of getting it, right? And this usual thing about you need to sort it out in your mind. Jaundice, CT, MRCP, what you're going to tell and have the justification ready for each situation. These are standard questions. Will always come when you're doing a case of obstructive jaundice.
Most would be accepted actually. So it's just we want to see your thought process. You get hassled at that moment that they're asking me, so it must be the other one. It's not like that. We're just asking you why you want that and what would be the potential advantage. So if you feel the examiner is offering you a different one, You say, yes, the MR has these advantages, but CT is my workhorse. I normally would be more comfortable. Vascularity is there. I'm more comfortable. Whatever you reason you give, all will be acceptable. But you should not, say an outlandish thing. But by and large, most will be.
Puneet, sometimes you may need to do both.
Yeah, absolutely. You say in some of these, I need both. I might need even PET. So you should have. We are looking at how you're thinking, your thought process. Yeah, you had a question, young man. Sorry, we want the mic because it's online. People won't be able to hear your question.
Finally, for this patient, what surgery will do for this hydrocolongioplasty?
You tell us. That was the whole idea. There is going to be a divided opinion on that. By and large, there's a tendency to do right much more than left because of vascular reasons, because of the propensity of the cholangia to have the right-sided, the entire vasculature is going towards the duct margins.
Sir, here
There's extrahepatic duct available on the left side. For all those reasons, if there's a doubt, right, there is always a tendency to do right more. But we didn't challenge him because his point was of parenchyma conservation, which in this case was possible. So you can do a parenchyma preserving as well. So as far as possible, you can do a parenchyma preserving as well.
I think in
But
this,
sir, I would like
do
to
a
correct
left.
Sir,
Left. The
I
right
would like to
ducts are
correct
not
you, sir. In the
involved.
report, left pedicle was involved. So
But left you have an extrahepatic available, no? So if the right artery is involved and left pedicle, you can do frozen. Or obviously there is what Dr. Ramesh was saying about the transversality of the left hepatic duct. This had a nice transversal, so you can go quite a bit extrahepatic as well into that. So it's the vessels involvement which is more. Or you can do an extended
vessels
right
were
here.
involved, sir. So I thought we may
Yeah,
not
so
conserve
if those vessels are involved, then extended right
Left
would also
hip.
be an
Or
option.
you can do a left.
Extended
and-
left is the worst, is probably
and
one of the worst ones to do.
But you
So-
can do a right hepatic artery ligation, not and non-reconstructed. The Chinese papers have shown that. There are a lot of things you can do.
options available. We want to see what your thought process is going to be. Why you're choosing what you're choosing. Yeah.
In this cholangiogram, there was secondary confluence on the left side was involved. So we need to do left hepatectomy at least. Because
If the secondary,
parenchyma is
if the secondary left is involved, yes, you have to do left. Yes.
If there are no more questions, we'll close this. Thank the faculty. We break for lunch now and we reassemble back here at 2:30 sharp.
No, but they are nervous.
సార్ రాలేదు సార్ అట్లా ఉంది. ఇంకా కొంచెం అడ్జస్ట్ చేయాలి సార్. ఇంకా కొద్దిగా ఇప్పుడు చేసినామైనా మళ్ళీ చేస్తే సరిపోతుంది. చేసినామైనా కొద్దిగా చేస్తే
We can start.
Good afternoon, everyone. My patient is 30-year-old lady, resident of Karimnagar, Telangana, daily laborer by occupation, came to the hospital with chief complaints of upper abdominal distension since 6 months. Abdominal distension was since 6 months, which is insidious and onset and gradually progressive and associated with early satiety. There is no history of loss of appetite, but there is history of significant loss of weight, around 10 kgs in the last 6 months. And there is history of easy fatigability and no history of abdominal pain, no history of vomitings or constipation or diarrhea, no history of hematemesis or melena, no history of fever episodes or jaundice, and no history of swelling in the lower limbs or altered sleep habits. There is no history of OC pills usage, and there is history of exposure to pets, and no history of breathing difficulty, and no history of hemoptysis or bony pains. And there is a history of 1 unit of PRVC transfusion during previous cesarean section 10 years back. And past history, there is history of similar complaints in the past 10 years back in 2012, complaining of abdominal distension without any abdominal pain, diagnosed during first pregnancy. At that time, after the cesarean section, patient was operated for the same after 6 months of cesarean section. And specimen was showed to the attendants, who told that it was arising from the liver. And she has taken, after the surgery, she has taken medication for 2 months after the surgery. And there is history of open appendectomy 15 years back and history of 2 cesarean sections, and no history of diabetes or hypertension or tuberculosis or asthma. Family history, none of the family members are affected by similar complaints. And personal history, she takes mixed diet, bowel, bladder habits are regular, sleep is adequate, no history of any addictions. Menstrual history, she attained menarche at the age of 13 years. Menstrual cycles are regular, 4/30, and 2 cesarean section, 2 children, live children. So, on summarizing my history, 30-year-old lady with no comorbidities, present with the complaints of upper abdominal distension for the past 6 months, with significant loss of weight and early satiety, with no loss of appetite, and history of easy fatigability, and with history of similar complaints in the 10 years back, for which operated 10 years back, and shown and told that lesion was arising from the liver.
Then you can go on to other aspects.
We can't come to one diagnosis. I will tell based on the anatomical.
You can give a broad-based
yes.
thought process.
It can be a lesion arising from the liver, or it can be arising from the retroperitoneum or pancreatic lesions.
Could you try and cast some light on what this previous surgery on the liver was 10 years ago? What would it be? Which, would it be related or
liver, or it can be hemangioma, or it can be any hepatic adenoma during pregnancy time diagnosed.
Looking at the 10 years history, do you think it was malignant or benign?
With most benign.
So if it was benign or something like that,
benign
recurrent, what are the things which come in your mind?
Liver suspecting hydatid cyst, liver hydatid cyst, or liver hemangiomas, large hemangiomas, or hepatic adenomas.
Yeah, I want you to think of conditions which produce a 10 kilo weight loss in 6 months. Is that something you have mentioned? Among the positive findings you have said, interesting points in the history you have said that this distension or the fullness of the abdomen, the absence of pain,
yes, sir,
and the presence of weight loss. Yes. So, when the situation comes like this, did you further investigate the weight loss as to whether the weight loss was associated with
6 months of delivery?
6 months after the delivery, she was operated
Because
and then
during
received.
pregnancy, it is contraindicated.
So the surgery was after the. This process, benign etiology, malignant etiology, connected to each other, all possibilities open. I'm okay with everything.
I'm not sure.
But I need to know what you're thinking at.
Right, exactly.
So you've got all cards on the table. Okay, all fair enough.
On general examination, patient is conscious, core and cooperative, well oriented to time, place, and person. Patient is thin built and poorly nourished, and a height of 154 centimeter, weight of 53 kgs, with a BMI of 22.8, ECG performance status of 1, pale or present, there is no jaundice, no cyanosis, no clubbing, no pale edema, no generalized lymphadenopathy, no signs, no stigmata of chronic liver disease, and vital data pulse rate is 94 per minute and regular rhythm normal character, blood pressure of 100 by 70 millimeters of mercury, and respiratory rate of 20 per minute, and the patient is epiprile. On inspection, there is a generalized abdominal distension and more prominent in the upper abdomen with umbilicus displaced downwards and inverted in shape, and scars present. One is a Mercedes Benz incision present in the upper abdomen, and there is a right lower paraumbilical incision present, and there is infraumbilical midline scar present. And all scars are no cough impulse on the scars, and no all quadrant moving corresponding with the respiration. There is a flank fullness present. No dilated veins, no sinuses, no visible peristalsis, and renal surface are normal. There is no cough impulse and no renal angle fullness. On palpation, there is no local rise of temperature, no tenderness, and there is a duffy consistency of the abdomen, distended abdomen, and there is we can't palpate the hepatosplenomegaly, and no defect in the scars. All scars are healed by primary intention, and renal surfaces are normal. On auscultation, on percussion, we can't exactly delineate the liver span and hepatomegaly because of distension, and there is a fluid thrill is there, sir, in the abdomen. And auscultation, normal bowel sounds are here, and per vaginal examination is normal, and per rectal examination there is a fecal staining, no blood staining, no mass palpable or nodules, sphincter tone was normal. And respiratory cyst examination, bilateral normal air intake present, normal vesicular breath sounds are here, no adventitious sounds. And the CVS normal, S1, S2 here, no murmurs, and CNS is normal, sir. And the spine is normal.
Always good to immediately after that give a summary. Summarize what you've got.
30 years.
You would have lost something that you was important, and our assessment of what you said may be different because we missed out on what you said. It's always good idea to summarize. And don't wait for anybody to tell you to summarize.
I missed the earlier part, but can you tell me what is the educational history of this lady?
Not daily, not educated, sir. The 30-year-old lady with no comorbidity presented with a 6 month history of upper abdominal with a significant loss of weight, early satiety, and no significant loss of appetite, with history of abdominal distension for 10 years back, for which she was operated and on medication for 2 months. And since 6 months, she was complaining of similar complaints. And on examination, patient has pallor, and patient is poorly nourished, and with generalized abdominal distension with duffy consistency, and more of abdominal distension more in the upper abdomen with no hepatosplenomegaly, with Mercedes Benz scar and lower midline and right paraumbilical scar with fluid thrills. Yes, sir.
Unclear about this doughy consistency. Presumably she has 10 societies. That's what you're telling me, right? There's a fluid thrill.
Distension,
so once you have 10 societies, how do you get it? What do you mean by this doughy consistency?
Classically taught that doughy is usually tuberculosis.
Yes.
But, I mean, the way you are describing is more of a.
What do you mean by doughy? Do you know what dough is? Atta, I don't know. No, but that is inconsistent for residents. That's only after your consultant. So doughy, you feel a little give which doesn't go back. Right? So that is classic tubercle, those omental nodules. But when you get fluid, right, which is tense, you're not even feeling liver, you're not feeling spleen. Do you think you're feeling any organ? Are you feeling anything except fluid? Then I would not be
They
sure
don't
that
together.
they don't reconcile.
They don't go together usually.
And in your description of the fluid, you never said free fluid, which was a bit surprising. You said fluid in the abdomen.
He doesn't know it's free fluid. I would give him credit for not saying it's free fluid.
Did you try to elicit?
No, so on standing position, the swelling is still more prominent in the upper abdomen only, and there is some no fullness in the hypogastric region. So it is not looking like a free fluid in the abdomen. Upper abdomen and a flank.
So we'll be very interested in knowing what you're thinking now. Do you want to withdraw the doughy feel or do you want to keep it? Withdrawn?
Did you auscultate that swelling?
No venous sounds, no nothing. Yes.
Once you mention specific names like a doughy feel, they are quite dangerous unless you are absolutely certain about these. Better not to, because what you said, when you put two and two together, it appears like a loculated ascites in the upper abdomen, a tuberculous process. But if that is not what you are hinting, then you have not expressed yourself completely.
Tell us what you feel.
The consensus among all the candidates, this is what you felt, that upper abdomen, there is a swelling. There is a.
Is it the whole abdomen? Or is it? It's almost the complete abdomen. You cannot feel a lower border to the swelling. It's not a well-defined lump. You can't put your fingers in the pelvis and say this is the lower end. Yeah, but you feel the distension is more in the upper abdomen when the patient stands. That is your point.
No comments.
Professor Supe showed me doughy abdomen when I was a student. So tell us what you're saying. Everyone's asking you the same thing. Now, please, otherwise you'll be asked more and more questions you can't answer. So you better tell us what you feel it.
Can be recurrent hydatid cyst. The secondary abdominal.
Giant, huge hydatid. Anything else?
Secondary abdominal hydatidosis.
Anything else?
Any insisted ascites.
Why would you say it's insisted?
No, loculated ascites.
Why would you say it's loculated? Why can't it just be tense ascites and you're just getting a bigger bulge because the muscle tone is poor because of the rooftop or whatever incision?
Yes, it can be ascites.
Hold on. If you are making the diagnosis of peritoneal hydatidosis, then you're finding it that there is prominent bulge in the upper abdomen. It's not consistent. In hydatidosis, you have an abdomen which is can't create a distinction in upper abdomen, lower abdomen.
That's what you feel. It's your impression.
Previously, she had a Mercedes-Benz incision. So probably the primary surgery could be a liver surgery, and based on the recurrent symptoms what she has got now, probable organ of origin would be liver, and my initial would be a benign pathology like a secondary abdominal hydatidosis or a recurrent biliary cystosarcoma. Because first time she might be operated for a hydatidosis, now she might be developing symptoms because of the biliary cystosarcoma.
You explain the fluid around what you were saying.
So she had almost 5 incisions, rooftop incision, Mercedes-Benz incision, and the lower. So because of the incisions, there may be adhesions and formation of a loculated connection.
Is that all you can come up with? Any more differential?
So I'm sorry, but you said that she has 5 incisions?
3 incisions. One was
3 incisions. 3 incisions, one is a cesarean, one is a Mercedes-Benz. What is the third incision? We were told she had one surgery. Appendectomy. Okay, sorry.
Right parameter.
So 3 incisions.
Tell me this is not a pseudomyxoma peritoneum.
Because of the doughy feeling and the loss of
No. Hello.
I think most of them are now operated through laparoscopy. But previously, I think people used to take once in a while Mercedes.
Cannot blame him for the thought process of a surgeon 10 years back. So
does it rule out other things like what we had
No,
said
I will
about
rule out a
rectoperitoneum,
pseudomyxoma
stomach,
We cannot rule.
pancreas? Does it rule out all this?
Cannot rule.
do you seriously think it's a biliary cyst adenoma?
No, sir.
You told us that was your second diagnosis.
Might be a possibility because of the recurrent. Might be a possibility, sir.
Notice. So, how often have you seen a fluid thrill in a biliary cyst adenoma? So, do they usually attain that size without malignant transformation?
Rarely, sir. They rarely.
Could this just be ascites that you're feeling now?
It might be ascites.
Yeah. So, there could have been another etiology, and now you have ascites. So, what etiologies can you think of? And now she has 10 ascites.
Pseudomyxoma peritoneum, that might be a possible.
Right.
Patient is having malignant and hemorrhagic ascites with because of the
Now, why do you think it's ascites due to a tumor?
Tumor.
Where, which tumor?
Not with this history and examinations can't come to one.
No, but likely now
Liver.
since you have this history.
Primary liver and ascites. Maybe a possible.
No tumor and ascites.
Maybe
No, we don't. We are not connecting the two. I can tell you she had blood transfusions 10 years back, got hepatitis B or C, and now has cirrhosis and ascites. Do you think that's a reasonable diagnosis? So why not coming out with these? Why are we just stopping on the and then coming with biliary cyst adenoma? See, so if you see 100 patients like this in your outpatient, we had a very famous teacher called the Balega line. I think this is it's a thing that we were all taught. So you put down each and every diagnosis that you can think of, however wild it might be. And then you draw a line and say that these are the possible ones and these are the less plausible ones. So you come up with the possible ones first and you leave the less plausible ones for lower down. I think that was a...
Yeah, I think this was Dr. Baliga line is very used in our hospital where we used to list the most probable causes and then you have a line. So these are most likely, and many times you can have anything, as you said, it could be stomach, spleen, everything, but they mainly go below the line, most common. So when you are trying to analyze, you should have some possibilities which are likely to fit into this. So as you said, one or two what you said, but now, let's go to the next. What you can really say, what are you going to do now? So you have anything want to add to this?
No, sir.
No, fine.
Now I like to review the whole investigations, what surgery was done, what was the imaging before the surgery, and what medication she was on, and now the complete blood picture because she is anemic.
Knowing that she is illiterate, you don't have any previous investigation. So what will you do now?
Now I would like to get a ultrasound abdomen with a chest X-ray and a complete blood picture, renal function test and liver function.
Have this.
Uh, 18 into 13 into 6 centimeters soft tissue with solid and area surrounded with rim of liver tissue. Impression is a benign lesion and morphological features of mesenchymal hematoma, no evidence of malignant change.
This was about 10 years before, right?
Yes.
Is helping you in any way?
No.
And there a malignant equivalent of a mesenchymal hematoma? Pediatric hepatology, your mesenchymal hematoma and big tumors in children, like highlighted. Undifferentiated embryonal sarcoma. So mesenchymal. So the malignant version is an undifferentiated embryo. 30-year-old possible, but very rare.
Complete picture. Normal. She is anemic. On examination, she is anemic and.
That help you make a diagnosis?
No.
At this moment, I think we're all struggling to want to get to the diagnosis. Maybe all that you ask for, but my question is,
My suggestion is in the exam you quickly. So I want hemogram, renal function test, liver function test, tumor markers, and ultrasound of the abdomen. So that then you're not exposed to questions like this. Yeah, because ideally when you draw blood once, we write everything down. So you obviously want a hepatitis B, hepatitis C, blood transfusion in the past. So all that should come as one sentence.
Liver function test, synthetic function normal, and the enzymes are not elevated, normal. Ultrasound up. Large exophytic heterogeneously hypoechoic lesion with multiple internal septae with internal vascularity extending into the whole of the abdomen and displacing adjacent locoregional structure around 28 in 24 into 12 centimeters. Evidence of similar other morphology lesions scattered in both lobes of the both the lobes. Gallbladder not visualized, lightly compressed. Lymphadenopathy.
Now we'll have to question your clinical finding. Do you think this patient will give you a fluid film?
See, now here we are not seeing the patient. In an examination, patient will be there. So if you say like that, examiners will take you to the patient and they'll ask you, demonstrate me that. And that's the time you will be really exposed. So I think that's the problem in this case.
Even your finding of pallor is suspect. She is pale.
Let's move. What do you want to do next? So now this is your finding.
I would like to further characterize the lesion by the triphasic CECT abdomen.
What are you looking in a CT scan? What is the purpose of doing CT scan in addition to get a diagnosis? Are you looking, what are the facts you're looking into?
One is the better characterization of the lesion with arterial and portal venous phase.
Let me ask you before that, do you think this is the recurrence of the previous kind of an surgery or the excision of nucleation it was done? You think that has recurred back and is the same lesion which has now grown back or recurred? So your theory of that this is a new lesion, is it that? Okay, fine. Sure.
Sir, this lesion still can well be a recurrence of the previous lesion, but again, it's just 10 years and the lesion is more than twice the size that it was previously. And it might again well be another non-related lesion.
Could we have malignant change into that lesion?
Quite possible, sir, if it was not removed completely.
Just anything else you want to really add, the member?
Just one question. Are hematomas known to behave in this way? Undergo malignant transformation after excision?
No, sir. Sir,
were you willing to entertain that possibility?
Sir, if it is some residual disease which is present there, we don't know, sir.
That's what I'm asking you. The surgical excision, even if there is some residual disease, are hematomas known to follow malignant transformation?
No, sir.
Then why are you willing to entertain that possibility? You have to have your conviction straight. It happens or it doesn't happen. I might shoot you a lot of possibilities to put you in. You walk into the trap.
So we would like to see the CCT abdomen.
You like to read it? Just show her the plane and arterial phase and one by one.
This is the axial cut non-contrast CT of the abdomen, showing a clear chest, no lesion in the cut sections of the lungs with no pleural effusion. In the abdominal cuts, we can see a large liver and no gross collection in the abdomen that I can make out, sir. It is a heterogeneous lesion, and I would need to see more pictures. Yes. Sir, this is the liver with the middle hepatic vein, the right and the left lobes, and this is the heterogeneous lesion, sir. I cannot make the boundary. Apparently, this seems to be the whole lesion, but I cannot make out the boundary of the lesion, sir.
Can you see the
Can you
difference
see the
between-
characteristics?
yeah,
huh?
between the plane and the contrast? What is striking?
Sir, it is a heterogeneous lesion with traversing septa, which are there, few septa which we can see in between, and it is crossing the segmental anatomy.
See the cuts below that. How would you
What is
describe
that?
that sort of vascular enhancement?
Sir, the contrast enhancement is there, sir.
What is it called as?
Pattern?
It is the
What are we saying?
Characteristic of,
Peripheral nodular enhancement, sir.
what's that characteristic of?
The hemangioma.
So which phase is good for diagnosing hemangioma? What is the real CT picture of a hemangioma versus a hepatocellular carcinoma or other lesions? How do you differentiate on a CT scan? What happens in the first phase? What happens in venous phase? Are you aware of all that?
Hemangioma is a classical feature of the blood pooling. Every phase is the
What
same
link is the
intensity. The same intensity every phase.
Hemangiomas are more you
The
see,
late arterial phase.
late arterial or late phases you find still the contrast is still there. While in a HCC it is a rapid washout. So use these words while describing.
Even portal venous phase continuous enhancement is there.
You have more images of this, or this is all we have? Yeah, you have to keep progressing. So every
phase
sequential until it completely fills up on a delayed phase, which might even be 10 or 15 minutes.
The centripetal fillings.
You have more. Do you have any later phases, or is this it?
Delay phase. Delay
Because
phase.
obviously the CT is not being done at your institute, so are there any more plates? Because often they won't be. So these are the only plates.
Could you
These
comment?
are the only cuts we
Could you comment on which part of the liver is affected and which is the normal liver? Is it possible or is it not possible in these images?
Mostly there is a right lobe is available. Left lobe is slightly visible.
And the left lobe is normal?
The left lobe is only segment 2 or segment 3. Might be.
Go above.
What is it? What does the left lobe show? Whatever left lobe remnant you are seeing, is it normal or is it also show something else?
The multiple lesion there is also.
Are they
The left
hemangiomas?
lobe. Is it
Forgive you if you say they're too small to characterize. But
Yeah.
you must
Yes, sir.
answer quickly.
I was going to say
Yes,
that, except that one alone has got some
Just here, there.
contrast pooling.
Now what do you want to do?
Yeah.
There's an enucleation of the hemangioma.
Now what do you want to do?
It's
Happy with the
probably the giant hemangioma.
Happy with the diagnosis? Enough information.
The exophytic, along with the exophytic component.
Plus numerous hypodense lesions in the
left lobe. Now what do you want? Happy with the information? You want more imaging? This is all we have, sir. So I think there is not much.
So you would like to know the arterial supply of this, no?
Yes.
Because
The
you
hepatic.
want to see whether you want to.
You also want what's happening in the left lobe.
Yes, sir.
So now what do you want? Repeat the CT, any other imaging, operate directly, don't do anything.
There's a recurrent hemangioma with multi-operative history. So we just plan for the medical or conservative management at
In
present.
a 30-year-old
Why?
who's lost
Why?
15 kilos of weight,
30.
what medical management can you offer her? What do you think is a benign condition?
So even more importantly, the symptomatology that she has. You think conservative treatment has got some role in that?
On one hand, you said it's a giant hemangioma, right? Plus, she has all symptoms. Don't you think we should do something rather than just living alone? What are the options you have?
Have you looked at the
Go
platelet
for-
count? Has to be delivered.
Then if
The first question, are you happy with the information you have? Or do you require
Like to
any
do
more
anything more?
information before you intervene? If we stop investigating when we are happy with the information we have.
we see the exact volume of the left lobe is available or not, sir. If we are planning for the
Are you interested? What is the principle of surgery for you? Are you going to do an anatomical hepatectomy in this? You plan to remove too much normal liver? What is the surgery you do for hemangioma?
this is mostly non-anatomical resection, sir. Anatomical or non-anatomical. Denucleation is mostly about.
Okay? So liver volume is not your primary concern.
Yes, sir.
What is your primary concern?
The artery supplies. In this patient, even I will plan for the test, the preoperatively.
Test?
It is a tear, the embolization,
not-
embolization, not a test.
Why would you want to? No, this is a very interesting
Yes.
concept which I've heard from a lot of students. How will this help a hemangioma?
Decrease the size of the hemangioma, the hepatic artery embolization.
Will it really reduce?
Why do you think it will reduce? Your contention of embolizing it, uncertainty, actually not going to help. But why? What is the reason?
There is multiple collaterals also there.
There are multiple sources of blood supply to this
Multiple
hemangioma
collaterals
rather than
also
one
there.
single artery. Right? That's why even if you embolize one, the collateral circulation will continue from the other side. Nothing done. If that is the one,
CT
if that is the
angiography.
situation,
Exactly. No, no.
So that's the
Ramesh,
best way to
that's
do it.
angiography
exactly we
is
would
for
like to
CT.
do CT angiography.
CT angiography.
We know what is
Kind
the
of.
prominent
Arterial
artery. If so, we will do it. If it is not
CT
so, we will
angiography.
not do it. But I don't know, many times we'll do it, but many times you'll find while doing surgeries at embolization may not be of a great help, because on table you will find it is coming from multi, and ultimately you'll have to go in that proper plane, meticulously you will have to go through.
Which it also depends upon what is the time lag between the embolization and
Just before the 48 hours to 72 hours,
very
only
rapidly
before
coincides.
surgery.
A hemangioma, even if it weighs 10 kilos, never invades the porta.
Yes.
There is no way you can't clamp a right or left hepatic artery in these patients. You're wasting time and you're wasting the patient's money. And with any embolization, you get inflammation. It sticks to the diaphragm, and then you go through hell trying to peel it off. So embolizations are the last thing you want to do for any.
Yeah, you have to do
24 to 48 hours.
Right? I think the invigilators are giving you a clue now. What do you think they've put up?
Arterial phase.
Of what? What is this?
What investigation is this?
This is MRI injury.
How do you think it's helping you?
It is same T1 weighted image with contrast surgery.
Why do you think it's been done?
Can we have your last colleague to itching to say something?
Please, go ahead, go ahead.
To know the vascular structure surrounding the lesion while resection, we can plan the resection plane according to the vascular pattern.
Any other advantages to the MR?
And other lesions also will
So-
be
so
well
what- So, do you want to see any more phases of the MR? What other phases do you want to see? No, this is just the enhancement pattern. T1, T2 will tell you a lot. Do we have that, or it's? Can you make it a bit smaller and go down? What is telling you about the left lobe? So can you then answer the question of what is in the left lobe?
Multiple.
What?
imagine-
These cysts, what are they?
Hemangiomas.
They're also hemangiomas. Now you know that there are multiple hemangiomas also. Those
Mostly you are not going to do anything to them.
Yeah, but you know that they're there. That's right. So you have the information that you need.
Can I add one comment? This case mostly not looking like hemangioma. I still feel it is MHL. MHL means mesenchymal hematoma of the liver. We have experience of 3 cases. So these, if you see this MRI, I can strongly say this is MHL because they present cystic changes. So that cystic changes is due to biliary cyst. So that is why if you see the T2 weighted image, the right side which is showing like a bile duct, left side it is not showing. So previous history of hematoma, which was incompletely done, so that must have been recurred. So MHL is more predominantly will have a cystic component. This is my feeling. It's not looking like hemangioma.
So just the vascular enhancement pattern with that cloudy is rare because in MHL it's the septae in between.
No. It's not like that. It's not like a biliary cysternoma. It is a hematoma.
No, but
It
you
will
get
have a-
septae. So take septae, which enhance. So you don't usually get this cloudy which increases between arterial venous late to fill the whole lesion.
See in that right side of the liver, in T2 weighted image, like MRCP images, bile ducts will be bright. So same images like that. That is a clear classical feature of MHL.
Anything? We are already beyond time. So Piyush, you want to add anything or Shastri?
I still feel it's hemangioma, but I'm happy to be proven wrong.
Has this been treated, the patient? Do we have an answer?
No, sir. MHL, there are different treatment is they prone for rupture, circulatory problems. So they has to be resected. If not resected, transplant is also described. So these MHLs are very common in pediatrics, sir. After hepatoblastoma, second commonest indication for a liver transplant in children is, other than hepatoblastoma, is MHL only, where it is occupying entire liver, like this case. I feel because left side segment 2-3 is having a small cyst, I can give a option of right extended hepatectomy plus or minus IVC resection and wait, or we can give an option of liver transplantation because she is a young fellow, 35 years. Yeah, we should give it, sir. We should give it.
Last question: when you open the patient, will you know whether it's an MHL or hemangioma?
Yeah, we can know.
For the students, would you
Sir.
like to? Who would like to answer it?
Sir, grossly also, if we'll see the lesion will be more maroonish and a bit different. And secondly, if we'll clamp the right hepatic artery.
All you have to do is press it. When you leave your hand, it will just slowly fill up. An MHL, you'll not be able to press or lift it in.
Go on to the caption.
So hemangioma, if you can enucleate it, will be nice. It would be difficult to do. Difficult to do.
Feeling when you compress the hemangioma, it will go down and slowly fill up.
You withdrew the doughy field. No, you kept the fluid still and withdrew the doughy field. You should have done it the other way around.
And how do you explain thrill now in this? The thrill is still unexplained.
You chose the wrong one to take back. If you had kept the doughy field and withdrawn the fluid
I
still,
congratulate
you'd have respected
your group for being so spicy because it is a good thing.
Good one to hear.
One strong point is in favor of hematoma is the previous histology. I think that would, instead of thinking two diagnoses, I think hematoma, recurrent hematoma would be a more plausible diagnosis here. So I think she should be assessed for a right hepatectomy. Because he recurred already.
Why not?
See, that must have.
About 70 more in the liver, sir. It's going to recur whatever you do.
Exactly. I mean, what I'm saying, why not ask her for transplant at this particular? Maybe because see, whatever exercise you're going to do with, say, bottles of blood, again is going to recur after 10 years or something.
Why not?
Yes. If the whole experts agree, yes. This is not a very common indication, but with the group of experts who put on the
To be
list,
honest, sir,
yes.
I think if you look at a 5-year survival, you're far more likely to live with a resection than a transplant in this patient. So, yeah. So I would have transplant as the absolute last resort. Someone with normal liver function and someone else's life will be saved because the cadaver will be more useful for.
Can we go to the case capsule?
Yes, sir.
So, 58 years old male, resident of West Bengal, working as a businessman, came with chief complaints of vague abdominal discomfort since 4 months. So on history, a patient was apparently asymptomatic 4 months back when he had developed vague abdominal discomfort in epigastric region, which is insidious in onset, gradually progressing in nature and not associated with any meals or any other aggravating or relieving factors. History of loss of weight of around 2 to 3 kgs in past 1 month associated with loss of appetite. There is no history of vomiting, jaundice, fever, no history of altered bowel habits, no history of GI bleed, no history of breathlessness, hemoptysis, seizures, or any bone pains, no previous blood transfusions and prodromal symptoms. Past history, there is no history of similar complaints, known hypertensive on medication, and no other significant comorbidities. Personal history is normal, takes mixed diet, is a known smoker with 3 to 4 cigarettes per day for 9 years, stopped 4 months back. Patient also takes alcohol occasionally. Family history not contributory. On general examination, is moderately built and nourished, ECOG 0, breath holding time 30 seconds, BMI of 23.8, vitals are stable, there is no pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy, no palpable supraclavicular lymph node or axillary lymphadenopathy, no signs of liver failure, and skin and spine are normal. On systemic examination, inspection, abdomen is flat and umbilicus is central inverted, all quadrants moving equally, no visible lumps, sinuses, engorged veins or pulsations or peristalsis, hernial orifices are normal, no renal angle fullness, palpation abdomen is soft and non-tender, liver and spleen not palpable, no other palpable lumps, hernial sites normal. On percussion, liver dullness starting from 5th intercostal space, liver span 13 centimeters, epigastrium, umbilical and right upper lumbar quadrants or tympanic nodes, no free fluid. On auscultation, normal bowel sounds heard. Rest of the systemic examination is normal.
Yes. Again, we come back to the same question of abdominal discomfort. So, what is your thoughts on this? Fine. So, you want only investigations to be discussed? So, what investigation you would like to do in a case?
58-year-old man, abdominal discomfort. What comes to your mind and what do you want? Give us 3 differential diagnoses that you're considering and then move on to whatever investigations you want.
DD could be a pancreatic indication.
Pancreas what? Pancreas.
Okay, tell us what you want to do to get the differential diagnosis. If you have something in mind, it's easier to focus on the investigation and do a better job. If you don't have anything in mind, then you can start with an ultrasound. So you can start with an ultrasound.
Or any lesion from the left lobe of the liver.
Why left lobe? Okay, sorry, I'm not allowed to ask you that question. Go ahead. Okay, so what do you want to do? You want to do an ultrasound? Ultrasound, because you don't have any differential diagnosis, you don't know anything. The simplest investigation to do is an ultrasound. If you do a CT, somebody will murder you for doing it. You might as well do an ultrasound. Simplest.
Hello, Piyush. He got
PET
it
CT.
wrong.
You want to do a PET CT?
What is the complaint of the patient? Vague upper abdominal epigastric, uneasiness. That's the complaint, isn't it?
This was an IASG exam. They would set up a J endoscopy.
Must it necessarily be localized to the left lobe of the liver?
There is.
Solid hypoechoic mass, right?
Solid hypoechoic mass lesion in the right lobe in segment 7 and 8 of 9.7 into 8.36 centimeter with increased vascularity on color Doppler. No ISB or dilatation or CT.
What is your differential diagnosis? Your mind.
To all the solid liver lesions that you can see, 1, 2, 3, 4. Come on.
Hepatocellular adenoma,
1,
focal nodular hyperplasia,
2.
or could be any hepatic malignant lesions.
Which malignant lesion?
It could be a secondary malignant lesion.
Metastasis 3 and primary.
Yes, sir. But there is no echo texture is normal and there is no cirrhotic.
So what is the incidence of HCC in a non-cirrhotic liver?
You said, but the echo texture is normal. How does it rule out the other thing?
No, sir.
You are using this statement, but the echo texture is normal. That means the normal echo texture is ruled out.
Less likely. Sir.
No. It says the parenchymal echo texture is increased.
Increased.
Normal or decreased? Increased. What is the significance of that?
Fatty liver.
It's possibly a fatty liver, and so the hypoechoic mass can be one of. Can it be hemangioma? Can it be hemangioma?
It will be hyperechoic on ultrasound.
So less likely. So
Yes, and benign hepatic lesions. Less likely.
Fine. What next?
We'll do the I proceed with the CECT abdomen. Off.
Do exactly what you suggest. Show him the contrast CT.
Coming on, you'll need blood tests, you need a creatinine. Do you want any other tests with that?
For ensuring the renal function test is
Will you do any markers at this stage?
You're collecting blood from the patient. No, they don't like it having collected 3 times.
Liver function test you want?
Liver function test and
CBC.
protein also.
Viral markers.
Yes.
There is a non-contrast axial CT scan. This just scroll it up. Up.
You want to waste time on your non-contrast? Are you going to find anything contributory?
There is a hypodense lesion in the.
Yeah, but then.
Okay.
In proceed
in the right lobe. In the right lobe.
Some more valuable.
What other things did you want to see in the brain?
There is no free fluid space. No calcification, no free. Display. Yes.
Compared to the contour of the liver, is for it to
yes.
That you could say the brain.
Go to the contrast.
This is a arterial phase. There is a heterogeneous enhancement. A complete arterial enhancement is present. Sir. Non-dream arterial enhancement is there. Right-sided hydronephrosis is also there, sir.
It's a renal cyst.
Renal cyst.
Venous
So
space.
total venous space, sir. The delay washout, the early washout is there with rim enhancements also there.
Say
With
early
excellent-
washout or delayed washout?
Early
You use
washout,
both the words. Huh?
the early washout with rim enhancement is there, capsular enhancement. The HCC, sir.
Go ahead, you not finish the venous.
The release,
What key information are you looking for?
the portal veins also. Portal vein, please. There is no other lesion in the liver, or the lesion is there.
So just a small question. Venous phase is what? You're talking about portal venous phase or hepatic venous phase?
The portal venous phase.
What is the venous phase described in SCC for diagnosis? You're talking about washout, no? Which phase it is described?
The portal venous phase, sir. The delay.
Portal, there are two phases to what is being mentioned, portal phase and venous phase. Where do you expect the washout in HCC?
The early washout is the portal venous phase. The portal vein, the right portal vein is normal. There is no thrombosis in the right portal vein.
What are the features on the CT scan which will tell you that you cannot resect or transplant this patient?
Sir?
What are the features on a CT scan which will tell you you cannot resect or transplant this patient? Are there any, and what are they?
There is
Presence of extra abdominal metastasis.
One.
Liver metastasis.
Extra hepatic.
Extra hepatic
Okay.
metastasis. Presence of ascites that, and associated lymph nodes. Lymph nodes and tumor thrombus in the
Where?
portal vein, and even
Which
IVC.
part of the portal?
Main portal vein.
Main portal. Supposing it is in the segmental, what would you?
We can go for resection.
You can go for resection. Would you go for transplant? A difficult question. Anyway, we can discuss that later on. Anything else you're looking for? UCSF? Would you for
Sorry, Milan criteria. More than Milan criteria.
Milan for what? What are you telling me for?
Sir, for transplant.
For transplant. So you can choose your criteria, whatever it is. So you have to see it's within criteria. But if it's resectable, do you want to consider transplant for this?
No.
Otherwise, which case would you choose for resection and which case would you choose for transplantation?
It will depend more on if it is
General condition as in
sir,
comorbid illness?
He's a fit 50-year-old. He will be eligible for resection and transplant. He's a multimillionaire. He's got 17 brothers willing to donate for him.
Sir, his baseline liver function, sir, and the background of CA. Patient has a background of texture, and if he is transplantable,
So on this
then-
CT, what are you going to look for which will tell you there's background CLD, which will make resection difficult?
Sir, it will be a macronodular cirrhosis, if you can say.
Are you going to see that very easily on CT? Even if there's micronodular cirrhosis, you may not want to resect him. What
Caudate
other
hypertrophy is there? Caudate hypertrophy.
caudate hypertrophy, is that enough to tell you I cannot resect? You can't resect cirrhotic livers?
We can.
So what will tell you that a cirrhotic liver is dangerous to resect?
Portal hypertension.
So how will you see portal hypertension on CT? There's no
Multiple
pressure
collaterals
measurement.
are
So
multiple
multiple collaterals and
collaterals.
splenomegaly. Yeah. So simple question, simple answer. Volume.
Volume also. Do you think this patient can be with all these points? Can we know what are points?
Yes, sir, the patient can be resected.
Not see anything.
Yes, sir. There is no portal hypertension,
Liver
no
looks
ascites, no
not-
other collaterals which are
Is this liver patient has a fatty liver?
looks like that.
That will have to confirm.
Yes. Sir, the volumetry that we'll get, the FLR might not be good enough with the CT to find. We might have to go for an ICG study to look for the functional.
You will have to keep a higher volume which is residual. Don't go at 30, 35, then you have to go for a
40%.
higher. That's the difference.
For number and size, performance test, all thing. What is the staging system used to decide management of HCC?
BCLC criteria.
You not told that, no?
So, sir, the basic for the BCLC criteria as of again the baseline characteristics of the liver and of the patient performance.
No,
These two
it is child C. Let us say child C. How does it impact on the BCLC staging?
The patient is child free, then it is then the patient is out of the transplant.
So whatever criteria you see in CT, it is not applicable. No, that's why the staging system is there. Okay, so you should come out that my.
I think the point is valid that if you're not seeing ascites, you're not seeing collaterals. I would be amazed if this patient was child C.
Have we made time?
Or are we over? Are we over? We have the biochemist.
They asked for investigations. The point I was asking you was after the ultrasound, CT and LFT would have been important. If the LFT had been abnormal, either way the path would have been different. Any final comments based on the LFT? In correlation with the TT?
Child A, if at all, is cirrhotic. We don't know whether it's cirrhotic.
Platelet
Based on
count?
this. Platelet count is, I think, 1. Okay. Little low, but. Any other questions anybody wants to clarify from the other students?
That's the best option.
Currently, yes. No, I thought you were just asking them. So why would you
Okay.
have- Yes. They have already decided. No, no. They already resected it. So fine. I think the examination, if you say with all this, because there's no other factors, the resection is our first choice, I think it is accepted.
Actually, if you're on a good CT, if you don't see collaterals, you may not even need an endoscopy. To be honest, sir, with the presence of a 9 centimeter lesion, this SGOT, SGPT may not be unexpected. So,
I have difference of opinion. See, this is a right appendectomy, correct? So, as sir was telling, we are not sure about the quality of people on the left. Volumetry not done. Okay, we don't have the information. So, straight away deciding for right appendectomy, I will be little bit susceptible in this, especially in child eye. So, liver, we have altered acquisitions here. Enzymes are not normal. Okay. Yes, yes, sir.
posterior sectionectomy is the correct operation.
You may not do trisectomy. You will just do a posterior sectionectomy. May not really compromise a lot of your liver residue.
Non-anatomical for HCC is not an exam answer. Please don't give it. Yeah, across the world, it's not an accepted option.
Posterior sectionectomy will be better. Anyway. He said that.
I don't know your name, but if the liver function tests were like this, the ICG is going to be normal. No, that's not what she was talking about.
No, but what I'm saying is the ICG can be useful more by giving it 3 days before and then lighting up the tumor on the table.
That's what Rajan said.
And then you can excise it precisely with a non-anatomical resection.
So you still want a segment anatomical resection because of microthrombi and the portal vein branches. Your aim should always be anatomical.
No, but if it is
out of
cirrhotic,
desperate situation, you can't do it. That's a different issue.
that's a different issue. Yeah.
Yeah. Is it okay? We close. Thank you. Thank you, sir.
So for the next session, we'd like to invite the Dr. Ashok Kumar, Dr. Narayan Rao, Dr. Venkat Rami Reddy, Dr. Chetan Kantharia, Dr. Madhusudan, and Dr. Puneet Dhar.
Can I start? Evening, sir. My patient is a 65 years lady. She is a resident from Anantapuram. She is a housewife. Presented with chief complaints of pain while defecation since 2 months and intermittent bleeding per rectum since 2 months. History of present illness, she was apparently asymptomatic 2 months back and she started to have the hard stools once a day, following which she developed the perianal pain. And she experienced the pain after each defecation. She also gave history of bleeding per rectum, which was bright red, and 2 to 3 drops after passing stools. And that bleeding per rectum was it is separate from the stools. And there is no history of perianal discharge, mucoid stools, and there is no history of alternate constipation or diarrhea. There is no history of mass per rectum. There is no history of urgency, tenesmus, or incontinence or spurious diarrhea. There is no history of abdominal pain, abdominal distension, nausea, vomiting, and there is no history of postural dizziness, syncopal attacks. There is no history of easy fatigability or shortness of breath. And there is no history of blood transfusions, and there is no history of loss of weight or loss of appetite, and there is no history of jaundice, respiratory distress, or back or bone pain. With these symptoms, she was initially evaluated in her local hospital, and she was advised some medication, and she was examined, and she was referred to higher center for further management. Here, she was evaluated, and she was evaluated with scopy and biopsy.
What is just based on the history? What do you make out from the history?
Sir, she is a 65
Can you summarize the history?
65 years lady presented with the 2 months history of pain while defecation and with history of bleeding per rectum, which is 2 to 3 drops after defecation separate from the stools. And apart from that, there is no other history.
So what do you make out from this history? Based on the history, what do you think the patient is suffering from? What are the possibilities? Patient has only 2 symptoms: bleeding, PR, and pain for last 2 months.
Yes.
What is the the differential diagnosis, or what do you think the patient is suffering
Sir,
from?
I am suspecting the benign perianal pathology, the most likely chronic fissure in ano, or another thing is thrombosed external hemorrhoid.
Again?
Based on this. thrombosed external hemorrhoid.
So you feel it's a benign pathology. So what in history supports that it is a benign pathology? What in history tells you that this is benign?
Sir, even though it is short duration, the 2-month history. but-
Short duration means benign.
No, sir.
Then second,
perianal pain, painful defecation, sir. And, history of bleeding per rectum, that is very 2 to 3 drops. That is only after passing the stool. That is separate from the stool. Apart from that, there is no other history.
so in a benign pathology, say for example, you said hemorrhoids. What did you say? Fissure.
Chronic fissure in ano.
So in chronic fissure in ano, what is the bleeding pattern?
Bleeding pattern, bleeding will be separate from the stool, sir. It will start after. Yes, sir. It will be like drops, or it will be separate from the stool after the post defecation, and it will follow by the
No,
patient.
no,
will have
you are giving totally wrong things. So the causes of, you see, the cause of bleeding in young patient, in a child and elderly patient, all would have a different causes at different point of time. Then the second question is the bleeding. Bleeding could be obviously the fresh bleeding, hematochezia or melanage we discussed in the previous cases. So, and then in addition to that, patient may have other associated symptoms. And you said that the bleeding in fissure in ano would be fresh bleeding and drop never fissure, because the fissure, you see, always the crack into the mucosa of the anal canal, and that lead to not a drop of bleeding, but mainly the bleeding at the stick at the surface of the stool. The bleeding, fresh bleeding before or after act of defecation, and could be because of pain, or it could be that without pain, and because of it may be because of associated symptoms like mucus, diarrhea, constipation. That will explain the various pathology at different age of point of time. So as you mentioned, the bleeding in the fissure would be never fresh drop bleeding. It is always on the surface of the stool, usually at the act of defecation, and pain may persist several afters, even after the defecation. So if you should be taking the history very properly. If the patient say stool mixed with blood, blood mixed with the stool, but and if the bleeding comes before, usually after the act of defecation, or before, usually painless bleeding in hemorrhoids. So you should be very clear of what you are describing.
If you have a 65-year-old female, short duration, bleeding PR, which comes at the end of the stool, what should be the first thing an elderly female that should come to your mind? Would it be a benign pathology, or you would keep something else in mind first?
Think of carcinoma rectum, sir, malignancy first. In this patient, she typically gave history of passing the hard stools, followed by she developed the perianal pain, defecation, and followed by she developed the. Yes, sir.
So I have to keep malignancy in mind, or so you don't be dogmatic, say that it's a benign pathology, just that. If you are feels very strongly that it's benign, still at this age you say that I would keep malignancy in mind.
Yes, sir. I will keep
One more
I
thing.
can guarantee you, if you had said malignancy, we would have said, why don't you think it's benign?
No.
So there is going to be this issue. So best way is to ride the horse, that it's, the whole history is very suggestive of a benign process, but I would like to rule out benign. Then you are untouchable.
One more thing also I'd like to clarify. You said the thrombosed external hemorrhoids. Thrombosed external hemorrhoids will never have this type of history of bleeding. Okay. Thrombosed external hemorrhoids, a painful disease. Many times acute painful. Patient also feels a lump. Lump will be one of the features.
Bleeding is not there. Bleeding is
thrombosed external
internal.
piles
Yeah.
is never
It's a
dead
perianal
disable
hematoma.
history. Fissure, hemorrhoids, malignancy, everything can fit into the history, but not thrombosed external.
So go ahead. Yeah.
With these above symptoms, she was initially evaluated local hospital and referred to high center for further management. And she was evaluated here with colonoscopy and biopsy was done and imaging, for which she said.
I will stop you here. Like you have started with benign disease. why one will do colonoscopy and biopsy for benign disease?
That's right, sir.
I mean, if they suppose that if it is a hemorrhoid or maybe fissure or maybe fistula or maybe anything. So for these things, the colonoscopy and biopsy would never be done the first line of investigation unless somebody thinks the pathology different from all these possibility. Otherwise, for this, a small investigation, a proctoscopy suffice and pernatal examination itself is sufficient in majority of patients, except in a small group of patients.
When you are presenting a history in exam, you have taken the complete history, you have come to a probable diagnosis, you know all this. In spite of that, if you give your differential as benign, then it's not part.
I think he said it based on
the history, yeah.
Because
But
we stopped him
but
there,
at the same
he
time,
said
you have to
based
be
on
smart enough to say that I would still keep malignancy in mind.
For this patient is malignant.
Okay. So now go ahead with examination. So now go ahead with it.
Shall I complete?
Yeah. So she was assessed and they have taken biopsy and done some imaging. No?
That she received the radiotherapy and that was.
That will come to later. Okay. Now tell us examination part.
General physical examination, she was conscious, cooperative oriented, and she was moderately built and well nourished. And ECOG performance status was 1, and her pulse rate was 86 per minute, and blood pressure was 110 by 80 millimeters of mercury, and respiratory rate was 14 per minute, and she is afebrile. And where her weight was 74 kgs and height was 154 centimeters, and BMI was 31.2 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and there is no supraclavicular lymphadenopathy. Coming to the abdominal examination, abdominal is flat, umbilicus central inverted, anal quadrant moving equally with respiration, no visible lumps, sinuses or engorged veins or pulsations or peristalsis. There is 4 scars of the previous laparoscopic cholecystectomy healed by primary intention, and there is one phalansteal scar healed by primary intention. Hernial orifices were normal and no renal angle fullness. Coming to the palpation, abdomen is soft, non-tender, there is no local rise of temperature, and liver is palpable 3 centimeters below the costal margin at the mid-clavicular line and 4 centimeters below the critic sternum in the epigastric region. And the liver was smooth surface and round borders and regular borders, and it was non-tender. Spleen is not palpable and no other lumps palpable. The liver span is 16 centimeters in the mid-clavicular line, no free fluid in the abdomen, and auscultation, no normal bowel sounds heard all over the abdomen, and renal angles and hernial orifice normal, and back and spine examination was normal. To the distal rectal examination and proctoscopy, perianal skin was normal, skin tags are present, and anal resting tone and speech was normal. And there is an proliferative growth of around 4 into 3 centimeters, approximately 5 centimeters from the approximate size, 5 centimeters from the anal verge, in the posterior wall of the rectum, extending from the 5 o'clock to 7 o'clock position. And the longitudinal extent, the upper border of the growth was palpable. It is about the 8 centimeters above the anal verge. Love finger stain normal and 5 to 8 centimeters extent, longitudinal extent. No, sir.
Swelling at 8 centimeters. Is that correct? There's some mathematical challenge.
Tumor is 5 centimeters from the anal verge, sir.
Yeah. Starting from 5 centimeters and it's extending from 5 to 8 centimeters.
Yes.
Oh, is it only 3 centimeters?
So it is 3 centimeters.
So just read what you started out. So you should be very clear. So either you give the dimension of the tumor first or you give the location first. But you are projecting a graph or coordinates on the examiner's brain. Very carefully.
DRE examination is very important. Certain points have to be cleared very. So one is from what length it is from the.
It is approximately 4 into 3 centimeters, sir. Starting from the 5 centimeters from the anal verge, extending up to the 8 centimeters.
So it's 3 centimeters. Okay, one. So second, what other thing you want to convey on DRE?
The posterior located, sir.
So another way of putting it, it's extending from 5 to 8 centimeters from the anal verge.
Right.
It becomes clearer, isn't it?
Yeah.
So when you say 4 by 3, now we don't know what dimension you're talking about. You get the So the clarity should be there in
Second,
Only fixity, sir. It's not fixed. And,
third, that it's only involving the posterior wall, not circumferential involved.
So I will let you know how to do a rectal examination. What you have given 8 centimeter from anal wall, very difficult to reach the index finger up to 8 centimeter from anal vector for individual. Hardly 6 centimeter or 7 centimeters. Whether you were telling a PR finding or you were telling a colonoscopic finding, I doubt. Number one. Number two, so suppose that you are examining a patient in lithotomy. So the interior would be 12 o'clock, the posterior would be 6 o'clock, and 9 o'clock would be in the patient right, and then 3 o'clock would be patient left. So if you describe the length extending from, you were absolutely right, extending from 5 centimeter, distally, and then go proximally up to 8 centimeter. So its finger is very difficult, but suppose that I accept, then you should describe the growth is extending from maybe 3 o'clock to 9 o'clock,
Yeah, 5 to
3
7.
o'clock.
He said 5 to 7.
So
5 o'clock.
quadrant, if you divide a quadrant, 4 quadrant, that would be clarified. It is the posterior right, posterior left, anterior right, anterior left. So that clarifies the posterior wall is involved or interior involved and how much is involved. And then obviously the ulcerative proliferative stricturing, polypoid, it's the finger touch with bleeding or not, fixating to the mucosa, whether it's mobile or not, this all will help you the involvement of the sphincter, extent of the length, interior wall, posterior wall.
So, okay, so now we come to the next. So what is your diagnosis now? If the DRE examination is done, na? Anything else you want to convey on examination?
Finger stall?
No, sir. Finger stain, the normal color.
So, okay, give me your diagnosis. How will you give your diagnosis? What is your diagnosis at the end of examination? Clinical examine this patient, you have got the history and clinical examination. What is your diagnosis? And she has received radiotherapy. So how will you give your diagnosis?
PPT on.
What is the second differential before we go? First differential is CA rectum. Second differential? She has biopsy has been taken. She has received radiation. So where is the question of differential? So what is your diagnosis? So give us complete diagnosis. How will you?
Status post.
Post. You have to give complete diagnosis. Give us complete diagnosis.
Lower third of the rectum.
With no clinical evidence, so my diagnosis is CA rectum, lower third, post radiation status, with no clinical evidence of metastasis. However, patient has hepatomegaly, I would like to
Rule out fatty liver.
Okay, so what investigations would you do now? Means already, what next would you do? This patient has come to you now. What will you do? It's already confirmed. So what will you do now? How will you proceed? What all imagings do you think must have been done?
Done before starting radiotherapy.
And what else?
This patient comes without any history of radiation or diagnosis. It's a virgin case. What you will do the first line of investigation? A case of carcinoma rectum clinically suspect.
Must take proctoscopic biopsy.
Yes, you do the biopsy. Then
Okay,
After
then-
that, prepare for colonoscopy. So just say colonoscopy. No, why do you have to say prepare?
Colonoscopy. Okay.
Why
Why you want to do colonoscopy? You already have taken a biopsy.
Much percentage? 10%.
Oops. Synchronous plus metachronous.
So colonoscopy. Next. Okay, next. Then
You've not done anything to look for metastasis.
what next investigation?
I have not done anything to rule out metastasis other than simple ultrasound.
You have to just rattle out.
Not rules out.
What next investigation?
That's what.
Is MRI pelvis always a must? You have got a good CECT scan. Is MRI pelvis always a must for lower rectum?
Are there any conditions? So his question is very clear. You rattled it off. So is there any way that you would have, for instance, if you found mets on ultrasound, you would not do MRI pelvis? So that's one example. Are there any other examples that you can stop with CT and not do an MRI pelvis? MRI is basically done for a certain particular segment, no, which is probably the commonest in India. So it would be standard of care for most. But is there anyone which you will not do it?
So what additional information does MRI give you for lower third rectum?
From the location of the longitudinal extent of the tumor, involvement of the sphincter and levator, involvement of the fascia, involvement of vasorectal. Also, we can put extra mural venous involvement.
Most important thing, MRI in pelvis in a lower 1/3 rectomy. If at all you are planning to contemplate sphincter preservation
So
surgery,
basically
you need to know exactly the levator ana involvement, sphincter, internal extent.
So your
because MRI gives classification of lower 1/3 rectum, juxta, transphincteric, like that. Okay.
So your answer should be yes. I will do a MRI for all lower third rectum, CA rectum. Now what else? What next investigation in this patient would you do?
Do you have a,
Must have been done.
Do you have the CT image? We allow him to read. Because
What must have been done? Patient has received neoadjuvant.
before radiation CT do you have or MRI? Yeah, project.
You would do PET. You just said PET.
You said PET CT.
Would you do it routinely? Then would you do it pre-radiation?
It is very high CA level.
CA level. What else? Okay.
Okay. Perfect.
Any suspicious, anything?
What you will do if you find on
IP.
CT bulky lymph nodes, paraaortic nodes, you won't do?
So large volume disease on.
So these are the three common indications for doing. Basically, whenever there is indeterminate lesions in the liver, high CA level and bulky lymph node. Okay. So we can see the imaging. Can you? Yeah. So then we can ask the next person to read the image.
This image pre-radiation?
Pre. She is now post-radiation. So madam, can you read it for us?
Hyperintense well enhancing in the lower part of the rectum. The exact site of it, I would like to see it on the title section to look for the length. And I see that it is
Okay, so while we are sorting it out, so what radiotherapy was given for what duration?
5 days in hospital, and she was discharged on the 6th day.
So basically short
For
term.
short course, short course radiotherapy.
Short course. Why short course was selected for her? Any particular reason?
She was told that during the laparoscopic cholecystectomy immediately after the liver disease, the liver problem. The exact character, the details of which was not available.
What is the question? What was the question?
Why short course?
Why was short course? You think short course was selected in her?
How is the lap chole relevant?
Short course would have been given to sterilize the local.
Why not long course in her?
Sir, we will have to see what was the CRM on the
So don't
MRI.
ask cross question.
Anyway, you have-
Is you give your what would be your indication?
When do you give a short course? When do you give a short
We-
course?
Short course and lower rectal CA, provided CRM is negative on the MRI. And I would like to sterilize the tumor in T3, stage T3 and positive nodes.
See,
With
that is routine for indication of radiation, either T3 or mesorectum involvement, whether it is short course or long course. But what is the standard of care now is long course.
Long course.
So there are some still people follow short course.
Some
There are
indications,
some indications.
specific indications
You understand?
for short course radiotherapy. When will you do it? Anybody
What
else
your
knows?
indication telling is standard indications for radiation.
Anybody else knows?
Preoperative radiation.
Anybody wants to answer this?
I think she was trying to answer this by lap chole before that because you suspected that there was some liver disease, so you want to avoid chemo. Is that what
I
you're
would
going
like
to say?
to avoid
So
chemo.
start with that statement that in cases where I would like to, when you started that, I knew where you were going, but I just want to know. Based on what you say, how you say it is very.
In patients whom I would like to avoid.
So what do you think?
In neoadjuvant, what chemo give? One simple capecitabine. Huh? Do you think that causes that much liver toxicity?
What is that called as? What happens if you give chemotherapy in patients with fatty liver?
Yeah, CASH
CASH.
syndrome. See, CASH syndrome will not caused by the capecitabine. You understand?
So that should-
Folferinox, Folpac, what it contains.
So that should not be the. So tell us the indications for short.
Bulky disease? Would you do it for bulky disease short course? So you need non-bulky disease for sure, isn't it?
Non-bulky disease, CRM is maintained, provided CRM is better than chemo. Like to just sterilize the local area.
Interpreservation.
Like he's saying, sterilization is there for long and short. If the question is, answer question. Don't generalize. Viral thing where the guy is given a and he got 17 marks out of it. So don't do that. The specific question answers.
Yeah. So anybody else wants to answer this? Anybody of the five of you all?
So aim of our neoadjuvant therapy is not downstaging of
Neoadjuvant.
short course preoperative radiotherapy is not downstaging. To just
So indications. When will you just do that? But given a choice, the standard is long course radiotherapy, na?
T3A sir, T3A B with no involvement of mesorectal fat, no bulky lymph nodes, then I can.
Anybody else has a different answer? Huh?
Synchronous colonic malignancy.
Anybody else? You had a different answer?
What next? So we'll just ask them the criteria. That's only coming up now because the original studies, the actual evidence, we've also been following that, but the actual evidence has accumulated only now. The original thing was to do it quickly only, and since he's, I mean, I think we'll have to go with what they're stressing right now. That I don't want to I just want to sterilize. I don't want to downstage. You're almost saying as if downstaging is a harm. So you
got that long course long duration after it.
Not necessary. That's what I'm trying to tell you. It is not necessary. You wait 8 to 10 weeks, short course, down stages, as much as long course.
What he's trying to say is that the short course is not downstaging in that in
3 days, but in 8 to 10 weeks it does. Because the biological effect of the short course is equivalent to the biological effect of the long. We have enough studies now, and we have our own patients whom we have been following up. You can see any number of studies that shows that the downstaging is there with the 8 to 10 weeks. The Stockholm 3 trial, the Polish 2 trial, all these new trials have all shown that.
Okay.
So there's a change.
So
the latest change is that the Americans have now started.
Can you
accepting
read
short
that MRI?
Continue this discussion. You read this MRI.
Read
since they
MRI
have,
problem.
loaded it. Yeah. Madam.
here.
You start speaking.
So this is the weighted image where we're seeing the coronal sections, and what we see is the levator ana and the sphincter complex. The tumor is away from is not involving the levator ana and the sphincter complex.
Yeah, go ahead to speak.
On
Yeah.
the right side, I see some loss of fat planes.
Loss
I'd like
of
to see the other section.
fat planes between?
I would like to take back my right-sided levator ana
So,
and the
so they seem to be obscured. Okay. Next. Go ahead. You want to see further cuts?
yes, I would like to see. Tumor is seen in, going into the mesorectal plane. This loss of fat plane there, probably a T3 stage. I don't see any significant notes because all of the significant notes in the mesorectal envelope. Could you come down on the lower cuts? Yeah, a bit up. This is the good fat plane which is being maintained, but when we see it here, it is entering into the mesorectal envelope. This is the mesorectal part, and this is the tumor.
That plane seems to be okay.
'Cause 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 compare it to the left side, this is where I felt probably.
Okay. So there, it seems suspicious. If you say so, okay. Then what else? So no prominent node.
No prominent.
Okay. So now this has been done MRI, and this patient is subjected to short course radiotherapy. Right? Now she's come to you. How long would you wait for this to give a definitive treatment? So sir just give you the answer. How long would you wait? 5 centimeters from the anal verge.
Since the levator in a plane was quite suspicious, I would like to wait on this patient because the biological work of the short course chemotherapy over a duration of time would probably reduce the tumor burden there. Previously, studies said that short course we could wait, finish the course by 5 days and operate over after a gap of 7 to 10 days. But in the recent trials like Stockholm 3, they have waited for up to 4 to 6 weeks, and then they've seen that the short course is equivalent to that of a long course chemoradiation. So in her, I would like to wait for about 6 weeks and reassess.
You still believe short course, or you want to give a standard of care as existing all oncologists practicing long course?
No, it's okay. We get the point.
No, it's
what he's
the
saying
standard of
equivalent,
care. Even if you see NCCN guidelines, it is both said, but they given short course B.
Okay, with due
given a B, sir.
See, with due respect to it, we'll reframe this question. This patient, had it come to you first, would you have given long course or would you have given short course? Let us reframe it.
Provided she had no liver problem, I would have considered a long course on her.
Why? Why long course?
Exactly. So, what is there any other benefit apart
Why
from
long
the fact
course?
that you're trying to prove it's equal? Is there any benefit of short course or long course?
Why long course? Why long course?
Main intent here is to try and see if we can get a curative treatment on her. The long course is known to bring down the tumor burden. It is known to take care of the micrometastasis that is going to happen, that is going to be there, because it is also gone as provided since it's a very low rectal tumor where the levator in of the patient is involved. Or probably.
So, if the levator NI is involved in the pre-treatment MRI, what would your plan be? To give long course to attempt sphincter, the sphincters involved pre-treatment. Would your long-term plan be to conserve it, to make sure that the radiotherapy reduces that contact, and would you plan it based on the original? I know some people do that, but is that how you would sell it? What would be your funda? What would be your philosophy?
That would have,
Your sphincter conservation would be dependent on what? Involvement, pre-treatment, post-treatment, or what?
Pre-treatment.
The pre-treatment is it's involved, and post-treatment it looks like it's little separate. Then
I would give the option.
What would you recommend? If it's your own relative, what would you recommend? So you need to be clear on that. We need to take that out of. Because you're saying that it is closed, so it looks as if you will save it based on that. You should be clear that for technical reasons we end up, with that. That's exactly what I'm saying. If the it's decided on so even in liver mets we have this issue.
So, Dr. Nisha, you have been answering. You have been answering very well.
All of you.
So, this patient was given short course radiotherapy, and a repeat scan was done 5 weeks hence, and you found that the lesion has disappeared. Now, how will you manage?
Actually, the same question.
So now again, I'll give the option.
No, what is your standard? What would be your
No, what would you do? What would the patient would say if I were the patient's relative? I would say, I leave it to you, doctor. What is best for my patient, you do it. So what will you do?
So you're shifting the responsibility from someone who's aware of the consequences.
What will you do?
Who has no
Since
idea
you've
what the
been
consequences.
answering so well, what will you do next?
The only ideal setting. If somebody says that the patient is insisting and all that, you'll do it. But don't say I will offer to the patient. What would you do if this in a neoadjuvant with neoadjuvant protocol, the lesion visibly disappears, radiologically clears? So what is the answer? What should the answer consist of? Answer must tell us. You have to tell us what is the actual pathological response.
Doctor.
So with that in mind, you have to say clearly
So,
what would be my
so
standard
Dr.
of
Manoj,
care,
what is,
then
sir?
what is possible?
What is sir talking about pathological response and radiological response? Can you tell us, Manoj?
Imaging tumor appears to be disappear. It will not be seen, but following surgery, there might be some pathological island. Then that is the only imaging.
Doing surgery.
Like pathological response is based on biopsy, sir. And clinical response it includes.
So usually they may not correlate. Means a radiological response not necessarily have a pathological response. So what is this? What is the other option? She said that given a choice, she would operate. What is the other option?
Wait and watch.
Whose policy is that? Do you know?
Habergama.
So what is that? Habergama's wait and watch policy?
Following this, neoadjuvant therapy, if there is a clinically complete response, then we can select it.
No. It's a
Neoadjuvant
it's a
protocol, that's
definitive
exactly why it's
chemo RT.
neoadjuvant, no?
See, Brazilian Habergama regimen says those patients doesn't want to undergo for surgery.
Thing.
Medical
You guys have all
management,
misunderstood.
definitive CT RT, right? They are totally different.
When the
Yes.
intention is neoadjuvant, you have to go ahead with surgery. If the so long as the intent was originally there and it's you're using that biological dose, you need to go ahead with surgery because we don't have enough evidence that you will get complete pathological response. But it's a liver with chemotherapy, the liver metastasis, they disappear. You still will do it. So exactly. Chemo.
Add to the effect.
So I'm coming to that, sir. So Manoj, that is one thing that Habergama's approach is this. Now, since she said that she would want to operate, the patient says, no, even if the lesion has disappeared, I want to operate. I want to get operated. So, since the patient's tumor biology is good, it has disappeared, would you consider giving total neoadjuvant therapy to this patient? What do you mean by total neoadjuvant therapy?
Total neoadjuvant therapy is completing the entire radiotherapy along with the chemotherapy prior to surgical management. Like
How is that different from standard neoadjuvant long course?
initially
Total
it is
versus standard. So just give the difference between these two. Looks at a lot of other background. Let's give the main difference between these two.
main difference in standard it is the long course chemoradiotherapy followed by surgery after 6 to 8 weeks followed by adjuvant chemotherapy. In case of total neoadjuvant therapy, chemotherapy will be planned prior to the surgery either as an induction or a consolidation chemotherapy. In case of induction, first initial chemotherapy will be given followed by radiotherapy, then will be taken up for surgery. In case
The
of
entire chemotherapy is anterior.
anterior.
Just the entire chemo is finished. The
Prior
whole
to-
adjuvant which you were given, you're distributing anterior and posterior. Your entire
Prior
chemo
to
is
surgery.
given prior to surgery. That's
What-
the main difference.
What is the advantage?
The sales pitch for the short course is over. We can continue with the. So what is the benefit of short?
What is the advantage?
So since we have this, we are trying to prove something is equivalent to something. We know something is very good. Why should we have a sales pitch? What is the benefit?
shorter duration, like 5 days, it's compliance to the patient, and followed by 6 weeks will be waiting and taking up for surgery.
You're saying compliance is there. What is
Compliance.
single for in Indian setting? What would be the most
Cost effective. Cost
Absolutely,
effective.
because all cost is decided per fraction. It immediately becomes much more affordable.
So,
not paid by the American insurance company.
what is the advantage of total neoadjuvant therapy?
Total neoadjuvant therapy. Most of the patients who require adjuvant chemotherapy might not be fit following surgery due to some complications. So these kind of patients can be dealt with. They will receive chemotherapy prior to surgery. So entire chemotherapy can be completed.
So chemo is an important. Earlier it was just an adjuvant, but it's an important part of the entire thing. If for any reason you're going to delay it, the entire package might be damaged.
So now to Dipesh, now this patient, the relatives are a little over smart. They say, doctor, can we eliminate radiotherapy? Is there a role for elimination of radiotherapy? You are the consultant. They come to you. They say, we agree to all this, but can we eliminate radiotherapy? We don't want to undergo radiotherapy.
No, sir.
How will you answer the patient's relatives? Loud. Mic near. Yeah.
Still, radiotherapy, regards to the local control of the.
In which subgroup of patients of CA rectum can you do eliminate radiotherapy?
Early tumors, early one.
Is it got to do something with the level upper rectum? So upper rectum patients, you can think of eliminating radiotherapy. Okay. Yeah. So now this patient has undergone radiotherapy and total neoadjuvant therapy. Now what surgery are you planning for this patient? Loudly. APR. The tumor is 5 centimeters away from the anal verge.
But sphincter preservation, if you plan, it's better to. Yeah, it has to be. If you are planning upfront APR, yes, I agree. But if you are planning a sphincter preservation, I still.
For the purpose of discussion, it is above the sphincter, 1 centimeter above this. What surgery are you planning? Quick. What surgery would you do?
Low resection.
Low resection? Loudly and clearly.
The dented line, sir.
So what technique will you do? How do you say that? You will do a low anterior resection by double stapling technique, open or minimal access, whichever.
It cannot be an anterior resection, because anterior section means the colon must be anastomosed to the rectum. Here, if it is 1 centimeters above the anorectal junction, giving your clearance, it will be a coloanal.
Coloanal anesthesia. Agree. So now, taking the discussion further, is at which point during surgery, can you damage nerves? And which nerves?
One is at the IMA, sir. IMA, there will be superior hypogastric plexus. And also during the TME plane, so we can injure the both hypogastric nerves, and also while at the lateral dissection, the lower rectum.
So one is at the IMA, second is at the TME, third?
Plane. Third at the lateral rectal stalk, lower hypogastric plexus.
Very good. Fourth?
Also anteriorly at the while at the prostate dissection.
Perfect. So what is your view? Do you do high ligation of IMA always or sometimes?
Only sometimes.
Why? Why not always?
So there is no survival advantage, sir, provided that there is no nodes around the IMA, and also that there will be increased complication with the higher high ligation, but that there is an increased chance of nerve injury, and also there is increased chance of nerve injury.
What
There
do
is
you
only
mean? What do you mean when you say not a high ligation? What are you implying? High ligation, we know what it means. Onto the aorta. What is a non-high ligation?
low ligation.
How? Where?
After the take of the left colic arteries.
Yes. So that is why you preserve the blood supply. Leave the left colic intact.
How will you counsel the patient? What will you tell him? Your young male is worried. What will you tell him? What can go?
Preoperatively, well, I will counsel for the patient requirement of the stoma, and because of we are planning for the lower anastomosis, and also there might be chance of nerve injury. Also, there will be a chance of bladder disturbance.
The stoma is tell very clearly. You're going to make a temporary or
Temporary stoma.
It should be.
Percentage. No, you need to say exactly what every day, isn't it? You're good at that. So why don't you give that properly? I will tell him that if I'm planning a LAR, it's going to be or a colonel, it's going to be a temporary. There's a possibility 5% or 10%, whatever any figure you say. I will tell him that there is a real possibility of it being converted into a end stoma as well.
Yeah,
you
he
need
should
to
tell.
get that. You need to get that in the documentation, otherwise you'll have litigation. Absolutely.
Yeah, it's
Always
mandate.
get that mandatory.
See, this type of case, young patient contemplating a low rectal resection and sphincter preservation, definitely there is a possibility of permanent stoma also. Unless if you don't prior inform, you will be in a land.
You take that. Haven't you heard that in the consent process every single time? So you just say that. Yeah, we're just seeing what you're going to do. What else? So for the neural thing, what are you going to counsel? What exact thing are you going to tell him? So one thing in theory, what do you do in practice? What do you tell him?
It will be like bladder disturbance, and also there will be
Bladder disturbance. Okay.
So the sexual dysfunction.
Dyspareunia. No, I said for a young male. I know this is a
Male, we can it can be a ejaculatory dysfunction or
so which will happen where?
With the IMA, that there will be in retrograde ejaculatory dysfunction. The lower lower hypogastric plexus, it will be erectile.
Can any of these be temporary or they're always permanent? Can it be because of disease or they're always
All those nerves,
surgical?
the ones when you have
What are those nerves
ejaculatory
called?
problems, erectile dysfunction when you have erectile. What is the name of
Which part gets?
what is the nerve called?
Perigantis.
Nervi urgentis causes
Yes,
what?
nerve area.
Very good.
Where do you damage them?
Or try
No,
not to.
I know, but where do you damage them?
Lateral left rectum.
Lateral rectal stalk is rare because they don't actually enter through they just come close to the rectal stalk and then they go anterior to the prostate. So where do you normally injure them?
Anteriorly.
Yeah, anteriorly when? Where do they go anterior?
During dissection.
No, is it? So the denon-villus fascia has two layers, an anterior layer and a posterior layer. So they go between the two layers, the nerves. So if you stay posterior to the denon-villus fascia, in a tumor which is say posterior, you will not damage the nerve. But if you are in a tumor which is
Anteriorly placed large tumor.
you will have to
While dissecting.
go anterior to the denon-villus fascia, and the nerves are most likely going to get damaged.
Next person. What are your views on dissecting lateral pelvic lymph nodes? Do you always dissect or you keep it behind? Loudly, mic near.
The question. What was this question? Accurate question.
Used on lateral pelvic lymph node dissection.
He said, "Do you do it or not?" So you start the answer like that. This is a very standard thing. You're always answering theoretically and generalization. So don't do that. That's repeatedly I'm saying because you're not hearing the question. So you start with that, whatever you're going to do, and then continue on. So your point must come.
Then rationalize why you are doing it.
That's why we are continuously digressing since morning. You're not listening to the question.
So what do you do? What is your practice?
I would not like to do it because of this. However, there is whatever. That should be your. So we means Say I. His question was you, so I.
In our center, if there is a not present on the
Obvious
pre-neoadjuvant
visible.
MRI and it does not disappear after neoadjuvant on the MRI.
You give a knee.
Three groups, sir. First is in between the ureter and the iliac artery. Second is internal iliac artery and internal obturator.
Yeah, these original studies were described in Japanese fellows. That is in the era of before radiation was standardized. Now after neoadjuvant, this
Patient says, I do not want a stoma on any count. What will you do? Practical. I don't want to go whatever is written in theory and all that. Patient comes to you, the patient. She says, I don't want a stoma on any count. What will you do? No temporary, no permanent. You can move it.
She has undergone radiotherapy, I will counsel her. There will be high chances of, if she is ready to accept in the
She's not ready.
Send to my friend.
So you need to be clear what you're going to do. If I have seen all of you hit her at this state and cause problems, you say, okay, I guarantee you I will not do it, and then you have a problem, you have a leak. What do you do?
definitely.
So you have to be sure that you have to be clear to yourself that if you think that there is a reasonable chance of at least a temporary, I will not do this surgery for you then. You need to say that loudly to yourself first. It takes a lot of guts, but you need to do that at some stage.
best thing you say, either you select surgery or if at all surgical therapy, you need to counsel for a stoma, whether it is temporary or permanent, how much. Tell them. Otherwise, best option is like abergam marriage. Follow it. And
So
risk,
that would be a
risk
good,
of recurrence will be definitely more.
not after neoadjuvant, you have to decide upfront.
You cannot get.
Yeah, that is all. Yeah, that is.
Okay, bowel prep.
Only thing, one question. What sir said is to stoma avoid, but it's not for that. Or rectal growth. Main problem, what is distal margin positive, right? Is there any surgery which can be avoided this distal margin positive? New modification.
Intersphincter.
What? Yeah, that's it. No. What? See, you have said this patient is obese, right? BMI is high and also suspecting some fatty liver changes. Definitely.
So what is the advantage of TATME?
What is mean by TATME?
What do you do in it?
TATM, total visceral
What they do? What they do first? What they do first?
abdominal pace first. Go to
No,
the
no, no, no. They don't do abdominal first. What they do? TATME, transanal mesorectal excision, right?
Yes.
So this is virginally divided for lower rectal growth, obese fellows, narrow pelvis fellows. Prevent R1 positivity. What they do? The transanal margin below 1 centimeter, they circumferential bursting. Then they divide, then they go into the mesorectum excision. You understand? So by initially only you will know where you are cutting lower end margin. But the main disadvantage is high ureteric injury, urethral injury. Some of the countries like Sweden is banned, but other countries are still banned.
Okay, next person.
Bowel prep. What will you do? Bowel prep.
How will you prepare the bowel?
Will you give? What will you do?
It's an elective setting. How do you prepare the bowel? Will you give bowel preparation? If yes, how?
Oral antibiotics plus mechanical bowel preparation.
Do you do that?
For rectal.
Are you telling me theoretically or what do you do? What do you want to do? What oral antibiotic do you give? You can't give this time gap now.
Erythromycin.
So that tells me that.
Erythromycin and.
What dose of erythromycin?
500 mg PD 2 days prior to taking.
You're questioning me or? You saw that gap. This is classical what exam happens, unfortunately. Okay, the first round was very good. All looking at how to modify it. So you give whatever you.
So you would give a combination of mechanical as well as an chemoprophylaxis, antibiotics you give. What is the advantage of giving both what is the rationale behind it? There has to be a rationale.
In rectal for rectal malignancies, there is going to be like decreased surgical site infection following post-op surgical site infection. For colonic malignancies, bowel preparation is not mechanical bowel preparation is not required in electricity. For lower rectal cancers and rectal malignancies, is shown to reduce the post-op surgical site.
For rectal cancer, it is the Grecor trial from France.
Study.
But for the left colon, now most are advocating preparation. They have moved, though the earlier randomized trials were supposed to show, but this very large database from American.
So basically, you must understand the history. First, we started with oral bowel prep with needed patient in liquid for 3 days. Then the American managed care setting came, the insurance companies came with day of surgery admission. So they had a few hasty trials which showed IVs as good as oral. Then finally, this is what actually showed that the large database study actually showed that it's
and you give oral antibiotics
oral is
the day
better than,
before.
yeah.
Now that has become a standard of care.
You've given all this.
He said so.
You do all this. You're on table. You've done a temporary stoma, but the colon is loaded. Which stoma would you do? You can pass the mic on. The gentleman has answered very few. Ileostomy. So now the entire colon is full of
Fecal matter.
liquid shit. Yeah, and you've done this, right? Third post-op day, patient is in severe sepsis. What will you do?
It's like I would like to do a CCT abdomen.
Even if you don't see it, presumed leak, isn't it? What do you want to do? You've got a colonal anastomosis. What do you think? What do you think is your window of opportunity of doing a lot of things? What are the options open? Don't tell me only investigation. What's the ultimate plan? What are the options open to you? Clinical options apart from just doing investigation. Once you finish your residency, you have to do action. Yeah. Till now, it is what the boss told you. You have to do. So you have to go move beyond that.
In that collection.
You'd like to drain the collection. How? A colonal anastomosis. Percutaneous from where? From below? From above? What is it realistically? Now he goes into septic shock.
What was the mistake that was made?
I've seen several such instances where patients have two stomas. You need to, if you're counseling,
he's giving you hints.
So remember this very important principle. If you are planning on doing an ileostomy, colon must be empty. Okay, so if the patient is not obstructed, they must be bowel prepared. But if it leaks fecal matter, you will go into sepsis. There is no fecal matter and you have diverted the ileostomy, patient won't go into sepsis, it will just be an innocuous leak. So if you are doing an ileostomy, you must prepare the bowel. If you can't prepare the bowel because of a partial obstruction, or you find motion like this, you have to do on-table lavage and clear that motion till clear fluid comes out before doing the anesthesia.
Need to do that in the segment the proximal segment to the resected part. You can actually make a thing and empty. So and all these complications come early on. So just to rephrase, because sometimes you answer this wrong. Sorry, he's already given you the answer, but I just want you to say it in your words. What does ileostomy do what is the role of an ileostomy because you answer this wrong in the exams very badly. Somehow you're not able to phrase this. So you need to practice some of these phrases, not only for the exam, but also to tell the patient. Because all this is what carries on to a litigation. When you tell them this prevents this, there's an issue. Because that's documented, there's a video consent, and then you realize that what you should have said was something else. So he's already given you the answer, but I just want you to still rephrase for the whole audience, what are you going to tell the patient? Reason for ileostomy. Patient is very reluctant for a stoma. What are you going to tell them? That I'm doing an ileostomy because. So you go after saying all this, after all that Ramesh has said, he still says to avoid a leak. Would anybody agree in the audience? Anybody raise your hand? Does it prevent a leak? It doesn't prevent a leak. He said very well. There is some recent evidence that it is but since Ramesh only goes to the sales pitch for one paper, I think the overwhelming evidence is that it does not reduce a leak. He made a lovely statement. I just wanted you to repeat that because it's exactly but one second, Ramesh. This is exactly what they do in the exam. They say that it reduces a leak, and then they go into a problem. So, but at the moment, would any of the faculty agree that what they should say in the exam, what they would accept?
No, maybe 1 in 10 paper it says prevent the leak, but maybe
will you counsel the patient?
8 out of 10 paper says it does not prevent the leak. Leak is going to be happen in majority of patient, and it prevents the complication or consequences secondary to the leak. That is the purpose of this.
You have to say that statement.
That you should not say based on one paper. You should say that it's prevent the leak.
I said he's given
maybe there are evidences that it may or it prevents, but majority of papers say it may not prevent, and it only reduces the complications secondary to the leak. That's why you adopt it.
That's how you have to counsel the patient. If you do not counsel that way, you are exposing yourself to litigation. Even though, as Ramesh said, there is some recent evidence that it also reduces the overall leak. But that's how you have to counsel.
But that's only if the colon is clean.
So that we agree. Otherwise, sometimes you have to do another colostomy in already anastomosed patient. Sometimes you have to disrupt the lower coloanal anastomosis.
That is a very crucial.
And
when
that is more dangerous. You will do ileostomy at one point and end colostomy after disrupting the anastomosis. Another operation. That is the only way to reduce the complication. I'm asking one question. If the donut comes positive, what will we do? After 5 days, biopsy came, and you have done all heroic surgery in a patient where likely elevator and I is involved in this patient. You have restored based on your experience or patient request, and finally turned to be positive in 7 days. What will you do?
If the donut is positive, then I will like to counsel the patient. If and I will also look for the distal stump of the rectum. If there is an adequate stump, and if we can revise the anastomosis by going in.
Coloanal anastomosis, this distal.
Be realistic. In
this patient, coloanal anastomosis.
In the worst of cases, will you ever be able to, accept it? It's very, 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 very. So you have to counsel all that also in your counseling. And all these cases will come early on in your post-MCH experience. So one option Chetan has given is that one easy way to avoid this is not to send the donut
No, not acceptable. This is statement at this point.
Let them say it. So what would be your answer?
No, it's a medico-legal implication, and somebody may take you in the court once there is a recurrence in 2, 3 weeks, 4 weeks time.
Absolutely. No, you have to say, we are not entertaining. You have to clearly say, I will send it for, lab coli. There is a paper. Since Ramesh is only reading recent papers, there's an American paper, not an Indian one, suggesting that that there is not enough evidence because they don't have CAGB. There's not enough evidence that you send everything.
So what will you do? What will you do for this patient? Now donut has come as positive. What will you do?
Adjuvant chemoradiotherapy. We have to add radiotherapy to.
Patient is young, not this patient. Patient is young.
all these questions,
See-
you give the options available and then say, I would like to choose this. When you give only the latest and the, you are trying to, are you trying to save the patient's sphincter or his life? You need to be clear on that. So what is the best way to salvage his life is not to salvage his sphincter. So say these are my options.
The primary objective of any malignancy or oncological surgery is not to save the sphincter. That is a secondary objective. First objective is curative surgery by
R0.
all possible means, R0 resection. Even the surrounding structure is involved. You have to resect in toto. Don't try to separate it. In 50% time it could be malignant. 50% time it will be benign.
Just one
So
statement.
never try to separate it. Try to excise in toto. But there are several situations it's not possible.
So last
I just
question.
want to make one statement. The Haber-Gamma study relies on one fundamental principle. That is that the local recurrence occurs first and then only it will metastasize. So, taking that same argument to this donut here.
Enough studies showing T1 local resections, T1, which has very little systemic spread, T1 having, where only local resection
No,
is
it can
done.
spread first. I'm not talking, I'm not talking about that. I'm talking.
So just put them into balance.
No, when it comes in recurrence local, immediately you tell the patient, I will do an APR.
Salvage here.
Otherwise,
So that's part of the.
I can wait and keep you under follow-up, though the donut was positive. And as he says, you can add brachytherapy.
So put that as an option. What I'm saying is don't give one only. Say the options available to me at this stage are prime. So do the one which is most standard, traditional, and then go on to the latest.
I will rather say, you say this is the best option. If you don't choose, if you want alternative, this is the alternative option, but it is not the ideal option for you.
So two questions to complete the discussion. One is that suppose this patient had an obstructing lesion and you wanted to give neoadjuvant therapy. What would you do?
If patient had obstructing lesion, then I would first do imaging. And,
What would you do to
actions?
relieve?
You have to stop investigation and do action sometimes.
What would you do?
Stoma
Don't-
therapy, stoma therapy definitely.
What would you do? Answer quickly. Or diverting stoma, or which is better? Any literature evidence?
For rectum, you cannot put a stick.
So that's what I'm asking. So it's basically only the stoma which is shown. Next question to you. What is LAR syndrome?
Constellation increased urgency, increased frequency with nocturnal defecation, affecting his day-to-day activity.
Why does it occur? In which group would you anticipate? In which subgroup of patients would you anticipate LAR syndrome to happen?
Patients who have received pre-op
Neoadjuvant radiotherapy. One. Second,
male, obese, narrow pelvis patients where we do a colonial anastomy.
location of the
Very low.
Single most will be the location.
Ultra low,
no? All the
ultra low
others are
anastomosis.
secondary.
Age.
And
The older they are, absolutely.
These are the subgroup of patients whom you anticipate LAR syndrome. How do you manage it?
So if I am anticipating it preoperatively, I can teach him Kegel's exercises, and intraoperatively we can try and make a reservoir, either instead of a straight colonal, we can try to make a J pouch or probably a transverse coloplasty pouch.
Okay, you all did very good. All of you all
Or
did very well.
advanced stage, very advanced stage, you give the option of removing the thing also. Pre-op if you're giving exercise.
So now
then
we
you
are on
give the
to
option.
sure, next person.
53 years old male coming from Jharkhand.
We will not touch on
working-
the history part of it. Here.
Came with chief complaints of altered bowel habits since 9 months and blood in stool since 9 months. So patient was apparently normal 9 months back, after which he developed altered bowel habits, increased frequency of stools 5 to 6 times per day, small quantity of liquids or semi-solid stools, blood in stools with mucus and sense of incomplete evacuation with tenesmus. Pain abdomen is present before and after passing stools, no history of nausea, vomiting, fever, no loss of weight, loss of appetite and no transfusions. Past history, he had similar complaints 16 years back, increased frequency of stools 7 to 8 times per day, small quantity with blood and mucus. He was evaluated for the same in 2006. He underwent colonoscopy and then was started on medication, following which he had symptomatic relief. The symptoms recurred after stopping the medication. He had similar recurrent episodes till 2012, after which he was symptom free. A patient is known case of diabetes, hypertension on regular treatment. He had undergone open reduction and internal fixation for left femur and tibia in 1998. Family history not significant. Personal history not significant. General examination moderately built and nourished. ECOG 0, breath holding time 32 seconds. BMI of 25.3, no pallor, icterus, cyanosis. Vitals are normal. On examination, inspection, umbilicus central averted, abdomen is fat. No positive findings in inspection. On palpation.
Palpation.
Yes, sir. In percussion, parietal examination, perianal skin normal, sphincter tone normal, hard mass palpable 3 centimeters above the anal verge, involving 2/3 of the circumference anteriorly. Surface was nodular, mass is not freely mobile. Upper limit could not be reached and gloved finger stained with blood. Systemic examination is normal.
So Manoj, we come start with Manoj. So Manoj, what do you think we are dealing with?
It's a long history and history of colonoscopy 16 years back, and with medications it is settling, giving a history of inflammatory bowel disease you might be having. On medications it is controlled, and even he had 2 flares after stopping medications. And now on examination, digital rectal examination is showing a mass 3 centimeters from the anal verge, circumferential lesion. So probably a malignancy in the background of inflammatory bowel disease.
What is the relevance of this fracture? Is it related to this disease?
Could be a pathological fracture.
No, when was the fracture reduction?
1998.
When was the treatment started? I also thought I looked for it.
Unrelated.
Probably not steroid induced.
Not steroid related. Okay. So how will you take it forward? This patient has come to you. You are suspecting that there is a malignancy in the background of inflammatory bowel disease. What would you do?
I would like to take a biopsy from the throat, proctoscopy and biopsy.
Why did you say biopsy? What is the most important? I agree with you.
To prove malignancy, like on the background of inflammatory bowel disease.
So the nature of malignancy be different?
Do you think any other possibility? Suppose there's long-standing ulcerative colitis or inflammatory bowel disease. Patient put on medicine control and developed a mass into the rectum. What else could be? What first possibility malignancy? What else is?
Malignancy is okay. We give you. Anything else in this background?
Inflammatory mass.
What is DALM?
Dysplasia associated mucoid lesion.
Lesion or mass?
Lymphoid.
Lesion or mass?
Lesion or mass.
Look.
You will take, what else he will do?
Colonoscopy, he has to prepare him for colonoscopy. Full length colonoscopy has to be done.
Prior to this, how will you, means to avoid this situation to arise, what is the surveillance policy or recommendation? In a patient of ulcerative colitis, how will you keep the patient under surveillance to avoid this situation of malignancy developing?
He refuses to go to your medical colleague. He's sticking with you. What will you tell him? Got pancolitis.
During the initial colonoscopy, if there is a pancolitis and associated with any dysplastic lesions,
next nothing is there. How?
Like he should be under
pancolitis, but no obviously.
Should be under regular follow-up with the colonoscopy, sir. Duration regularly. Duration.
What is the, how do you do it? There is a schedule. Yes. So how often do you do it? What else do you do it?
The patient is having associated lesions like any primary sclerosing cholangitis or family history.
No, don't mix up things. Simple, keep it very simple.
Okay, just say that, yeah. Just say
kind of risk factors. If the patient is having, the follow-up should be more frequent. Maybe at least after initial diagnosis, after 1 year.
First say the regular one, then you say PSC and family history has a higher incidence. Agreed. That's more to scare them into the rather than changing.
Simple question पूछा. Means I've asked you a simple question.
After 8 years, even though you're saying a correct thing, it's actually distracted the people. Don't do that.
Patients will be started on the medical management and clinically followed up.
The
After
question.
8
What
years,
was the question? Again,
colonoscopy follow.
what is the question? Simple. My guess is your simple answers. I'm not really sure. I have to guess in between. I'll flap around a lot. Do not do that. So because you will never get an answer in flapping and you'll get a problem. Whereas if you say I don't know, all of you've done in the first half very well. If you do that, this is where unfortunately people to have a retrograde amnesia.
Dipesh, you want to answer? How often do you do it? Agree.
The question is that a patient put on medicine, patient is gone complete in remission, number one, and patient has no symptom. Would you advise regular colonoscopy in this patient, yes or no? If yes, then how frequently? Another group not responded well, off and on bleeding, but symptoms control. How frequently? Another third group patient has one polyp, a dysplasia at some point. How will follow this patient?
Patient with complete remission, I would not like to follow the patient with
Ever. That's how we'll come back to? Never. Pancolitis at index, no suspicious lesion. He doesn't need a subsequent one. I mean, let's put it in another perspective. The standard recommendation is when without any disease without any pre-malignant condition, what is the standard recommendation for
8 years.
No. You and me, when would you consider a surveillance colonoscopy? Is there any recommendation for routine surveillance colonoscopy? So in a pre-malignant, it will be at least better than that, no? No, you're not getting the question. Happening it?
Here there is no. You
Should-
don't need a colon.
Do you really think you should not need it in India? No. I mean, in parts of India, the incidence is almost as in Kerala. The incidence is all of them come with advanced malignancy. So there's a definite case for it. I don't agree, and even in some parts of North also. Yeah. Absolutely.
per
So
se is
in
a
the
country.
absence of having epidemiology, this thing, I don't think we can even debate that we should not do it. So we can debate that whether we should do epidemiology or not, but I don't think we should veer away from the guidelines as they exist. If you're following NCCN for cancers, why not for pre-cancer? Absolutely, I totally agree. Totally agree. So he's got a 57-year-old guy who's got colitis for 16 years. You're saying if he's well controlled, I will never do a colonoscopy. Is that correct? Of his age.
Your first answer was right that after 8 years,
You said that, no? Absolutely.
ulcerative colitis never goes. So even if they're completely asymptomatic, you do a colonoscopy, you do a biopsy, the pathologist will tell you this patient is ulcerative colitis. Even if the colon looks normal on colonoscopy.
So basically, any patient,
Lesion or not?
there is a dysplasia, mild dysplasia, early dysplasia, or late dysplasia.
Now
If
you have
there
mild
is-
dysplasia on that. What will you do?
Again, there are guidelines. If
He's
there is a-
well controlled. There are no other surgical indications. He's reasonably well controlled on medication. You don't need to sell surgery to him, but he's got mild dysplasia. How will you counsel him? He actually went to your medical colleague, but somebody told him this is a medical decision, so he comes to you. What will you do?
You want to answer? Agree. So if there is a mild dysplasia, you need to get it done annually at the endoscopy. If it is moderate to severe dysplasia, every 6 monthly you have to get it done. And you have to take a biopsy. How will you take a biopsy? From where will you take a biopsy?
take the 4-quadrant biopsy starting from anorectal junction, cecum, and every 10 centimeter. And some says that in left-sided colon every 5 centimeters should be taken, but standard guideline says that every 10 centimeter 4-quadrant biopsy should be taken, plus targeted biopsy from any suspicious lesion
Any
should be
suspicion,
taken.
plus any suspicion.
Okay.
So make sure even for your index, you see, should have that. You should know. Sometimes you'll pick up these missed Crohn's and patients with segmental colitis. You'll realize they're all pancolitis.
Biopsies does it come to?
What is the describe? How much does it come to, doc?
4 biopsies every 10 centimeters full colon.
What is the length of the colon?
40 to 40.
Applied.
No. There is a number given. Your textbooks have given a number.
33.
33.
Major mathematical challenge, no? You've taken only 3 biopsies instead of 4.
Now coming to your question, means that this patient, you will do colonoscopy at this time and take a biopsy from the lesion.
On PPT.
Instead of a colonoscopy, because he's 57. What's an average age of onset of IBD? With a reasonably high chance of having a malignancy, can he have multiple tumors also? He can have, no? So you do need a there you go. There are 2 lesions.
So, madam, what would you do?
Do you want any other information on the colonoscopy? Are you happy with this?
You see,
Has this told you till where they've gone?
They said they could not pass the scope. beyond
Good.
the
So
rectum
you cannot go beyond it. Otherwise, you would have wanted that information. Anything else?
to visualize the rectum.
But it's whatever visualized. Do you have any evidence on that? You want to look for the IBD changes in the rest of between the 2 tumors. No, is that mentioned there? No. So you need to ask for. So you need to train yourself to look for stuff which is not there.
suppose that is turned to be malignancy, biopsy is malignant. Suppose that the rest of the colon proximal to the rectosigmoid is normal, and another situation, it's another similar lesion somewhere in the transverse colon, that the management would be same or different in this patient in the setting of ulcerative colitis.
It would be provided the histology of the transverse colon growth is same as that of the.
Is it this? You want the worst pathology, isn't it? What is going to decide now? If it is completely obstructed, what is the T stage? So ipso facto, you need to look for other things as well. No, but is there systemic spread? T4, a high chance of.
Simple practical problem. No assuming all this. The case looking like long-standing history of inflammatory. Now you got a tumor in the lower rectum. It's tenosing lesion. What investigation you will do? You can't do colonoscopy. Is there any way to assess proximal colon?
Virtual colonoscopy can be done.
Yeah,
PT
that can make it out at least.
No, but his question was, does it make a difference?
No, we are going to remove the entire colon in the. because
So
the
do you
entire
really
colon is
need
going
a
to be
virtual
diseased.
colonoscopy? Virtual colonoscopy also needs a patent passage. The contrast does have to come out, no?
Yes.
Can you get in Indians, can you get, it's all very, very well to say it in a minimally, the T1, T2, which is got in the surveillance where we refuse to do surveillance even in disease conditions, known pre-malignant conditions, we obviously get advanced lesions. If the doctors are saying that, the patients are not going to do it. So with that background, do you really need to do, is it going to change the management, was this question? So you need to know now the metastatic workup, isn't it? So why aren't we going for that? Is virtual colonoscopy the next important thing? No.
So you do a metastatic workup and everything is normal. What is your plan?
In him, this sense, I would
Only
like,
him.
in this case, I would do the complete total proctocolectomy. I would offer the patient total proctocolectomy.
And what would you do? You'll offer something and do something.
Total proctocolectomy, you would, and it's an obstructed lesion. You said obstructed lesion means T4 lesion. So what would you want to do?
No, let us answer what you said total proctocolectomy. We didn't complete.
Okay. Total proctocolectomy, that is long term. Prior to that, but what surgery would you want to perform? Total proctocolectomy.
The entire chemotherapy and looking at the
You haven't finished. What you said total proctocolectomy and he stopped you at that.
And what surgery? And
ileostomy. Okay. And then, so why are you scared to say that? It's a real option. It used to be standard of care till 20-30 years back. It's probably the best for this, isn't it? Then, not the histopath for that.
once this is
exactly, sir. I'm coming to that. So prior to surgery, this is an obstructed lesion. Do you want to give neoadjuvant therapy? Or it's because it's an inflammatory bowel disease, you wouldn't give? Is it going to change?
It will change. Which one is obstructed?
rectosigmoid growth was obstructed.
So rectosigmoid, what is the standard of care? Do you give neoadjuvant?
Very low.
But that is not obstructed up. From that, it's passing up. Right, so what's the point on? No, it's rectosigmoid. So you said it's all completely operable. No, you didn't want to. They've got all the reports ready. You stopped it at that.
Seen the MRI.
So
We don't know what the
somebody said that all that is done and it's not showing anything.
No.
He said that.
No,
See,
but
we
no.
confuse them because that's the problem.
We have not. The rectum must always be violated with an MRI, high resolution MRI.
So you want
must-
that, no?
You must
go back,
see
let's-
the
yeah.
stage, and even in ulcerative colitis, you give the radiation and neoadjuvant if the patient can tolerate it. If not, at least radiation to prevent the local recurrence.
I fully agree. This patient should be treated right in a malignant lesion.
Yeah.
So there is no difference. The only thing is that obstructed. The another option could have been maybe some first stage would be diversion and then neoadjuvant treatment, and then she absolutely right, say total proctocolectomy and ileostomy in the treatment in this patient.
That's MRI.
CRM is involved anteriorly. Definitely, diversion is followed by a
You do a neoadjuvant NACRT and
Actually, because it's a T4B, N2 the rectal growth, I would say that we should do a colostomy proximally now to relieve the obstruction, and or an ileostomy, and give this patient total neoadjuvant therapy.
Malignancy is proven. This patient to be treated as a malignancy, not as a benign disease, like standard neoadjuvant if it required, or straightaway surgery, depending on the site of the lesion and the stage of the disease, whether it is metastasis or not. Based on that, you have to take a decision.
so basically the message is, even if there is underlying inflammatory bowel disease, you treat it like a malignancy, what you would otherwise do for a malignancy patient.
One more thing is you should discuss with the patient. You have developed a malignancy in the setting of ulcerative colitis, which is a pre-malignant lesion. So your other so-called normal colon likely to become malignant in your future. So that is very, very important to counsel the patients. If you have decided that you want to do a total proctocolectomy and ileostomy, it's an excellent procedure in these patients. Try to convince the patients that your other so-called normal bowel is likely to become malignancy. If patient chooses that, actually many people choose that. Okay, if you can explain rightly, and these people will have an excellent the quality of life if they can choose end ileostomy when they develop malignancy.
So can you do only so you find that the virtual colonoscopy shows rest of the colon is not showing any other tumor and not much significant colitis. Would you do only a segmental left side colitis and do an end colostomy after all the neoadjuvant therapy? Why not?
because in ulcerative colitis it's a progressive. It will eventually.
No, if the patient has got long standing, okay, disease free, okay, this thing, if the patient wishes, you can, but this patient has to have a very frequent surveillance colonoscopy. But number one. Number two, when the patient already has got a lower rectal growth, if they got a permanent colostomy versus permanent ileostomy, there is no much difference. So these issues practically you have to consider.
Of disease and 100% chance of.
Yeah, these things you have to consider before
very clear
suggesting anything.
Okay, Manoj, just for the purpose of discussion, this patient had a lesion in upper rectum in a setting of ulcerative colitis. And now what surgery would you plan? Upper rectum, rest of the colon is normal, everything is normal. What surgery would you do?
Total proctocolectomy, the ideal pouch anal anastomosis can be considered.
You will do an IL pouch. Will you do a pouch
You might
surgery?
not require radiotherapy since it is upper rectal.
No, will you do a pouch surgery?
After, not at the initial stage, sir. After
You said
biopsy
the rest
report.
of the colon was normal.
Rest of the colon is normal. The lesion is involving the upper
Whatever the rectum below the growth.
rectum.
You said
No,
advanced upper rectum.
No.
upper-
what is the growth? What is the rectum below the growth? How is it?
no, I have not said this. I want to hear from you. That is why I asked the discussion. So there is a lesion in the upper rectum. So what would you do? Would you do a pouch surgery?
Yes, sir. Total procto.
You'll
What
give a
was-
sales pitch for pouch surgery, or will you give it in a? So it's very dangerous when you. It's obviously a controversial area. Isn't it? So give options again. This is the place you need to give options.
There are obviously two
Pouch is
options.
improving the quality of life. But if there's any doubt of quantity of life, then there are options.
There are three options in this scenario. One, obviously, neoadjuvant treatment and maybe anterior resection, low anterior resection, or depending on the site of the lesion. Then, suppose that if you want to restoration, so then you can do anal anastomosis, straight ileoanus. Obviously, the frequency would be high, quality of life. Third option would be the pouch anal anastomosis, it removes the entire colon. But if you leave the rectum behind, then you put the patient on regular surveillance. These are the three options for this patient.
If you leave the rectum behind, you have to do a mucosectomy.
No, Chetan,
Yeah.
whenever somebody gets colitis, malignancy and ulcerative colitis, there is always some degree of colitis which is persistent for many years. Doesn't happen that there is no colitis.
Agreed.
So I don't think we should send a message that there is a segmental colectomy is an option.
So
we have not said. So we have
That's
not
what I
said.
wanted to clearly say. You should never say segmental colectomy in ulcerative
So there is
colitis,
no question
whatever.
of segmental colectomy.
There's
It is
only-
always total proctocolectomy.
Even if it's ulcerative proctitis and the rest of the colon is normal, if the patient says I need surgery, otherwise I'm going to commit suicide, and you think you need to do the surgery, you have to do a total proctocolectomy.
The question is whether will you do a pouch or not? Will you do a pouch anal anastomosis, or will you do a straight ileoanal anastomosis, or what would you do? That was the question.
Or end ileostomy. That's a absolutely valid option. Please give that option in a malignancy of the rectum. If in a rectal malignancy you're not going to do, I'm worried. At this level, if you're not going to do, see, you're not selling a pouch to them.
Colitis, always give an option. Total proctocolectomy. Either restoration, permanent stoma, you should tell them if it is in the rectal growth, more possibility. That's it. But it has to be total proctocolectomy only, no segmental nothing. Because it's a field cancerization. If established cancer once, another maybe dysplastic stage. You cannot give a segmental colectomy option at all.
Stage, yeah.
What we do in a staged manner, you do rectal stump below the tumor, you staple it like Hartmann's procedure. What we do in a regular surgery, ulcerative colitis. Once you get a histopathology, you are okay. Then you completion proctectomy and ileal pouch.
Sudeep, yeah.
What is wrong?
Practical point. If you have a sufficient margin for an upper rectal growth, you'll have a very small rectal stump. You try and go in and do a pouch in this, it's a very difficult operation. You're most likely going to have a pain.
So basically the exam answer would be, you may do whatever. The exam answer would be, I would generally not do a pouch surgery I would
That
do
is
a,
not coming across. All of you seem to be selling.
I
a
would
pouch.
do a
Don't do
either
that.
this, if at all continuity has to be maintained, hand sewn straight with a mucosectomy.
Mucosectomy. The problem when you do a double staple pouch is that you have a straight line at the bottom, a circle on top. The corners are extraluminal. Even if you're doing a proctoscopy weekly in this patient, something happens in the corner outside the lumen and your recurrence practically face this problem. Your bilateral ureteric shock is the first symptom of recurrent tumor in a patient with ulcerative colitis. Actually died, who's 45 years old, who might otherwise have had a normal life because of this. But it doesn't work for a photo either.
But I must say, you all did very well.
Message is in ulcerative colitis, malignancy, be more aggressive.
Thank you, sir. We take a short break, tea break now, and reassemble back in 15 minutes time. The next session will start at 5:45. Welcome back to the sixth session. Students for this sessions are Zishan, Mohammed, Arti, Amit and Deepti. I would like to invite Dr. Avinash Supe, Yashwant, Dr. Upendra Rao, Dr. Ramesh, Dr. Sadiq and Dr. Biju for this session. You, sir. HRMS sir has left, sir. You can start.
Good evening, sir. Good evening, everyone. My name is Dr. Amit. I'm from Nizam's Institute of Medical Sciences. So today, my case is a 27-year-old gentleman from Jharkhand working in a marketing agency, presented with chief complaints of multiple episodes of epigastric pain for the past 5 years. History of presenting illness: he's a 27-year-old gentleman, apparently all right 5 years back. He developed epigastric pain which was sudden in onset, continuous type, moderate to severe intensity, which used to relieve with bending forward, associated with abdominal bloating with no relation to food. This used to interfere with his daily job and the requiring hospital admissions and IV analgesics. There were no other aggravating or relieving factors. The current episode in 2017, which was 5 years back, he had one episode of pain which lasted for a week, for which he was evaluated by a local doctor and started on analgesics, IV analgesics, and also he was advised, after the discharge, he was advised to take a tablet which was 3 times with meals. He complains that the symptoms were controlled with these medications, but over the period of time, he complains that he has occasional associated oily stools with intake of fat-rich meals. Patient was symptomatically better with these medications, and he stopped these medications in 2020. However, he developed similar episodes of pain, which was similar character, 3 to 4 episodes for the past 3 to 4 months, requiring multiple hospital admissions and IV analgesics, which led to his loss of his job. There was no change in character of pain. There was associated weight loss of 3 kgs in these 3 months, and also he complains of generalized weakness. There was no associated vomiting, nausea. There was no loss of appetite, no jaundice, fever, pruritus, no clay-colored stools, no abdominal distension or lump, no hematemesis, melena, or any history of blood transfusion, no history of visual disturbances, bony pain, nasal or gum bleed, no history of PR bleed. Coming to past history, patient had history of appendicectomy at the age of 7 years. Other than this, he does not have any history of diagnosed with diabetes mellitus, no history of tuberculosis, no history of or any other comorbidities, no history of any other interventions or surgeries in the past. Coming to personal history, patient is taking mixed diet with occasional, and patient gives history of occasional consumption of alcohol for 3 to 4 years, and he stopped since 2017 after the episode of pain. He is a non-smoker. Bowel habits, except for the occasional oily stools, he does not have any other altered bowel habits or bladder habits. Family history, there is no significant family history. Treatment history, he was taking, except for the IV analgesics and oral analgesics, and also he was taking a tablet with meals thrice a day for till 2020, after which he stopped it and developed the above-mentioned symptoms. And also presently, the patient has been admitted for the current pain management. The summary: a 27-year-old male with multiple episodes of severe continuous type non-radiating pain for the last 5 years, with the recent multiple attacks associated with non-significant weight loss, which relieves with bending forward and no other relieving and aggravating factors, with steatorrhea, with no loss of appetite.
Not associated with food also, right? No relation with food.
Would you call this steatorrhea?
Sir, he said that he has
No, you said very clearly that when he eats a fat-rich meal, he has oily stool. Otherwise, he doesn't have. So steatorrhea is a continue. He should always be having oily stool. So this is only occasional when he eats a specific food. So
He is not, he is probably a little deficient in his lipase, but he's not yet gone into steatorrhea yet.
How educated he is?
So he works in a marketing agency.
Okay. Who is going to tell us about the examination?
So what is your impression at the end of the history?
So at the end of the history, I would like to think of a chronic pancreatitis with exocrine,
Both of them.
with exocrine insufficiency and with intractable pain.
Okay. Who is going to tell us about the examination?
A patient.
Louder. Keep the mic close.
A patient was conscious, coherent, and cooperative, thin built, with a BMI of 18.5 kilogram per meter square and a performance score of 1. There was pallor, there was no ictus, there is no generalized lymphadenopathy or enlargement of supraclavicular node. There was no edema. There's no evidence of koilonychia or postural hypotension. There is no evidence of chronic liver disease. There was no bruises and conjunctiva was normal. Pulse rate was 82 per minute and blood pressure was 120 by 76 millimeters of mercury and respiratory rate was 16 per minute and was maintaining saturation of 98%. On abdominal examination, abdomen was flat. There was an appendectomy scar in the right iliac fossa and there were 4 ecchymotic patches in the epigastric region. Umbilicus was central. There was no dilated veins, pulsations, or any visible peristalsis. Spine, back, inguinal regions were normal. There was tenderness and guarding that was present in the epigastric region. There's no hepatosplenomegaly. There is no free fluid. There is no renal angle fullness or tenderness. And the rest of the inspectory findings were confirmed. On percussion, the liver span was 13 centimeter and digital rectal examination was normal and there was no malignant. So to summarize, 27-year-old gentleman who presented with recurrent episodes of epigastric pain over the last 5 years, was moderate to severe in intensity, with no aggravating factors, but relieved with bending forwards and IV analgesics, with occasional oily stools, and having no significant loss of appetite or loss of weight, with evidence of pallor and no ictus or any other evidence of conjunctival changes or dry skin, with 4 ecchymotic patches that is present in the epigastric region following a procedure, a nature of which the details are not known to us. So I would like to consider, given the nature and characteristics of pain, I would like to consider chronic pancreatitis as my first differential diagnosis.
The differential diagnosis you have in your mind?
Acid peptic disease, I would like to consider, sir.
5 years, colic pain. Much of IV analysis.
That goes against it, sir.
Tenderness and guarding on examination.
Yes, sir.
Okay.
So
what is the diagnosis?
So this tenderness and guarding, patient said that he underwent a procedure yesterday and 2 days back.
No. Okay. That is not the thing. First you tell and then explain. Okay. Don't try to create a paragraph explanation, tell the summary. Just tell what you want to tell, then explain.
Sorry, sir, can I please have the
No,
question?
you tell the diagnosis and then explain your reasons for that. Why the tenderness and guarding?
When
And your
you
diagnosis
use-
is chronic
Very
pancreatitis.
right, actually. Like this is the word guarding when you use, you should have clarity of thought. The patient of chronic pancreatitis, why should there be guarding? Tenderness we can understand.
The patient said that he underwent a procedure, so probably it was an endoscopic procedure, or we don't know what procedure he underwent. So if it was an endoscopic procedure, probably it was an attempted endotherapy, following which there was a complication, a possible complication, should be kept in mind.
Bye. Pain.
What other thing can cause with this history tenderness, guarding, and ecchymal thick patches?
I mean, acute exacerbation.
Ecchymotic patches, 4 sites, no? 4 areas.
4 spots.
4 separate areas.
Yes.
Cannot be
in the epigastric region.
Okay. So what do you think? Any other thing?
Acute exacerbation.
Oh no. Anything else? Do you think you have done some therapy with this? Or was it diagnostic?
I think it was a therapeutic one. Probably it was then ESWL. ESWL.
The patient with chronic pancreatitis, they present with the tenderness in the epigastrium and guarding. Do you have any other issue in mind? It can be due to acute pancreatitis also. Can it happen?
Yes, sir. Tenderness
Okay,
guarding
so
can
that
be
should
there.
be in mind.
No, but I'm not sure why there is confusion about what was done. You said endoscopic procedure, why patient, you have taken a history, there's an endoscopic procedure, you would say that there was a tube put and you had to undergo procedure. If you went for there is you should be able to give, so I don't know why there is confusion about what kind of therapy. Did we not approach enough to find out what it is? Because it's important. You've seen that there is recent exacerbation or these symptoms after the procedure. So one would need to have clarity about it. So I'm a little surprised that...
No, I asked her and she said that she didn't ask for those. I asked her whether he was sedated and whether...
No, I know.
You
She
should
said-
probe. Many times, most of the patients will tell either the
Yeah.
tube was put, or shocks were given, or
They will
something,
tell
or
that.
injection was given. Something they will very clearly tell.
Both procedures are unforgettable. No patient will forget if they are conscious, because endoscope they will definitely know, and the extradural, the shock is felt.
And most importantly, nobody would do a procedure without consent. The patient ought to know what procedure has been done. So, I mean, when you say that I don't know, some procedure was done, if it was done somewhere or in the remote past, one can understand. But just 2 days back, it's hard to believe that we don't know what procedure has been done. And it has a direct correlation with the acute symptom, isn't it?
So it seems to be that whatever the procedure was, it has precipitated the guarding, tenderness, and severity of pain today. So that is why you should ask that in more detail and examine it in more detail. The history should be taken in more detail and ask for that in more detail.
It just conveys to the state of examiners that you are taking a history more in detail and you are correlating with what is going on. You're not just blindly taking like tick mark. You're trying to look at relevance in the history, and that's all exactly what the examiner wants to see. When you present it like that and you feel blank that I don't know what has happened, it creates a little bad impression. I would really want you to go little detail and give some relevance to those points. Correlate guarding with that, it explains it quite.
Who is going to present what? No, please go ahead.
I'd like to order a hemogram, sir, liver function test, a renal function test, and then
What is
ultrasound.
your
Tell the
purpose of
diagnosis.
investigation? Tell me in
PPT,
this
please.
particular patient. Now, in this particular patient, would you not like to know what has been done before? What procedure was done before? Would you
Yes,
not have to
any,
get those
any
details
previous
at this
available
stage?
investigations
If they are available.
if they are available.
What investigation you want?
I'd like to previous in any ultrasound that has been done previously, or any other imaging that has been done, and any previous liver function test and serum amylase or lipase was done during the attacks. Previous attacks.
Do you have any previous investigation?
Old CT is available, sir.
I leave
Old
that.
planes.
Ultrasound is not available.
Old CT is available, sir. Recent ultrasound.
Okay, we will go. He wanted the blood test. Just quickly show him the blood test.
Nothing significant.
Nothing significant. Next. Again,
Renal function.
everything is normal again.
Right.
Liver function.
Normal, yes. Okay, so all these tests which you asked for are normal. Now what do you want? Ultrasound report, please.
Serum amylase and lipase.
Okay,
Anything?
that is one. Anything else?
Random blood sugars are fasting and postprandial.
You need to know,
Yes.
no?
Yeah, you
You're
need to
dealing
know.
with chronic pancreatitis. You want to see whether the patient has diabetes, right? Both.
I think an HbA1c should also be done because sometimes that may give you in the long term. If it's a little higher, then you know that he occasionally probably had high sugars.
So you know what the mistake you did? Okay, you started telling the blood investigation. You told routine. Now the question asked, you missed thing. So what examiners will think that you missed the blood domain. So you finished the blood domain. Now you shifted to ultrasound. Now the sugar is coming. Okay, so the problem is you are not told the diagnostic investigation first. After the diagnosis, you might withdraw more blood, no?
One of the way back, if you go back, you gave emphasis more onto the exocrine deficiency. You did not really say in history or examination, you never emphasize about the endocrine deficiency evaluation based on an history. That has to be also emphasized in a patient who has a long history. Though I'm sure 5 years is a short time, but still you have to really look whether you really look for any endocrine deficiency.
So in the history, a specific mention that there is no history of diabetes mellitus, rather than telling everything, this should be stressed so that people understand that he has no diabetes mellitus. So there's your ultrasound report.
Regular in contour. Main pancreatic duct is infiltrated 11 mm with multiple large calculi, largest 7 to 5 mm. Peripancreatic edema in the tail, no fluid collection. Spleen is normal, sir. Kidney also seems to. Rest of the findings are normal. Finding is suggestive of chronic calcific pancreatitis, dilated PD and.
I want to ask you now one question. This particular patient, just forget that any procedure has been done. This patient comes to you with the history and this sonography. What would be your approach? With 17 millimeter, how much, what is the stone they said? I am not able to.
17 into 5.
A large stone, right? So, and how much is dilated?
11 mm.
11 mm.
11.
So what is your approach? How would you approach this? Would you do ESW like what they have done, or would you go for straightforward for surgery, or we would like to just try painkillers?
Before taking a decision, sir, I would like to do further investigation. I'd like to do a CCT abdomen.
Why you want a
Why do
CT
you
now?
want?
Tomorrow you want a CT. What is the diagnosis here?
Chronic calcific.
You heard the history. You heard the examination finding. You heard the ultrasound report. What is the diagnosis? So tomorrow you can operate this patient?
To make a decision whether the.
What is the problem? What you are staring at you, which is little bit different from chronic pancreatitis here?
large calculi.
Large calculus is part of chronic pancreatitis. No, what else? What other is
Very
written?
pancreatic edema.
So what is that?
Could be.
So you started telling about CT right now. You want a CT right now? No, this is timing is not. So what is the diagnosis now?
Acute exacerbation of chronic pancreatitis. Acute.
So also, Zishan, what is important to know is when is this ultrasound done? Was it done prior to the procedure or post procedure? Because you had some symptoms started post procedure. So whether this peripancreatic edema is post procedure. So you have to find out that this ultrasound was, when was it done? Since there is an intervention. Although Dr. Supe, you forget that. So when you say forget that, then you also forget for a moment maybe the peripancreatic edema.
Post procedure, today morning, sir.
So post procedure.
This was done today morning. This after
Maybe
the
it is secondary to the ASW. See, the problem in these patients will come is that you have a 5-year patient, 5-year history, and he has severe symptoms with a large stone, dilated duct. Now, this is where endoscopies versus surgery should come. Are you going to do upfront surgery in this patient, or are you going to try multiple stenting and ESWL and all?
So let's ask in the sense, how do you decide the treatment paradigm for a patient with chronic pancreatitis? Diagnosis is staring at you. Now you have to decide what treatment, medical, endoscopic, surgical.
Name Arti. Static question. Speak into the mic. These are all
being
old
transmitted.
mics like this.
Yeah, they are being
Hello.
transmitted. Yeah.
Sir, so this patient is already on, is not responsive to any oral and also on IV analgesics. So I would at least consider to give some kind of endoscopic therapy or surgical therapy to this patient. So the stone, sir, before knowing whether I can go for endoscopic procedure, I should know whether what is the exact site of the stone. Multiple strictures are present.
So you
or not,
need
or the
more
proximal-
information, right?
Yes.
Yes.
So
More
the
information.
answer is that since the patient is severely symptomatic, requires either frequent analgesics or admission, he needs some therapy. The kind of therapy which we want to provide to this, I would need more information before I make that decision. So
That
one-
more information that you want.
Another question. Is it obstructive or is it because of some other reason why he's getting pain? Would you not like to know all that information before you decide what you want
Yes,
to do?
sir. Yes,
So tell me what information you want to pick up from a CT scan in this particular time.
Yeah, sir, I would like to know whether it is already given that the duct is dilated. The duct is having multiple calculus. This large calculus, each of the calculus, so that if it is proximal, then we can go for endoscopic therapy. But
You are talking based upon ultrasound? Here we have only ultrasound.
No. Only on ultrasound you're talking about?
No, she's saying
She just
why wants the CT, what she will look at the CT and what she will do
We have
according.
only ultrasound here. We have reached only at this stage. No.
She's telling, we have asked her what next she will do. She said CT.
Did you
So we
ask
said why
her,
CT?
why do you want to do CT? What are you looking for in a CT?
So she's saying this. Have you got the CT pictures?
What investigation you want now? You want the CT? I want to do MRI. Why you committed for CT?
Sir,
Okay, MRI will work beautiful pancreatic duct. Will show whatever information.
Sir, we can also know about pancreatic parenchymal calcifications and if
That
there
can
is
be
any
seen in
head
MR?
wounds.
It will not be seen in MR? Why you opted for a CT?
There is any presence of any mass, then and pseudosis, then it can be picked up.
The best investigation for a pancreatic mass, CT or MR? No, you jumped into the CT. So before jumping, just you should be aware about this. Want to do?
Most of us would do a CT. I think as the first investigation, except for one or two situations. For example, if you're looking for a broken pancreatic duct following trauma and you want to see the duct, maybe there an MRI to see whether there's a break in the duct. If you want to stent it, you may. But most of them CT will score. So we will do CT. And
pick relevant points where CT would score over. So I'll start off. For instance, plain scan will give you the calculi the best. MRI will, you may actually miss, you may have a packed duct with calculi. You can miss the entire calculi if it's packed.
If you want to see ductal anatomy, you're quite right. Our hospital, the protocol is MRI pancreas with MRCP and plain CT. So,
okay, so that is the protocol, but then that will be make it a costly protocol. Oh, then it's okay. Okay, so most of us would, I would look for a CT first and do an MRI if I'm interested in the ductal anatomy for any reason or in any other reason. So, can you tell us something about this CT scan?
So this is a plain scan, axial sections showing multiple calculi, largest in the head region, with body, and multiple pancreatic calcification can also be seen in the last section.
Do you think this is a good CT?
6 section.
Simple answer. Is it a good CT? Today morning we talked a lot about negative contrast.
What is pancreatic protocol by the way?
And
Are you aware?
pancreatic and normal contrast orally. So here you can see the small intestine, the stomach, all outlined by the positive contrast. Okay. So when you're looking for calcification, you don't need any positive contrast in the abdomen because it may hide if the bowel loop comes over the pancreas and there is contrast, what is behind will not be seen. So especially because you're looking for calcification. So you don't give contrast at all, or if you give water as negative contrast, then it won't be seen. Okay.
Is it a good CT? What is your answer? Sir was asking, no? How do you know it is a good CT? What are you looking for first?
First, the sections are very.
That's all fine. With respect to chronic pancreatitis and pancreas, what are you looking for in a CT? Whether it is there or not, you check and tell.
I'm not able to see the pancreas parenchyma very clearly. That the duct. Plain scan.
Oral contrast. So this is a very good example of where an ultrasound would be probably as good as CT because the very in CT the fatter you are, the better planes.
If you can move towards these films like this, now the other way around. Now you look at this picture, and this is where the confusion will come. You see in the tail area, there seems to be what seems to be a large calculus. But there's actually, when you follow, is part of the bowel, the positive contrast. And why is that important?
Because then it would change the plan of management.
Yeah, so what is the change of plan of management if you have such a large tail calculus?
No,
If you have.
no, and we cannot try any endoscopy because.
Yes, so calculi in the tail is a contraindication for endotherapy. So, okay, so this confusion can be avoided if you don't give the oral contrast. That's why I didn't like this CT. So, we don't have a newer CT, is it? No. X-ray is available, a plain X-ray or MRI, whatever it is. Okay, so that's your MRI, and so what does it show?
In duct with irregularity, stone in mid of pancreas.
How do you know it is stone?
Stone or a color. Defect is seen.
Somebody is telling, no. Be clear.
Please remember that the CT scan you saw was done in 2017. And this is done now. So don't try to think of that and then superimpose it on this finding. 5 years, lots of things can change.
So the point is, the patient underwent an MR. You want to see the MR first or MRCP first? No, before seeing that and coming to here and interpreting, what is going to happen? You are not seeing the MR images, T1, T2, but you started interpreting the MRCP. These questions are going to come and you are going to be in a difficult situation, whether it is cyst or stone.
Filling defects can be seen in upper right image.
Speak a little louder.
Yeah, sir, this is the dilated PD showing this filling defects as calculus.
No, you are not running your checklist, okay? Exam MRI in a patient with a chronic pancreatitis with a peripancreatic fluid collection is what you are examining. You should have a checklist in what all I am going to look for. You first jump to duct and stones. That is not the correct approach. No, you should know which are the areas to be seen first and then start commenting one by one.
Yeah, first, sir, this is the MRCP showing normal gallbladder, normal CVD. Pancreas parenchyma is not seen.
Is this a T1 or a T2 image?
Sir, T2.
Okay. When is pancreas best seen?
Yeah, T1. T1.
T1? So because that's the most fat laden structure in the abdomen. So that is best seen in T1 images. So that you should ask for the T1 to see the pancreatic structure first. Then you can come to the T2 to see the fluid and the ducts.
While the image is being getting loaded, you have to mentally prepare yourself that what all I'm going to look at, and that information how you are going to use to make the decision for which we started, no? That what kind of therapy we want to offer. So start thinking. So I mean, Dr. Biju said you have to see a lot of things, but let's just concentrate on pancreas for now, because we are looking at pancreatic pathology at this.
I would like to see pancreas parenchyma first, whether there are any calcifications. Then in T2 images, then I will see the duct, whether it is dilated, how much is the diameter, whether there are any presence of stricture, whether there is any dominant stricture at one side.
They don't have any T1. Because always you can see the spinal cord. You can see the spinal cord and all the pictures. So they don't have any T1 images.
Yes. Yes.
Because they can't record and transmit.
What complication makes surgery very difficult for you?
Which you may see better on a CT scan.
Portal hypertension.
Yes. So what type of portal hypertension do chronic pancreatitis patients have?
Splenic vein thrombosis in
A sinistral portal hypertension, yeah. So we have a large number of stones, mainly concentrated in the head and uncinate process. The tail and body doesn't seem to have any stones. That is what we have found on the CT and the MRI. And there's a dilated pancreatic duct. So what treatment option you will choose?
Sir, I would give endoscopic treatment option first for the patient. The patient is young and any.
In your institution, do you have the endoscope for pancreatic lithotripsy? No. See, this is the problem. Now I asked you what treatment you will offer, and then you said lithotripsy and endoscopy, and you don't have that option available. Because
What does age have to do with the choice of procedure?
Yeah.
You just said that because the patient is young, you want to offer endoscopy treatment.
Does long-term pain get relieved well with endoscopic therapy? What is the evidence and what is the level of the evidence today?
Sir, early surgery is better.
No, what is evidence? I'm telling you. See, the evidence is very clear. It's a level 2C evidence. It says that the endoscopy may relieve early pain, but long-term surgery pain relief is better with surgery. This is what currently evidence level we are.
The 4 randomized trials published have shown exactly
this. So we have to now think, what are we offering to this patient, and based on the anatomy, what is your first choice, what are you going to explain to the patient, and then decide, okay, this is what you want, what is the patient's main symptom. He does not have any mass, he does not have any complication like portal hypertension doesn't look to be here, at least on a CT scan. We don't know, this is 5 years CT scan.
But even on the MRI, there is no splenomegaly, nothing.
There is no pseudocyst. There doesn't appear to be any other complication. So the main problem is pain, stones, dilatation. So you have to really decide and tell patient both things very clearly, what it is going to relieve.
Also, the CT scan which you saw in 2017 had large volume of stones in the head. Actually, large volume of stone in the head, especially, is a poor prognostic indicator for endoscopic therapy.
Yes.
So,
And also, please remember that the lithotripter used for pancreatic stones is different from the lithotripter used for kidney stones. So in many hospitals, they do the lithotripsy with the kidney machine, and the results are very poor. And Dr. Nagi Reddy and Amit Medev have repeatedly pointed out that you should have a pancreatic stone lithotripter specifically. So there's a difference in the way it delivers. So that is another point to remember, that if you don't have that, then you can't offer this endoscopy treatment.
No, and see, in many times in practice, we see this. Patients are sent by endoscopists, they'll put a stent, patient gets relief. But when you're talking in an exam and you're looking at the evaluation of the patient, you should have also clarity, what is the current evidence, what are RCTs, what is the level of the evidence, what are we really relieving, short term or a long term. And as Sadiq rightly said, a patient who has a multiple stones in the head and he has a pain which is not going for 5 years on IV and all, on a young patient, if you feel that the primary surgery may be better, you put your opinion like that.
This
There's nothing
patient
wrong about
actually has what in the kidney we would call a stag-on calculus, literally.
To make things easy, in a surgical gastroenterology exam, what are the indications for definitive indications for surgery and definitive indications for endotherapy? Tell us.
Definitive indication for endotherapy.
It shouldn't be like
I don't think Ashok will say that. I told you absolutely based on what is the science today, right? Evidence today.
Endotherapy, if it is a proximal stricture.
Single stricture, short-term stricture, small stone,
No calcification
obstructive
of
symptoms. I think that will get relieved with the endoscopic therapy.
It needs to fill all the check boxes. So there's a out of 100 cases, only 10 will be suitable for endotherapy. So to say the way you said it is, in a microwave I can put either a. Now most microwaves do not accept. There's no point in saying that as an option. for transplant, for any malignancy, you have to fill all the check boxes. They should be not going to say transplant is an option first, no? You started out with endotherapy. That's a problem. It's not about surgery and medicine. For endotherapy, you need to fill all those check boxes to go there.
I mean, crystal clear, this CT scan, and I was continuously pointing out to you that there's a large number of stones. Crystal clear, this is not a good case for endotherapy, even in the best of centers, because the stone load is very heavy. Even if they do endotherapy, he will finally end up, if not today, a year later or 2 years later on the operating table.
Multiple large head and
So what is your plan?
since the duct is dilated, I would go for decompressive procedure.
Okay, shall we ask some other candidate also to answer? What is your approach to the treatment for this patient?
So first of all, this patient is having pancreatitis.
Listen,
Take off your
listen,
mask. You will be able
listen,
to.
listen 1 minute. Don't describe the patient. Sir, I asked, what are you going to do in this patient? Tell what are you going to do, then explain. Don't create a scenario that my answer will be correct in the end. Okay? That will not work out, no?
So you tell what you're going to see. That's what again and again. Answer the question asked, then defend the answer.
Once the patient is settled of acute pancreatitis attack, which he is having now, I will plan definitive surgery for the patient considering the age of the patient.
What do you mean by definitive surgery? What surgery will you do for him?
What surgery is there?
Phrase procedure, sir, for this patient. Phrase procedure will be ideal, sir.
Okay, so don't say surgery because a number of operations. You could do a Frey, you could do a Pusto, you could do so many operations. You could do a Whipple also. Some people with such a heavy stone load might decide that a Whipple may be a better option.
Sir, my question was, is there any definite surgery for chronic pancreatitis? Can you offer a definite surgery for chronic pancreatitis? This surgery is doing for what purpose?
Pain relief, sir.
Palliation.
Palliation.
Do we have a definite surgery?
No, sir. No, there is no curative surgery.
So we have a variety of surgeries and you practice one of them. Some people have a preference for one over the other.
99.
So as per imaging, there is no any mass lesion or inflammatory mass in the.
Will you tell patient that steatorrhea will continue to remain or it will get relieved with this surgery?
It is not going to relieve with the surgery, sir.
So what are you going to tell patient that after this phrase procedure I'm going to do?
We need
what
to.
will we get relieved? What will not get relieved? What are the likelihood of the prognosis which is likely to happen?
Surgery is purely for pain relief, sir. And for steatorrhea, we need PERT for the patient, sir. Later after the surgery or before the surgery also, sir.
Will this prevent patient going into diabetes? Will it delay it, prevent it, or will it really not happen or something like?
Whatever exocrine or endocrine insufficiency is there, it is going to be there.
Is there any evidence to say that you relieve patient of his obstruction and pain, the diabetes gets delayed? Is there any kind of an evidence
in the initial stages, sir? In very early
So he is in initial stage or is in a late phase?
In this, practically there is no parenchyma in the pancreas, sir.
So he is only going to develop diabetes, you mean?
There is some evidence for
Yes.
non-alcoholic.
There is one paper by Nelan.
Neelan and all. There's one Italian, there's one Indian also.
And they have shown that
Non-alcoholic, they may be if you do early enough. That's not an indication for doing it non-painful diabetes.
non-painful diabetes, we don't use that. We don't tell them that we will really prevent diabetes and operate. So we don't do that.
Pardon, sir? Release.
Is it done in India?
Do you know the ESCAPE trial?
Yes, sir. ESCAPE trial is early surgery versus endotherapy in the chronic pancreatitis, and the trials clearly shows that early surgery.
Does it define what is early surgery, which is the question? Does it define early surgery as? Medical and endoscopy. Medical therapy followed by endotherapy. No, sir, that's surgery. Patients did go for surgery, but they are managed as intention to treat. So, but how do they define early surgery? What is early surgery? Is it based on morphology? Is it based on any other criteria? Are you aware of it? No, I don't. Anybody knows?
Please use mic and put this.
Early surgery is defined as less than 3 years duration from the onset of symptoms, sir, and less than 5 endoscopic procedures and no narcotic dependence.
It's related to the intake of requirement of narcotics over a period of time.
Weak opioids, sir, for less than 2 months.
2 months.
And strong opioids for less than 6 months in 2 years duration.
Weak opioids for 6 months and strong ones for 2 months.
So in India, we generally don't use opioids in the management of pancreatic pain because it's a
narcotic
prohibited
law
drug and
that.
requires a lot of writing and careful auditing, and otherwise you can get into a lot of trouble. So we generally don't use it. So we don't use it. Now somebody talked about the medical management of chronic pancreatitis. So apart from endotherapy, what is the medical management of chronic pancreatitis?
Lifestyle modification of alcohol and smoking, diet modification, frequent small meals.
High protein diet can cause pain also. That also can precipitate pain. So moderate protein, but low fat. Yes.
Low fat and antioxidants, sir.
Antioxidants very important. Yes.
Antioxidants and for exocrine insufficiency, pancreatic enzyme replacement therapy. And apart from that, analgesics based on the.
Do you give pancreatic enzyme therapy for pain?
There is some indication, sir, in a small subset of patients it may benefit.
What is the problem with giving pancreatic enzyme replacement therapy for pain?
Sometimes it can cause
No. The pancreatic enzyme that is advocated for pain relief is uncoated pancreatic enzyme. All our traditional drugs that are available in the market are all enteric coated and they are for replacement therapy. So for pain therapy it should be uncoated, and there is only one company which has now come out with uncoated uncoated pancreatic enzyme now. So, and for pain you should use that, but for enzyme replacement therapy, when patient has steatorrhea, you use the rest because you don't want it getting broken down in the stomach.
And the biggest problem in our country is the cost.
Cost.
The kind of dose they advise, 40,000 per meal and 20,000 per snack. I don't think our patients can afford it for a very long time. And most of the patients take underdose actually, I realize.
But you said that you do phrase. Why phrase for this patient?
For this patient, sir, the morphology has a dilated duct with multiple calculations in the head and as well as the body of the pancreas, sir. And in phase procedure, we lay open the entire duct. We clear the duct of all the calculi and we put the head also.
No, you are not answering the question. No, see.
Why head coring? What will happen with head coring?
Yeah. If you do only say lateral pancreaticojejunostomy, do you think his pain will go away?
And short-term relief will be there. The long-term recurrence is
So
higher
again,
with
don't
lateral
go into theoretical answer. Do you think lateral pancreaticojejunostomy will be able to drain all the head ducts?
No, sir. The secondary ducts it will.
Then why are you
Exactly.
going into there's some
Simple
evidence
answer,
of-
no.
You say,
So
"No,
the head
I need
is
to
the
decompress the head."
The answer
head is the driver of the pain.
pacemaker of the
Pacemaker for the pain. So the head has to be. So even if there is no mass, it is probably wise to do some coring of the head. It may be less than when there's a mass, but I always core all my pancreatitis in my unit from the head. And when you have so many stones in the head, the only way to clear them all would be a proper head core.
if you go to even literature of phrase, no, there are different years people have been doing different levels of phrase. I mean, it's not that phrase is done one particular operation. The coring part is sometimes deeper and all. So the solution to that is you look at the kind of drainage which you achieve at the end of the phrase. If you are able to core it well and most of the stones have come out and you are able to drain the whole thing, that the level you go, then only your pain, even if there is no mass, you should achieve the drainage properly. And that is what you should really
Can
achieve at the end of
somebody
the phrase.
tell that how do you go about doing a phrase, like steps 1, 2, 3, 4, and what are the critical aspects of doing a phrase procedure?
Huh? Okay. See, there are too many people watching you, all of you, what you're answering and what you're not answering.
Yeah. We usually do rooftop incision for phrase, sir.
Oh.
So in our unit, we use a chevron incision.
Talk little louder, beta.
In our unit, we use a chevron incision, and we open the lesser sac and expose the pancreas and cauterize the duodenum.
Why do you cauterize the duodenum? You are doing nothing behind the duodenum.
So, but we'll have to have a control of the posterior aspect of the
Why?
pancreas.
Why
because
control the posterior aspect?
Because it is important during head coring not to breach the posterior capsule.
If you breach, what happens? You can just suture it. It's a fibrotic pancreas, nothing happens.
No,
What is the
what is
most
the problem
important
with the-
reason for cauterization?
What is the problem with breaching? Breaching is applicable only if you mobilize, no? The retroperitoneum will be there, otherwise it will be stuck to the retroperitoneum. You, in that position you core, what is the problem?
One
So
is,
coring is not to prevent, cauterization is not to prevent the breach.
one
You are
is-
actually exaggerating the breach by taking the duodenum out of the retroperitoneum.
One is to know how much we have cored. How much of coring has been done, whether it is adequate or not. And the other thing is for hemostasis.
The most important is the hemostasis. So sudden bleeding, you have your cauterized duodenum in your hand behind, you can just put your thumb, stop it, get your instruments and control it. So it's important for the bleeding. And in a case like this, the bimanual palpation will tell you the stones, where they are. Then you can cut on the stone, remove specific, open all the ducts and everything.
So how do you decide that you are going to do adequate coring? Actually, before going to coring, how much you have to have an exposure?
So we'll have to make sure that we have exposed the uncinate duct and the main duct as well, and extend it till the tail.
What do you have to do that maneuver?
So we'll have to first localize the duct and
No, before localizing the duct, you have to do a maneuver. You have to do something specific. Something to do with the loop of Henle.
ligate the loop of
Yes,
Henle,
you have
sir.
to ligate and divide the loop of Henle, because if you don't do that, the head of the pancreas is not exposed. You cannot do the coring. So that you have to specify. Always ligated or whatever you want to do, and it is divided.
And also always get and expose the lateral border of the superior mesenteric vein. Because unless you know that, you don't know how much margin you would be able to leave. So make an effort to expose that. So that way, now you have lifted the, cauterized the thing, you have the head in your hand, superiorly you have cleared the gastroepiploic artery and the GDA is exposed, and laterally or medially you have to expose the superior mesenteric vein so that the head is completely exposed for you to do any maneuver. What about the body and tail?
We have to extend the incision till about 1 centimeter from the tail parenchyma in order to.
Do you do anything to make sure that you expose the body and tail better?
We have to make sure that the splenic vessels are.
What did you say? 1 centimeter from the tail, you extend the which incision?
No, sir, should make would be the lateral extent of the ductal drainage.
1 centimeter from the tail of the end of the tail.
So one of the things which you have to do is release the pancreas from the retroperitoneum. Means the inferior border of the pancreas to incise the peritoneum, put the mesocolon down, incise the retroperitoneum so that the pancreas presents itself into the. Also, sometimes the superior, the splenic artery is very close to the superior border of the. So you have to be sure, especially in an atrophic pancreas, if it is very close, you may either incise inadvertently or your sutures may go through it and may develop a pseudoaneurysm as of it. So you have to do the exposure. So you said in the passing that I want to cauterize it so that I know how much coring to do. Is that how you make out, or are there any landmarks in coring?
So either we can, when we start coring, it can be just the parenchyma, and then we need to core it till the posterior
You
surface of
explain
the
what you
ducts now.
actually do. Okay, don't think about theory. Okay, you start the surgery at the head region. You start the surgery at the head.
Lay open from the.
This patient you have seen the CT.
Yes,
Where
sir.
will you start the surgery? Now exposure is over. Now where will you start the first surgery on the pancreas?
From the neck part of it, sir, because
The
it's where
patient
it
you
is
have seen the
actually,
CT.
From the neck.
Neck or body?
Neck
Or
is where you should not start, because it is behind the neck that the portal vein lies. So you don't want to go there first.
from the body of the pancreas.
Yes, you start to the left of the. So that's why he said, look at the superior mesenteric vein and then go well
How
to the
do you-
left.
I think one of the common problems, if you don't do all this, patients post-operative will have a huge bleeding. So what he said was very right. You have to really lift it up, separate those vessels. Otherwise, the stitches go through that, and on the fourth or fifth day, you find massive hemorrhagia. Or something like that.
So how do you identify the duct
So one means
to lay
like
it open?
we can aspirate and see whether the pancreatic fluid. We can aspirate the pancreatic fluid
At an appropriate point where you
when it
palpate,
is supple, or
or
How do you do it laparoscopically?
intraoperative ultrasound.
Have?
Not sure, sir.
what is the other way? Aspiration. Then
Bring the head.
no, still you are still in the body. What else can you do?
Be able to palpate the stone.
Right.
Exactly.
So if you palpate the stone, you, cut
palpate, you
on the stone.
Just right.
and you know
Sometimes on a
that-
laparoscopy also you'll be able to get that lung haptic feeling. You can get a stone, and that's where you probably begin, especially if you're doing laparoscopically, and open the body about 1 or 2 centimeters on the left hand side, because that's where it's maximally dilated, and then you extend on both sides, and then head coring you should do last, and you should end at the head.
So no stone palpable, no duct palpable. Then how will you identify the duct?
Intraoperative ultrasound. We can use ultrasound. Intraoperative ultrasound.
Okay, if you don't have, do you have?
Then and only then you can start the dissection in the head, because you can core the head. You know where the superior mesenteric vein. You come well to the side, core. Whenever you core, you will open one or the other duct. Then you can follow that duct and go laterally. If you can't in any other way feel the duct or find the thing, very rarely we can do that. Usually not required if it's a good dilated duct, but sometimes if you're operating on an undilated duct, you will have to do. What other treatments are possible for chronic pancreatitis you can take up? What other treatments are possible? These are all the surgical ones we have said. Any other surgical ones you know? Last question, because they've rung. Is that the overtime? Yeah, last question.
The surgical options are there is a head mass, and we can go for Whipple's procedure.
No, we have done all that. People has been covered. All these operations have been covered. Any other procedures you know? Something new, something that is not done commonly here, but can be done outside.
Needles.
What is islet cell transplant? Islet transplant.
Pancreatectomy.
So how do you do that?
Pancreatectomy, and then we harvest the islet.
So when do you do that? Do you know when you do that?
Be clear, no. This is chronic pancreatitis, islet cell, function, everything. That is what sir is asking. Function, everything you have to remember. You are isolating the islet cell from this chronic pancreatic tissue. Auto. The patient does not have severe exocrine endocrine insufficiency.
So it is done before the patient loses the pancreatic reserve. Yeah, so it will do nothing for the exocrine. It is only for the endocrine. And so the patients have pain, abdomen. They will do genetic markers which will say that these patients are prone for chronic pancreatitis. If you let them go even past the age of 20 or 21, they have irreversible diabetes. All the islets are destroyed. So in the United States, when they are 15, 16, they will take out the whole pancreas, give the patient unconscious on the table, go to the lab, harvest the islets. It takes about 2 hours to mash the pancreas and then harvest the islets, and then come back with the islets and inject it into the portal vein so that it will go and colonize the liver. It's not overwhelmingly successful. About 1/3 successful, 1/3 it reduces the need for insulin, and then 1/3 it fails. But the very happy thing to know about this is that the two largest centers that do the work are the University of Minneapolis in Minnesota and the University of South Carolina, and both the directors of the islet transplant programs are Indians, and both of them are from Tamil Nadu. Yes. No, there are two of them. No, one of them is.
One of my register does it. I'm very.
The one at Johns Hopkins is also there. Two are with us. One is his student. Two are from my college because they have trained for in Bellore for their PhD also.
No, but I think what he said is we had a lot of discussions with him, but as he rightly said, the results are still we have to see. But I think this is still, yes, it could.
It's just to complete the topic. That's all that question was asked for. Okay, we can have your case captain.
64-year.
Transplant.
Sir,
How
one
many?
doubt, sir.
How much successful? That's a problem.
Tell me, Habibullah sir used to do this very often, no? That was
Hepatitis.
not the ancient. But how do you manage exocrine deficiency with all?
That's pills only. Pills, no other way. Otherwise, you have to do pancreatic transplant. From the cadaver, take the pancreas and transplant. Again, so. No, but people have done a lot.
Okay.
Vaidya had done many in
Can I
Apollo.
request all of you to stop and let's go to the case capsule?
Yeah. So we won't discuss the investigations and the history because you just read it out. We'll go straight to the management.
64 years male resident of Telangana working as a businessman came with chief complaints of epigastric pain for 6 months.
Sir, one doubt.
Yeah, please.
Patient with pancreatitism and chronic pancreatitis. Should we go for a dorsal sphincterotomy initially, or can it?
What did you say?
Pancreatitism.
Yeah.
Divism with chronic pancreatitis.
Yeah, so the first line of management, if they don't have multiple stones already and across both ducts, then you can do the dorsal sphincterotomy endoscopically
And see whether there's a pain relief.
and put a stent and then remove it after 8 weeks and see if there's pain relief. There's no pain relief, then you'll have to do like a phrase.
Sir, I have a question. So, what is the panel's opinion about ligating GDA during phase procedure?
Not necessary. Nobody does it regularly.
I don't do it regularly.
I don't think everybody
No,
does it
Shrikant
regularly.
in Bangalore does it routinely. He told me.
I know.
That's what Shrikant does that always. He told me.
Why? But incidence of bleeding.
You do. Ligate in continuity always. Yeah, but I don't do it. I don't know about others.
I don't do it.
You may not do GDA, but anterior branch of the
That will come on the pancreas.
that is okay.
that you can do in continuity
That is the
and I always make a transfixation suture on that because when you cut, there will be always bleeding in there. In order to have the control in the cut part, which can bleed later, it's better to have a transfixiation on the pancreas under the pylorus.
We will move to case capsule.
See, I personally feel pancreas has so much of supply from
Other vessels also, yeah.
By ligating one vessel in continuity, can you really avoid the risk of
Remember the pancreas, the pancreas, weight for weight, gets the most blood supply in the human body. You know, you'll have the upper and again the lower, that whole thing continues. So when you pour, both sides you'll have to either, so I usually use a bipolar, but once in a while, as he says, if it's large, take a stitch across it.
Sure.
64-year male came with chief complaints of epigastric pain, history of vague, dull pain, not radiating in the epigastric region for past 6 months, which increases on taking food and subsides on taking medication. No other complaints. Past history, recently developed diabetes on oral hypoglycemic drugs. No other significant history. Personal history was not significant. Family history not significant. General examination, moderately built and nourished, well hydrated. No signs of liver failure. No other significant findings. On inspection, abdomen is normal. No visible veins, peristalsis. On palpation, it's normal findings. On percussion, liver dullness is from 5th intercostal space, 11 centimeters. Flanks tympanic, fluid trill absent. Auscultation normal. Distal rectal examination normal. Rest of the systemic examination is normal.
Okay, so one of you can take up this. What is the diagnosis?
The history given, it can be peptic.
This is the diagnosis.
history, no?
The diagnosis is dyspepsia. That is clear. Okay, he is dyspeptic because
many of the
his symptoms will
epigastric
fit
pains
dyspepsia.
will come. We'll have.
So what else he could have?
Same differential diagnosis you said, no, liver, pancreas, and all that, retroperitoneal. So what will you do first? Ultrasound. Okay.
Can you-
Everybody agrees with ultrasound.
Yeah,
Sure.
because the history doesn't and findings don't lead us anywhere. I know. Ultrasound I want.
Okay. Depends upon which he goes to GI or he goes to surgeon.
Okay, there is the ultrasound report.
Liver is normal in size with the homogeneous parenchyma lipodextral.
Yeah, you need not read the normal thing.
There is a
Read whatever is abdominal.
gallbladder. There is
Poor
smooth
window
wall
of head
thickening.
of pancreas. Dilated PD.
Pancreas, poor window at head of pancreas with dilated pancreatic duct noted in the distal body and tail of pancreas.
Tell what quickly next, no?
Spleen is normal.
Now you have a clue as to why he is having a problem. What do you think he has?
Yes.
Yeah, so what will be there?
Have a chronic pancreatitis.
Chronic
Can be chronic
pancreatitis.
pancreatitis with this finding.
You can't.
Dilated poor window seen there, seen a duct in the body and tail. What is diagnostic of chronic pancreatitis here?
Maybe, sir, because the pancreas is not
So
completely.
don't commit. No, why you are
Don't
jumping
commit.
to that?
Don't commit.
We have got some clue, but we are not very clear what it is.
It could still be just a
Anything.
stricture somewhere, an amp, because the poor window and the thing. So what will you do now?
This finding, I would like to evaluate him further with the
Please don't tell complete what you want for diagnosis. What is this complete hemogram? You go to the hematology lab, so many things will be there.
sir. Actually, I want to get
ठीक है. CCT after creatinine. ठीक.
He is asking you what is your diagnosis.
not able to come at a particular diagnosis.
Yeah. All you know is pancreatic duct is dilated in the body and tail. You don't know anything beyond that. Okay, so some pathology in the pancreas we think. and it fits in with the history that he eats food, he gets pain or whatever it is. So,
Did somebody read it? Actually, will read it. Read it. Can you just put it on full screen if possible? Okay.
This is an axial section CT scan of the abdomen with lower lung fields, which was visualized lung fields appeared to be normal. So this is the plain film. Coming lower down to the abdominal part, liver generation looks okay with normal parenchymal structure with no obvious SOLs. No.
What is that?
no, rather than telling the negative findings in others, tell whatever positive you're seeing, and then you can come to the negative findings in the thing. Because sometimes the examiner may then skip the negative and go on. So tell what is positive.
Coming to the pancreas, there appears to be a dilated.
Yes, fairly dilated duct it is actually, at least.
And then what?
Along with some thickening, some mass at the head region, head and body region.
Yes.
Describe
What is
the
that?
mass. Describe the mass.
It is a hypoattenuating mass.
Is this a contrast CT?
No, sir, this is a plain.
Then how can you say hypoattenuating? And you're comparing it to the liver. Hypotense compared to the liver, yeah.
Is it a mass? What are you seeing? Is it a mass? How do you know it is a mass on plain CT?
So there is an enlargement with some cystic.
Enlargement of gland is a mass. Can it be necrosis?
So it is difficult to comment.
Can it
on
be
the-
necrosis?
Can be.
So why did you comment on mass? This is the problem. No, plain CT can be necrosis.
Don't commit. We would like to see more films.
No, but necrosis would have caused
It is not
inflammatory
necrosis,
signs.
no, definitely.
It would have caused, unlikely to cause a dilated duct. And it is definitely enlarging in size as you go lower down on the cut. So to call it a mass, I won't disagree. I would agree.
There is also an hyperdense structure.
There is also something else there. What else?
Yes, sir.
Yeah, that was important. See, that is the critical finding, that there was calcification in that mass. Okay.
Coming to the arterial phase. Coming to the arterial phase, liver again looks normal, sir. There is no obvious IHBRD or looking at the pancreas. There is a dilated pancreatic duct with atrophy of the surrounding parenchyma.
I'm not sure. Excuse me. Looking at that liver, to just say that it is normal, look at that left lobe, the way it looks like a small leaf, and the way I have a feeling that this liver has some chronic liver disease. I'm not sure it is normal. Sudeep, what do you say? No, look at the liver. I'm saying the shape. Okay. You agree, then it's okay. Okay.
The pancreas, sir, there is diffuse dilatation of the pancreatic duct from head, body, and tail.
Head, where is the duct dilated?
Body and tail. So it's a head part.
No.
Neck.
No, it's not there.
Innate process, head, neck, and body and tail. SMA and
SMA is not in contact with head. SMA is in contact with head, neck, and uncinate process. Correct? How will you know it is head? That was the question.
the duodenum.
Tell that, no? Are you seeing duodenum in that cut?
No.
So
now you can see the duodenum.
Yes. The mass was present at the neck.
So the superior mesenteric vein is not the artery. The superior mesenteric vein which passes behind the neck of the pancreas, dividing it head and the body.
The splenic vein and the supramesenteric vein just forms there, no portal vein.
So that is the neck is the landmark is the superior mesenteric vein. So this seems to be to the right of the superior mesenteric vein. So more in the head, but probably extending a little into the neck. Not that it's not in the neck.
What are you seeing? Describe it.
So it is the diffuse
Arterial phase.
The arterial phase, after visualizing the complete pancreas, that is the body, tail, neck, head and body, there is diffuse enlargement of the pancreatic duct, along with the some enhancing structures inside the pancreatic duct.
Very outpatient. Mike Sadiq.
Is this the mass which is there in this cut?
So this is the dilated duct.
This is not.
Where is the dilated duct? So there's no mass here.
There is.
There's a mass there,
Yes,
no?
yes.
Right? So now you want to go up and see what is happening to the pancreas distally. Just can you scroll up, please?
Up.
No, just go up a little more till that duct dilated duct up. Yeah. Now what are you seeing?
To see the dilated pancreatic duct.
So you can see the tail and part of the body. The duct is dilated and it is getting occluded by this mass which is present in the body and neck of the pancreas. Now describe the mass. What is happening on the arterial phase?
There is enhancement of the mass on arterial phase, heterogeneous enhancement
Yes.
on arterial phase.
Let's go down now. Just keep on seeing the relationship of this with the vascular
Yes.
structure.
At this point, the duct is not visualized at the level of mass. Then going proximally.
Now saw that.
Now what do you see?
Again, this is extension of the mass.
Is it solid or cystic?
So it can be, it is along with cystic and it is heterogeneous, along with some enhancing component inside it.
Yes, it is mainly cystic, but there are some areas where there is a lot of enhancement which can be seen. Are you able to see septae?
No, sir.
No. Yes.
Also want to look at the relation of the vascular structures with the. Yes. Now we'll be going down and we'll be commenting on. Yes.
Stones. Periphery, center, in the mass, in an enhancement.
Peripheral and in the center.
I disagree. This is the problem of a contrast CT. If you remember your previous plain CT, they were all in the center. They were not in the periphery. The periphery, I think, are the vessels outlined by the contrast. The ones on the wall now, I think they are the vessels because
Yes.
they were not seen on the plain CT.
That's the city in the center, what is showing.
That is what was the
Stone. Rest are all what seeing peripherally probably are the vascular.
the vessels.
Yeah, and that's the duode. Now you're seeing the.
That's not the duodenum.
I think this is the septate.
That's the cystic
Still
part
cystic part?
inside.
Portion.
No.
Yeah.
Yeah.
Yes, it is dilated.
Would like to consider IPMN, sir.
Yes. Good. Very good diagnosis. That's what we have been looking for. And how will you confirm your diagnosis?
We Should do a EU. Yes, sir.
You can see the venous phase also, please.
A less invasive way of diagnosing it than UH? Any endoscopy will help you?
You gave it the game away. That's okay.
They are not very common. Even if you are able to make a diagnosis and go further, I think this is more.
So this is the finding. As he has already said, you have to do a side viewing endoscopy. So the mouth of the duct will be big, and you will see mucin coming out.
Have you done that? Show me.
Show that.
Okay.
This is a
Fish
video.
mouth papilla, large amount of mucinous papillary orifice. You have video or it's just a...
Only images.
Okay, only image. Show more images if you have. Get it correct. Perfectly.
So this sort of diagnoses it. What are you going to do for it?
Would like to do additional tests. Would like to get tumor markers as well.
No,
And,
but what do you feel? I mean, IPMN is one,
think it's a
but
plain
then what
simple
is
IPMN?
along with IPMN? What is there? It's not the end of the diagnosis, right? There's the IPMN. There is
And
the
there is
mass.
chronic,
There
calcium.
is enhancing structures in that.
Yes, mural nodule was
So what is the diagnosis?
End of type.
with high risk features.
Most likely malignant.
Maybe a malignancy on top of it. You know, the solid lesion which you saw.
Partially enhancing, no?
Partially enhancing. So how will you prove? How will you prove this? What will you do?
So I would like to get a US
Spyglass
biopsy.
cytology, no? And collect
Spyglass
that
cytology
fluid.
is one.
Collect markers.
US and FNB from the solid neural part, if they can see it, is another. And you could do an MRCP to see the ductal structures, how they look, and then you can sort of decide. If you run in US, main duct IPM with communicating cystic mass. Have they done a biopsy from that?
Actually, I wouldn't do a biopsy. You have a chance of infection. Anyway, this is an indication for dissection.
No, that's okay, but what is the harm in doing a biopsy through the duodenum?
You infect these IPM. Unless you have to do a biopsy.
Okay, but
You know, it's a borderline indication of resect, not to resect. Diagnosis is not clear.
The problem is that many of these insurance companies insist on biopsy nowadays. So I don't
Cytology
know
would
whether
give
you
a
have
diagnosis.
faced that, but
Oh.
many of them are insistent. Then you will say that you did it was negative. At least you,
This requires
yeah, maybe.
What are they implicating? MCN? It's IPMN only, no? It's a type of an...
No, the cystic mass means what? That could be the dilated duct which they are seeing, the hugely dilated duct which we saw. That as a second time they are saying is a cystic mass. The very dilated duct, the uncinate process duct that you saw. So what operation he is saying you should resect this? It's an indication for resection. I agree with him. What operation?
The patient will require Whipple's procedure.
Ripples will be enough for this
No,
patient?
sir, extending the resection to the left of
How left?
SMV.
Why not do
We'll have
total?
to get a frozen, we'll have to send the main duct for frozen section and see whether there is dysplasia.
Can you do a duodenum?
What consent do you take from the patient?
We would take consent for total pancreatectomy, sir.
Yes, total pancreatectomy. You could try
To
duodenum
conserve.
preserving total pancreatectomy, and if the duodenum looks good at the end of it, the color looks good, and the CBD is not badly injured, and you are able to drain it, I think you may get away with it, which may be a slightly lesser operation than a Whipple with a total pancreatectomy. So, duodenum preserving total pancreatectomy is an alternative that can be thought of. Not easy to do, but you have to preserve the arcade so that the duodenum doesn't get. So, to dissect there, it is a little tedious, but it can be done.
And even if doing extended Whipples, it's also a very tedious operation. You have to take that age, you don't know how much of pancreas you are saving, what is the importance of that.
No, extended Whipples won't be enough. You'll have to do complete
only,
pancreatectomy
basically.
because the duct is dilated in the end. So we don't know whether.
We are not really
or
going
you'll have to take
save lot
frozen
of
section at
pancreas. Exactly,
margin
definitely.
and see whether you can.
And maybe given
Pancreatoscopy.
Yeah.
so given that there is hardly any pancreatic parenchyma left, probably doing a total pancreatectomy would be better, or
Patient is not diabetic before your
He is diabetic. No? He's diabetic.
Yeah,
No.
he's diabetic.
Recently
No.
diabetic. Recent diabetic.
Yes,
yes,
diabetic
yeah.
is there. I would agree that I would probably do a total pancreatectomy because of the size of the duct, the likelihood of lesions being present, and the amount of pancreas after you get a margin which you're going to leave behind is very.
The thin rim
not
of
very
pancreas.
And if
The
it
huge
leaks,
duct.
it will be
So-
more headache rather than doing anything.
So
preserving the duodenum very valuable.
yeah, we are not about the duodenum. We are talking
Talking
about
about the
distal
tail.
pancreas.
Tail.
And I
would start the other way. I would actually start from the tail.
would
See whether
preserve
I can preserve the head.
splenic vessels. I will
can
try to
preserve the head.
preserve them. Yeah.
Actually, do a distal. It's much safer than doing a Whipple.
Sorry?
Do an extended distal, left extended pancreas, because there's hardly anything in the tail.
Yeah. We are
The head
all
is
saying the
big.
same.
We are all saying the same.
We are all saying the same thing, but you
So
want
can
to say it,
preserve
it's
the,
okay.
The duodenum, that's so worthwhile.
Yeah, we agreed to that right in the beginning.
That's what he said. No, you try to keep a rim of thing and try to say if it's not blue, then you can treat it.
IPM and malignancy, which rarely conjugal dilatation.
Considering the age of the patient, 65-year-old female patient, he is right now on OHA. Should we consider saving the last part of the pancreas with frozen section on table?
The last tail, if you try to save, if you look at it, the duct is dilated and there is very little parenchyma. So I don't think that even if you save that, she will go on to insulin. So she will not be able, at that stage, she won't be able to manage with an OHA. Now, whether she takes 10 units of insulin or 20 units of insulin, it doesn't matter. The problem with the total pancreatectomy is not the insulin actually, because the insulin can be easily replaced. The problem is that they become hypoglycemic severely at times, and that is because the hormone is not available. What is that fellow's name?
Glucagon.
Glucagon is not available. So that is the biggest problem, the hypoglycemia. So they have to be cautioned. So they should always carry some sweets. The problem with diabetics carrying sweets is that they'll keep eating it all the time. I have had that problem before, so I stopped carrying it. So
But now there's all CGMS. No, you put all that control and all that electronic mechanisms have come. I think it has become very electronically.
pumps.
AI has come into that picture. No, now.
Yeah, but the insulin pumps also require that they have to be changed the vial, then they have to change the needle every 2 weeks or so. So it's better than every day getting 5 injections, but it has its own problems. And the total pancreatectomy, as I told you, the main problem is not the hyperglycemia, it's the hypoglycemic attacks. And that can be really bad.
Also, the frozen section is not an easy thing to read in these things. Also, you may have skip lesions. So as you said that you can do a scopy and identify abnormal areas and take biopsies, but reading of these on the table and getting the
But when you have such a
is not an
dilated
easy
pancreas
thing.
from tail, Sadik, up to the head, everything is dilated. I think maybe. Yeah, so we do. Okay, we can try to preserve. Yes, agree. I think that duct is of the uncinate. I don't think
Yeah, there's a huge duct in the uncinate.
Uncinate won't be perfect.
Yes, sir. We have done duodenal preserving this total pancreas with splenectomy.
Did not keep any ring, right?
Small rim is left over the duodenum.
So they have, see, so
I wanted to ask you that uncinate process, duct which was dilated, what was the histopathology?
We are yet to get, sir. It was done yesterday.
yes, so they have done and the duodenum color was okay.
Yes, sir.
Yeah. So they preserved the
Yesterday.
rim. So the arterial margin is preserved. So they were able to save the duodenum. Now, the duodenum is a very important organ. Please don't ever underestimate it. Don't do a Whipple just because you feel like doing a Whipple. It is probably easier to do a Whipple with a total pancreatectomy than a duodenum preserving. But it is worth the trouble. The patient is much better off with the duodenum intact.
When you get a localized dilatation to the body and tail, what is the investigation of choice? Is it CT or MR? Let us say they removed the term of bowel gas. Bowel gas is not issue, but you are seeing isolated dilatation in tail and body. What is the investigation of choice? And even now, asking you whether MR is indicated in this patient.
Yeah.
MRCP. Why do you do pancreatoscopy on? What is IPM and actually? Do you understand IPM?
Field cancerization, sir. So there can be other mural
Please don't put
nodules.
new
that is-
terms and all that. It just applies some logic and why do you need a ductogram in IPMN or not?
Any additional mural
Mural
nodules which are
nodules.
Actually, what Sudeep said is the perfect thing. Do MRI with a plain CT.
Yeah, that was
I
the
think
correct-
that's very
that's
logical.
very
I
logical.
think.
And I would also like to have a vascular reconstruction of the CT scan prior to surgery, to especially see the arcades and see which, if there's an accessory arcade, something, then you have to be a little more careful of that.
Why do you need a total pancreatectomy? What is the philosophy behind advocating a total?
If you're
That
planning for
context,
if
do
you're
you
planning
need
for if you're planning for total pancreatectomy, we would not require an MRI. But if you're planning for a Whipple's procedure, then
So anywhere IPM you do total pancreatectomy?
it's a diffuse ductal disease.
The ductal disease, sir. There can be skip lesions anywhere in the duct.
MRCP or MRI will help you.
Yes.
What is the best investigation? What imaging of choice is?
MR plus MRCP, sir.
Okay, I think so. Thank you. Thank you so much.
Thank you. Thank you, sir. We'll move on to the next session. This is a GI radiology session. I would encourage all the residents to come forward, occupy the first two rows. Some of you can come in the front. There are no faculty here. So this is an interactive session. That's the reason I want you in front. Come forward. Rachan. Ajo. Samne ajo. All of you come forward. This session is basically to help you read images in exam. That's all. If you want to pass, you need to read an image, whatever is put up, either CT, MRI. I have two announcements to make. One, you will have dinner here after this session and then you will be transported back to your hotel. Tomorrow morning will start at 8 sharp. So I want all of you to come here and occupy your seats by 7:45. So please get up early, have your breakfast and then come down here and be here by 7:45 a.m. I'll hand it over to our radiologist.
The pointer.
Hello. So ma'am is Dr. Gayatri. She is a senior consultant here and she is the lead for transplant imaging. So first of all, she is speaking on evaluation of liver tumors and she'll also be talking about how to do volumetry in liver.
Hi, good evening all. I'm Dr. Gayatri. I'll start with the very basics of liver anatomy first, segmental anatomy especially. So this I'm sure all of you must be familiar with. We are looking at 8 segments in the liver in the coronal plane, where we divide the left and the right half based on the planes of the hepatic veins. So the median fissure, which is not so anatomically evident, is the fissure through which the middle hepatic vein runs, dividing the liver into the right and left anatomical halves. Whereas the falciform fissure, which is anatomically more evident, is the one through which the left hepatic vein runs, and the right fissure is the one, again not anatomically very evident, through which the right hepatic vein runs. And to divide the liver into the cranial and caudal half, we take the help of the plane of the portal vein, especially where the right portal vein takes off from the main portal vein. Now to look at it in the axial CT images, we again take the help of hepatic veins. So the right, middle and left hepatic veins divide the liver into the right and left half and respectively into the anterior and posterior segments. So to localize on a cranial and caudal section, as we can look at it on the image here. So cranially, we know we cranial here because we're still looking at the caudate lobe, we're looking at the IVC, we're still not looking at the kidneys, the adrenals, or we've not yet reached the level of the portal vein. So we know we are in the cranial section of the liver in a given single axial image. So trace the right hepatic vein, the middle hepatic vein, left hepatic vein. The left hepatic vein is not so easy to trace. It could be smaller in caliber. So we take the help of the fissure for dividing segments 4 and the left lateral segment. So the right anterior and posterior planes are again with the help of the right hepatic vein. Middle hepatic vein is to divide the right and the left lobes. Now caudally, so we know we've reached the caudal segments when we've seen the portal vein, and especially we've seen the right portal vein take off. So once we come to this level, we know we have reached the caudal segments. So we look at it clockwise. So from inferior to superior, or rather from caudal to cranial in a C shape, in a clockwise fashion, we have segments 5, 6, 7 and 8. Now apart from all this is the caudate lobe. So how do we identify the caudate lobe? Caudate lobe is that which is just anterior to the IVC and just medial to it, and posterior to the level of the portal vein. And then comes the Cantley's line. So Cantley's line is an anatomical projection. It is a approximated line extending from anatomical landmarks. That is, posteriorly it is the IVC, then along the diaphragmatic aspect of the liver, the cranial surface of it, caudally extending up to the fundus of gallbladder. So going through these three planes on a surgical specimen, or rather once you open and you're looking at the liver in the coronal plane, the approximate plane through which the middle hepatic vein runs will be this. So dissecting along this plane will be equivalent to dissecting close to the plane of the middle hepatic vein. Now looking at the liver anatomy, coronal plane. So coronal plane is that in which the surgeons are going to be looking at the liver. So the moment you open the abdomen, you look at the liver in the coronal plane. So to extrapolate the CT anatomy to the plane at which the surgeons are going to look, we as radiologists have to get used to looking at images in the coronal plane, because normally radiologists interpret everything in the axial plane, but we have to switch over to the coronal plane to understand the liver anatomy from a surgeon's perspective. So anterior most, as soon as we look at the frontmost cuts of the liver on the coronal plane, the first thing which generally hits us is the segment 4. So segment 4 and then the left lateral segment. And it's only after that that we're going to look at the right lobe, which is segment 8. You go a little posteriorly. We then see the middle hepatic vein, and then we know that we are having segment 5 and segment 8, and medial to it is segment 4. So generally, as a rule, the first thing that hits us anterior most, just above the gallbladder, is bound to be segment 4. Everything to the left of the falciform fissure will be the left lateral segment. And once we see the middle hepatic vein, we can then confidently trace the plane between segments 4 and the right anterior segments. So segment 8 and segment 5 are what we're going to see first. And after this, so here we're seeing the left portal vein, and after that is the IVC. So between the portal vein and the IVC, the segment here, the medial most, is the caudate lobe. That is how we identify it. Look at it between the portal vein and then the IVC. And then as we move posteriorly, we begin to see the posterior segments posteromedially first. So anterolaterally are the segments 5 and 8, and posteromedially will be segments 7 and 6. And further posteriorly, all that we see will be segments 6 and 7. So that's the coronal interpretation of the CT, which is segments 5. Will somebody want to take this? Describe and localize. Right, 4A. And in terms of description, yeah, it's hypodense, homogeneous. It has very thin, imperceptible walls. So that's a word to be using. Very thin, imperceptible walls. There are no enhancing walls. It is hypodense, it is homogeneous, but there are almost no walls. So those are the characteristics of a simple cyst. Can this be a hydatid? Yes, there is a possibility. But generally, when we don't see even a thin rim of wall, it is very, very unlikely. But there is a type 1 which could still be. The WHO class 1 can still be. So it's important for us to scroll along the entire length of the cyst, look for any area where there's even a mild wall thickening, and then we also have to raise the suspicion of any kind of a complicated cyst or a hydatid. So we have two axial MR sections. This is the T2 and this is the T1. So how do we make out T2 and T1? CSF, yeah. So CSF is what we should go by, because everything else there can be a mimic. Is this with or without fat suppression? It's without fat suppression because we're seeing hyperintense subcutaneous fat. So what could this be? First, to localize. Yeah, it's segment 4B. We are caudal here. We're seeing the adrenals. We're much lower down. So this is the caudate. It's just to the right of it. So description wise, this is a complex cyst. It is a cyst with multiple locules inside. And how's the signal intensity? The cysts and the locules are all T2 hyperintense. But apart from that, on T1, we can see that the larger cystic component is hyperintense on T1 as well, not following the normal fluid signal intensity. So what could a T1 hyperintense component in anything be? Fat is one possibility, but we're looking at a cyst here. It's looking like a cyst overall. It can be mucin. Mucin. anything containing proteinaceous mucinous contents can be hyperintense on T1. So this is a biliary cystic neoplasm having T1 hyperintense mucinous contents. So will we call it a biliary cyst adenoma or a cyst adenocarcinoma or a biliary cystic neoplasm? A biliary cystic neoplasm is a safer term because this could be a cyst adenoma or it could be a cyst adenocarcinoma unless we seeing obvious enhancing solid components on a post-contrast study, or unless the lesion appears really heterogeneous and the margins are not so well defined, we can't be sure if it's a cyst adenoma or a cyst adenocarcinoma. So we will just call it a biliary cystic neoplasm. It's a multiloculated cyst where the largest of the locules also has T1 hyperintense contents because there is mucin. So this is a biliary cystic neoplasm, which is again why it's not a hydatid, but hydatid can still be a differential. Why would there be T1 hyperintense contents in a hydatid? We would generally not expect, but any other condition where you see T1 hyperintense contents? Sorry, biliary communication? Blood, yeah, it's blood elements. Blood elements can be T1 hyperintense, but it won't be this homogeneous. We tend to see some layering because the blood products tend to settle down and hemosiderin tends to settle. We'll see layering. It will not be this homogeneously T2 hyperintense. You will see layering and some hypointense areas on T2 as well. Localize this. Is it pre or post contrast? Why is it post contrast? Contrast in the aorta and in the vessels. Is there any sequence that can mislead you into thinking that it's a post contrast image? Any kind of a T2 hyperintense sequence? There's a sequence called BTFE. It's known by different names. It's known as Fiesta on GE. It's called BTFE on Philips. So this is a T2 weighted sequence, a GRE based sequence where both bile and any kind of fluid, even blood elements, can look hyper. So watch out for it. Again, look at the CSF. CSF is black. So this is not a BTFE, any kind of a T2 weighted sequence. It is a post contrast image. So contrast in aorta, can you localize this? Cranial or caudal segments? Cranial, you're seeing the heart. All right, you're seeing two structures here. Okay. There's one here and one here. So this is the middle hepatic vein. It's difficult on a single slice. It's easier when we scroll up and down, but even on a single slice, once we see this, we know this is the MHV. This is the right hepatic vein. So this is in segment 8. So this was a patient diagnosed with CA rectum having a solitary liver metastasis. So if this patient was being planned for a metastatectomy, this is localized to segment 8. It's not encroaching into any other segment because we know it's not crossing the planes of the hepatic veins. So MHV and RHV to localize. All right, so focal liver lesions, before we go to characterize any focal liver lesion, the first and foremost thing is to see the liver morphology, whether it is cirrhotic or non-cirrhotic, because that changes the entire description and the way that we're going to look at the lesion, whether we're going to give a Lyret's classification or not, whether we're suspecting a HCC or not. The next is solitary or multiple and any known primary. The other is always assess a liver lesion only in a multi-phase post-contrast image, never in a single phase, because it can be very, very misleading. Always do ask for a multi-phase, never in a single phase, unless you know there is a definite primary and you're only looking for metastasis. Even in that case, it is better that we do a multi-phase because it could still be a hemangioma being mistaken for a liver metastasis. So to characterize, as far as just characterization goes, these parameters are good enough, but beyond that, to give a better report from a surgeon's perspective, one is location in anatomical segment, which segment it is coming into, whether it's encroaching beyond a segment, whether it's crossing the plane of any of the hepatic veins, because that completely decides what kind of a resection needs to be planned. The next is vascular anatomy to the liver, arterial, portal and venous. Look for any accessory veins, accessory arteries, any aberrant arteries from any other area, portal venous anatomy as well, and vascular involvement by the tumor, biliary involvement by the tumor, and of course nodal and peritoneal metastasis also for staging. Now, apart from all this, the other important thing to look for is to look for the liver quality, whether there's any steatosis, any fibrosis or cirrhosis, because the future remnant liver function is going to heavily depend on this. Normally a 30% remnant, though it is good enough, it will not be good enough if the liver is not of great quality if there's significant steatosis or fibrosis or cirrhosis. So not only assessing the location and the characterization of the lesion, but also the liver quality before any kind of resection is planned. So does someone want to take this? This is the most common liver tumor. Hemangioma. So how do we describe this? Puddles, yeah. So the most basic thing that everybody will come across, puddles of contrast in the arterial phase. So how do we decide which phase this is? It's by looking at the density of contrast wherever it is highest. So density of contrast is highest in the artery, in the aorta here. So arterial phase, portal, same, venous, same. So the way we describe this lesion is, it is a neoplasm whose density parallels the blood pool. So even in a cirrhotic liver, once we see a lesion whose density of contrast parallels that of the blood pool, we right away call it a Rayleigh's 2 or a benign lesion. So density paralleling the blood pool is the important feature apart from the pattern of enhancement. So how do we read a hemangioma on an MRI? There will be certain conditions where, there will be certain instances where we might prefer to do an MR over a CT for hemangioma. Because even without a contrast, the way a hemangioma looks on T2, the signal of it, it's almost called the light bulb sign. So no mass containing, no solid liver tumor, which is otherwise also hyperintense, will look this bright on T2 weighted image. So there are certain sequences called heavily T2 weighted images where we prolong the TE and the hemangioma looks brighter and brighter despite that. So that helps differentiate hemangioma from any other kind of a solid liver tumor, which might also show a similar kind of enhancement. For example, a neuroendocrine tumor metastasis can also be hypervascular, at times might be difficult to differentiate from a hemangioma. So an MR here helps because it is really, really bright on T2 like we can see here. So first we define the liver morphology. We know for sure it is non-cirrhotic. The margins are really clean. So here we have the axial T2 fat suppressed and T1 images. Does somebody want to read this for description? Okay, so overall the lesion is slightly hyperintense to the liver parenchyma on T2. In addition, there is a further hyperintense signal in the center in the form of a scar. And it's overall hypointense on T1, especially the scar is hypointense. And this is post-contrast, arterial, portal and delayed phase. So in the arterial phase, it is definitely hyperenhancing compared to the liver parenchyma in a non-cirrhotic liver. And in the portal phase, we see that the brightness is more than that of the surrounding liver. So there is no washout. So by definition, washout means that the quantum of the signal intensity or the amount of enhancement in the lesion should be less than that of the surrounding liver parenchyma, which is primarily because the main supply to a HCC is going from the artery and not from the portal vein, unlike the rest of the liver parenchyma. So this is not showing washout in the portal phase, and in the delayed phase we can see that it is still retaining contrast and the central scar is actually enhancing further than in the previous phases. So what do you think this is? It is a focal nodular hyperplasia. So why not an adenoma? Central scar favors a FNH over an adenoma, but it doesn't rule out. So do we have any sequence? Yes, homogeneous enhancement always favors an FNH over an adenoma, but this is not really homogeneous. There is a central scar. Why not a central necrosis? So is there any other sequence which help us clinch the diagnosis? So there's a hepatobiliary phase. So we only have one contrast in India, that is an MR-based, gadolinium-based contrast in India, which is multi-hands, which is also a hepatobiliary agent, meaning that you can do a delayed scan and there will also be biliary excretion. So hepatobiliary agent is always used in our institute and we always use multi-hands. So in the hepatobiliary phase, FNH is almost the only region. We'll rule out a few exceptions. Those are really exceptions, but a lesion like this, which is arterial phase hyperenhancing, showing no washout and showing contrast retention in the hepatobiliary phase, is almost always an FNH, because FNH is almost like a hemangioma where there are no normal biliary radicals formed, wherein it can't excrete the normal contrast like rest of the liver into the biliary tree, which is why the contrast gets retained and appears bright on the hepatobiliary phase. So in India, if you want to do this phase, your center will have to use a multi-Hans contrast because that's the only hepatobiliary specific MR contrast available in India. Now, in places where this is not available, the other way to clinch the diagnosis would be a technetium label sulfur colloid. So even here you can see that this is on the same patient. There is retention of the tracer within the FNH, which is not seen in any other kind of a lesion. So these are the two sequences which help differentiate. So like I mentioned, a closed differential will be an adenoma. So this can almost be mistaken for an FNH. It's showing near homogeneous enhancement on contrast in the arterial phase, and there is no washout in the subsequent phase. But look at the hepatobiliary phase, it is definitely hypointense related to the surrounding liver parenchyma. Not only that, you're seeing a few other lesions also. So this is a case of adenoma. So a hepatobiliary phase or a technetium label sulfur colloid are the main parameters to go for when we want to differentiate an FNH from a small adenoma. Adenomas when small can be a very, very close mimic to FNH, but when large, they don't behave the same. So when they're large, there can be areas of hemorrhage, there can be areas of necrosis. So all of these, so this is one case, this is another case, all of which are adenoma. This is an adenoma with hemorrhage. So this is an adenoma where there is heterogeneous arterial phase hyperenhancement, and there's also surrounding hyperemia in the liver parenchyma, no significant washout. There's areas of necrosis. It's very, very difficult to confidently call this an adenoma. We will definitely have to think of a differential of a HCC. There's no way we can confidently call this an adenoma. But once an adenoma is larger, it can show areas of necrosis, calcification, hemorrhage. But when small, it can be a very close mimic to FNH. Both are arterial phase hyperenhancing lesions. Alright, so we need to define whether the liver morphology is cirrhotic or non-cirrhotic. We'll define how the liver is cirrhotic. So the most important feature is an irregular liver contour with or without ascites and the presence of varices, a dilated splenoportal axis, splenomegaly, all of this. The other important feature is lobar volume redistribution, where the caudate lobe and the left lobe show relative hypertrophy when compared to the right lobe. So how do we make out? Okay, so the other feature that we look for is widening of perivascular spaces. So in a normal liver, the perivascular spaces are not so evident, but they are evident in a cirrhotic liver. Widening of perivascular spaces or fissural widening is the other important feature. So how do we make out if the caudate lobe is hypertrophied or not? So there's an index called the caudate to right lobe index, also called the Harbin's index. So how do we calculate this? We draw two parallel lines anteroposteriorly. The first line is drawn along the leftmost margin of the caudate lobe. The next line is drawn to the right margin of either the portal vein or where the portal vein bifurcates to give off the right portal vein. So there is a modified index and there's a classic index. Both are acceptable. And then once we've drawn these two lines, we draw a line perpendicular to it exactly between the portal vein and the IVC. And here we measure the ratio between this and this. That is the ratio between the transverse diameter of the caudate lobe and the right lobe. The normal values are acceptable between 0.6 and 0.7. That's the normal ratio, acceptable ratio. Anything more than 0.7 is unequivocally considered caudate lobe hypertrophy. We don't right away call it cirrhosis. It could be hypertrophy due to any other reason. There could also be a Budd-Chiari. It could be a pseudo hypertrophy due to any tumor because of a compensatory hypertrophy. But we call it a hypertrophy if it's more than 0.7. An example, this is a cirrhotic liver. We've drawn the lines. This is 4.5 and that's 5 centimeters. So the index here comes to 0.9. This is unequivocal hypertrophy of the caudate lobe. Alright, so SOL in cirrhotic liver, we always give a classification of Lyretz. So this has been created by the ACR, the American College of Radiology, and this is applied only for patients with cirrhosis, or even those who are non-cirrhotic but with high risk for HCC. So many places only accept chronic hepatitis B. Some places also accept chronic hepatitis C for defining Lyretz, but mainly it's only for cirrhotic liver morphology. So these are the criteria to always look for. The most important criteria is arterial phase hyperenhancement, non-rim. So this is a very, very important point. There has to be enhancement in the arterial phase within the substance of the mass and not just along the rim. The next is washout, delayed capsular enhancement, threshold growth seen over an interval of at least 6 months, and then the absolute size. So absolute size is also important because an arterial phase non-rim enhancing mass, which is less than 10 mm, will never be classified as LIRITS 5. It's always given only a LIRITS 4, even if it has all the other characteristics. So this is how this LIRITS is always available anytime for us to look up. But LIRITS 5 is never given to any mass which is less than 10 mm, even if it's arterial phase hyperenhancing. And it is also never given to any mass which is not arterial phase hyperenhancing as well, even if it shows all the other features. So these cases will either need a biopsy or a follow-up depending on their absolute size and the presence of AFP elevation or not. So will somebody want to take this? Which sequence is this? T2 with fat suppression, yes. So what are we seeing here? How's the liver morphology? It is nodular. So it looks like a cirrhotic liver morphology. We're also seeing ascites. There is a T2 hyperintense lesion in the right lobe. We look at the post contrast. Late arterial, portal, equilibrium phase. So over a background of cirrhotic liver morphology, there is a T2 hyperintense lesion in the right lobe, predominantly involving the posterior segments, also probably the anterior. What else we see is there is arterial phase, non-rim hyperenhancement, and there are definite areas of washout. Look at these. So any area which is hyperenhancing in the arterial phase showing washout is taken as unequivocal washout. So this will not be called just a HCC, but we will give a LIRITS category to this because it's a cirrhotic liver morphology. There are some areas. So the even late portal phase. So we'll have to look at a relative. Don't look at a single phase and expect a washout in the immediate next phase. So we have a late arterial, we have a portal, we have an equilibrium, and then we have a delay. So even if you don't see washout in the portal phase, in the subsequent equilibrium phase, if you're seeing washout, that is good enough. The thing is, relative to the surrounding liver parenchyma, the density of this or the signal intensity of this has to be less compared to a previous phase. That is good enough. That's still acceptable. If you see some areas of unequivocal washout, that is good enough. That's still good enough. Yes, this will be an LR5. Not on contrast. On T2, we could see a few hyperintense areas. These could be anything. These could be regenerative nodules. It could just be heterogeneous nodularity of the liver parenchyma, which is seen as part of any case of cirrhosis. So this is the arterial phase in another patient. Are we seeing a definitive mass? Are we seeing a definitive mass with arterial phase hyperenhancement? But there's something else that we're seeing here. We are seeing enhancement and vessels along a place where we don't expect to see them. And where is that? This patient's AFP was in thousands. Yeah, it's an arterial phase. So there are diffuse infiltrative types of HCC where we might actually not see the mass, but the only evident thing could be a tumor thrombus inside the portal vein. So this is an enhancing portal vein tumor thrombus where you can actually see neoangiogenesis within the portal vein. There is just subtle heterogeneous enhancement in the surrounding liver parenchyma. So this was a large, diffusely infiltrative HCC where the predominant finding was a tumor thrombus in the portal vein. So this can also be a presentation. Here we call it a TIV. So LR5, beyond LR5 is tumor in vein. So this is an LR TIV. So this is a young male patient, non-cirrhotic liver morphology, plain and arterial face. Is it hyperenhancing? Yeah, there is heterogeneous hyperenhancement, yes. Some areas of washout. So doesn't typically fit into anything, but it's a large tumor. Are we seeing a scar? Not really. This was a fibrolamellar carcinoma. So unless something typically fits into any benign category, unless we see a typical benign feature, we always have to be on guard, especially in a tumor of this size. If it was much smaller, we could probably follow it up if it was less than a centimeter. But any tumor of this size, it is important that we correlate with AFP and raise the possibility of a possible HCC or any other variant of HCC, especially if a tumor is this big and it is arterial phase hyperenhancing. So any arterial phase hyperenhancing lesion, unless it fits into a definite benign category, we are not to ignore. We have to raise a red flag and suspect a HCC or any kind of a variant. So another arterial phase hyperenhancing lesion. There's more than one. There are multiple. We're also seeing hyperenhancing foci in the stomach. Yeah, so this was an NET. It was a multifocal NET. It had NET foci in the stomach, in the duodenum, probably a ZE syndrome with multiple hyperenhancing liver metastasis. So the other close differential to watch out, especially when multiple and hyperenhancing the arterial phase, hypervascular liver metastasis. Somebody want to take this? Arterial, total, venous. Yeah, it is a rim arterial phase hyperenhancement, yes. And what's happening in the subsequent phases? We use the term washout when if something was hyper in the arterial is showing lesser density later. Yes, we see more enhancement in the subsequent phases than what we saw in the arterial phase. This is the delayed phase. So this is it's a very classic mass forming intrahepatic cholangiocarcinoma. So where we see peripheral, so the reason why LIREDs for HCC harps on non-rim arterial phase hyperenhancement is that there can be other tumors which can show rim enhancement. Even METs might at times show. So this is arterial phase, only rim enhancement, not substance enhancement, progressive enhancement. So the fibrinous stroma in the center of a adenocarcinoma, which is a mass-forming cholangiocarcinoma, tends to enhance in the delayed phase. Now, this kind of an appearance can also be seen in adenocarcinoma metastasis from a CA rectum, CA sigmoid, or CA from anywhere else, at times even breast carcinomas. So, it's important when we see a finding like this to rule out a secondary from a adenocarcinoma elsewhere, especially if it's multiple. But this fits very classically into a cholangiocarcinoma. So the other findings that we expect to see are, so this is an MR image, axial T2 fat suppressed, where we not only seeing a T2 hyperintense mass, but we're also seeing that the mass is encasing the ducts, and there's distal intrahepatic biliary radical dilatation. So this is another important feature to look for. So this, when present, favors a mass-forming cholangiocarcinoma over any other tumor. Similarly, even capsular retraction, this can also be seen in adenocarcinoma metastasis from serous carcinomas like CA breast, but a mass-forming cholangiocarcinoma can also cause this kind of capsular retraction because of the desmoplastic reaction that it causes. All right, we'll now come to volumetry. So the purpose of liver volumetry is to calculate the volume and also the percentage, the segmental percentage between the right and left lobes or between the segments, each segment, when compared to the rest of the liver. So for a volumetry, we are expected to contour the entire liver, which can be done either automated or manually. We then trace the hepatic veins. So the most important vessels to trace in a volumetry are the hepatic veins, because this is the plane along which we're going to divide the liver segments between the right and left lobe, anterior, posterior segments, and so on and so forth. So this will be the left anatomy, just an extrapolation of whatever we have seen on the coronal images. Middle hepatic vein divides it into the right and left lobe, segments 8 and 5, right anterior, segment 4 on the left, segments 2 and 3 forming the left lateral segment, and the right posterior segments 6 and 7, which are posterior to the right hepatic vein. So we look at a few applications of this. So when we get the total liver volume, which is in this case 1141 cc, we then do, so almost the relative density of liver is estimated to be 1, which is why the volume is almost taken as weight. So a liver with a volume of 1000 cc is almost extrapolated to be a liver weighing 1000 grams, or a 1 kg liver will be almost a 1000 cc on volumetry. And then when we have to divide the liver between right and left lobes, if you're planning a right hepatectomy or a left hepatectomy, this is going to be the plane along which we divide, and then get the relative volumes of the right and left lobe. Depending on whether we want to preserve the MHV or not preserve the MHV, the volumes might slightly change, but it can be more or less similar. So here it's important for us to identify the segment 4 vein from the segment 5 vein, because if a right hepatectomy is being planned, and we want to preserve the middle hepatic vein for the donor, if it is a case of transplant, it's important to leave the segment 4 drainage vein intact. And there are cases when only a left lateral segmentectomy might be required. If it's an exophytic mass only from the left lobe of liver, only a left lateral segmentectomy is to be done. We also calculate the percentage volumes of these. So we'll just look at a few clinical examples. So this was a mass in a non-cirrhotic liver in the right lobe, a well circumscribed mass. So where would you want to localize this to? Yeah, so it's predominantly in the posterior segments of the right lobe, but it was also partially encroaching into the anterior segments. So in this case, the total volume of the liver was taken, and also the regional volume. So we do a sectioning of the liver. So this region is 60.4%, which means this right lobe of liver. And the left lobe of liver remnant still has 39.6% volume, which means that even if a right hepatectomy done, this being a non-cirrhotic liver of good quality, it is good enough for a good quality of a future liver remnant. So this patient then underwent right hepatectomy, but the other option in these cases, especially if this was a hemangioma, it's also possible to do only a non-anatomical resection. So in those cases, it's also possible to just outline the tumor and extract the tumor volume. So the tumor volume alone in this case also could be calculated as 324 cc. So especially if it's a cirrhotic liver and there is a tumor which requires resection, and we don't want to, we want to preserve the liver parenchyma as much as possible from a surgeon's perspective, we also give the absolute tumor volume so that as much of the remnant liver can be preserved. So where is this mass? Different case. Predominantly segment 4. Is it there anywhere else? All right, so this is the arterial phase. This is the right anterior artery. So that is infiltrated. The right posterior artery is this tiny dot that you can see here, that's relatively preserved. The right anterior portal vein is also involved. And if we look at the venous phase, the entire middle hepatic vein is gone. It's encased by the tumor. So this tumor is not only in segment 4, but it's also involving the right anterior segments, which is why the plan in this case was to look at a extended left hepatectomy, which is why the right posterior segments alone need to be determined. We need to see if the volume of the right posterior segments alone is sufficient to sustain a proper future liver remnant. So in this, luckily it was found that the right posterior segments have a volume of almost 39.8% relative to the entire liver. And the right hepatic vein was free and uninvolved. The right posterior vein, the right posterior portal vein, and the right posterior hepatic artery, the main portal vein and the common hepatic artery were also good enough, which is why this patient underwent a extended left hepatectomy, preserving only the right posterior segments, and the patient did quite well. So this was the post-op image. After the patient had a regeneration of liver, this is the right hepatic vein. The entire right posterior segment has regenerated and grown. This was almost a year later. So for the right posterior segmental volume alone, we look at the volumes behind the right portal vein, right hepatic vein. The rest of the liver, we can see that the middle hepatic vein is not seen at all in this case because it's completely involved and encased by the tumor. So these are the various applications of liver volumetry to see and decide if it requires a segmental non-anatomical or an anatomical resection, and look at the remnant liver volume. The other things to watch out for are vascular anatomy. So one of the, yes. For volumetry, anytime CT, because the quantum of contrast in the hepatic veins is what helps us determine which segment we're looking at. And to have a good quality volumetry in an MR, the problem with MR is it can give you relative volumes well, but for absolute volumes, because of the motion artifacts, it might not be accurate. So if this patient was being considered for a, so let us just imagine that we're looking at a volumetry in a donor. If we were to look at volumetry in a donor, it's important to get the absolute liver volume also right, because any changes in that beyond 10% is going to affect the survival of the graft in the recipient. And this variation is bound to happen in MR because there is bound to be breath related artifacts which will lead to overestimation. So in one phase, the diaphragm might move a little higher up, in one phase it might move a little lower down. So we tend to overestimate the volume on MR. But if we were to look at the relative volumes, and if you're having a good quality triphasic MR where the hepatic veins are well visualized, it is all right to go ahead. But if you're going to plan a volumetry, anytime CT is advisable because of better breath control and because of better opacification of the veins on contrast. All right, so the other important thing as radiologists which we are supposed to give for is the segment for the overall vascular anatomy, especially the arterial anatomy. Now this can be very tricky, especially when we're looking at a segment 4. So if we are planning a left hepatectomy, the segment 4 artery is very, very important to determine, because if the segment 4 artery was coming from the, say if we are planning a right hepatectomy and the segment 4 artery is coming from the right hepatic artery, doing a right hepatectomy will also compromise the supply to segment 4 in the remnant liver, which is why it's important to always look for the segment 4 artery. So in this, it's very obvious. It's a big, large segment 4 artery from the left hepatic artery. Here it's a very, very tiny twig which was visualized with a lot of difficulty. Now in this case, we can see that the segment 4 is from the LHA proper. There's an LHA which is almost supplying only segment 4 with a small tick to the left lateral segment. But in addition, there's also an accessory LHA from the left gastric artery. One other variant, segment 4 from RHA, accessory segment 2 and 3 from the left gastric artery. So there's almost a non-existing left hepatic artery. There's only an accessory and the segment 4 is from the RHA. One other variant, artery to segment 6 comes from PHA. There's a small accessory artery from the PHA which is supplying segment 6. So these are all the possible variants to watch out for. One other case, a replaced right hepatic artery from the SMA. So all these are anatomical variants to watch out for. So not just vascular invasion, but the vascular anatomy is also an important point to look for before any surgery is planned. So to summarize, characterizing a liver SOL, the first thing to look for is see if it's a cirrhotic or a non-cirrhotic liver morphology. The next thing to look for is the arterial phase. Always please characterize a liver lesion only in a multi-phase contrast. Never ask for a single phase, only characterize on a multi-phase. This is a very, very important point because even suspected metastasis can be mistaken for hemangiomas or vice versa. So arterial phase hyperenhancement, if present, check if it's homogeneous or heterogeneous. Look for presence of a scar. Look for washout and see if the contrast is paralleling the blood pool, because all these features together determine whether it's a HCC or a hemangioma or an FNH or an adenoma or any other variant or maybe even a hypervascular metastasis. The next is look for delayed enhancement, which is especially seen in adenocarcinomas like mass-forming cholangiomas or even in adenocarcinoma metastasis. Look for capsular retraction. See if it's single or multiple. The other thing to look for is biliary involvement and vascular anatomy and involvement. So that's about it. Thank you.
Hello. Thank you so much, ma'am. That was very exhaustive and it completed the liver anatomy very well. So the second presentation would be from Dr. Ashirwad, and he is a consultant in radiology here and a fellow in GI radiology. So he'll be presenting the MRI for CA rectum.
Yeah, hi everyone. So I know it's 8 o'clock and you are ready to go for dinner. I think this CA rectum and reading of pelvis is little new for all of you, because liver you normally see very frequently triphasic liver and triphasic MRs. So rectum, not only as such as rectum, but I would like you know to know few points about pelvis, at least to identify what structure is what and if there is abnormal or normal. That would be my aim here basically. So going by CA rectum, first we need to know the staging, the modalities, the role of MR, what minimal basic preparation of the patient is needed, little MR anatomy, and then locoregional assessment, followed by restaging in post-neoadjuvant. This is, I think, one more important point, and future directions. So at least from this talk, at least one point, if you need to remember one most important point, that is this third point. The most important sequence, the workhorse of the entire MR rectum imaging is high spatial resolution T2 weighted imaging. So there are 2 points in this. One is T2 weighted imaging. It's not FATSAT, it's normal T2 weighted plane sequence, and it should be high spatial resolution. So what does high spatial resolution mean is there should be thin sections, as thin as possible. At least less than 1 mm is advisable. So this high spatial resolution is available in both 1.5 and 3 Teslas. Below 1.5 you cannot image perfectly. So at least 1.5 Tesla is needed. So before staging or restaging of rectal cancer, these are the things which we need to know before doing an MR. The main reason is the rectum tumor, lower rectum, mid and upper rectum. So there is difference in how you image the CA rectum. Matlab, we need to know where is the rectum first, where is the cancer first. So for that we need to know the endoscopy and pre-treatment MRs available or not. So if we know the primary tumor's location, then we can better plan the sequences. As you all know the TNM staging, so the basic point of doing MR is to differentiate T2 from T3 disease. T1 versus T2 is not very differentiable on MR. T1 versus T2 endoscopic ultrasound is preferred. So the entire MR we are doing to identify this T2 versus T3 disease. So that is one point you need to remember. T2 space, high resolution T2 spatial imaging, that is the first important point. Second point is to differentiate T2 from T3 disease. And T3 to T4, T4B, this is clearly identified. Okay. And then nodal metastasis. So we need to know whether it is N0, N1 or N2. That differentiation comes with number of regional nodes that we can count. That is not a problem. But what we need to identify is whether the nodes are only mesorectal nodes, extra mesorectal nodes, regional nodes, or outside the regional nodes. So these are the 3 points which we need to identify on MR. And the other one is metastasis. Metastasis is mostly better identified on a PET CT compared to MR. So what are the basic investigations available? So first thing is we need for diagnosis. So there are 2 things. First thing, if we know that it is CA rectum, we can directly stage the disease and we can give a TNM staging. But most of the times we don't even know whether it's CA rectum or not, and it can mimic a normal bowel wall thickening or something. So then we are not in a very good position to stage the disease basically. So if we have a biopsy report, or if we know that it is for sure that CA rectum, then it is better to stage the disease. And for staging we have US, CT of thorax and abdomen, and MR. So here the US is very good to identify T1 versus T2, and T2 versus T3 is better identified on MR. The reason being the walls of rectum are not very clearly identified on MR. Whereas in US, you can clearly make out the mucosa, submucosa, and other layers of the rectal wall. And also one more problem with the transrectal ultrasound is the upper rectal tumor are not very well imaged, and also the nodal metastases are not identified. So as I said, since there is difference between T1, T2 and N0 disease versus T3, T4 and N2 disease, this is where the MRI scores over endorectal ultrasound, and the treatment varies for them. So the various modalities available. So why do you think MR is better than CT? Anyone? Soft tissue resolution is good, first thing. Next. Yeah, CRM is very well identified on MR then CT. And there is one more thing also. In CT, you also need a contrast. In MR, for rectal protocol, you don't need contrast. This is the standard of imaging everywhere. We don't need a contrast study. It's a plain T2 MR. Okay. Resolution. So in US, you can identify mesorectal nodes, but the locoregional nodes are missed. And also coming to peritoneal disease, the T4A which we talk about, it is better identified on MR. In CT, it is very difficult to make out the peritoneal thickening and peritoneal lining basically. So that is one reason for MR better than CT. So what is the role of MR? First is for identifying patients for neoadjuvant chemoradiotherapy, for guiding the surgeons for surgical planning, and also to identify poor prognostic factors. There are some poor prognostic factors which are independent of all the staging and everything. So two of them are EMVI, that is extra mesorectovascular invasion, and also the mucin content. If it is mucinous tumor, MR is the best imaging modality. In fact, it is better than histopathology to identify mucinous tumor. Signet ring cell is one more tumor which is MR is not extremely good, but mucinous tumor, it is better than histopathology. Next, this is for primary staging. And coming to restaging, we can identify the evaluation of the tumor regression. So the amount of tumor regression identified, and also for tailoring the surgical planning after neoadjuvant therapy. Patient preparation is basically you did not do any preparation. We did not give any enema or anything. Only if there are significant air artifacts. So if there may be air, we can do a small micro enema. Otherwise, there is no need of any bowel preparation. 1.53 doesn't matter. Both are equally good. Non-contrast MRI is enough. And there is no need of any endorectal coil. This was before when people used to say that endorectal coil is better. Now we can go with a standard coil. It's no need of any other coil. It's pelvic coil. We don't need contrast MR except in few areas like probably after neoadjuvant chemotherapy. If you are suspecting some abscesses or some fistulae, we need contrast. Otherwise, it's always the plain MR. So what are the MRI do's? So first thing is any field strength is okay. T2 weighted is compulsory, and other sequences both small and large field. What are MRI don'ts? Endorectal coil is not needed, and fat sat images is not at all needed. Okay. MRI maybe. So spasmolytic agents can be given. I'll show you one example. So the first image here is without any buscopan. The second one you can see is with the buscopan. So this difference comes basically for the upper rectal tumors. Mid and lower rectal tumors not very useful, but for upper rectal tumors you can see how the bowel loops are better imaged on the second image, whereas spasmolytic agent was given. And then no need of any endorectal filling, because once you give some endorectal contrast, it distances the rectum, and also the mesorectum is completely effaced by it. So we don't give any endorectal filling, except in rare situations where only if you are suspecting a small polyp or small polypoidal lesion, then we would suggest endorectal filling. And compulsory, in addition to T2, if we need one more sequence, it is diffusion weighted imaging. So this is very much useful, especially for restaging. Okay. So this diffusion weighted image basically means that, so this is type of functional image. So what happens is normally in a molecule, the water moves freely within the cells. So the amount of randomness, so amount of free movement is how we image the diffusion. So for example, if it is a malignant cell, the free movement of water is not available because of the large nucleus and the reduced cell size. The water movement is not very free. So what happens is if the movement of the water within the cells, or if the tightly packed cells are there, then there is brightness on diffusion. That is how we image as diffusion restriction. So restriction here is nothing but the restriction to the movement of the free molecules of the water, free molecules of water or whatever it is. So you need not know the physics, but basically you need to understand is if the cells are tightly packed, for example in malignant cells. So in such situations there is diffusion restriction, or the cell death. If it is brain, MR brain, where there is cell death or cytolysis, the cells are very tightly packed, and then you get this diffusion restriction. Restriction means that it is bright on diffusion images. Okay. Normal cells, less diffusion restriction. We can also quantify it, but we don't need that quantification. We can just see it is bright or not. So these are the three planes. I hope you all know the three planes. The first image here. Pointer is okay. Sagittal image is the image which we see from the side. So here you can see the second image, lower left image, which is the sagittal image. The third image is the coronal images. So I'd like to show you basic MR anatomy of the rectum and also the pelvis. So you can see this is the normal rectum, which continues, the inner wall continues as the internal sphincter. The puborectalis, this is puborectalis sling, and this is the levator ana margin. The levator ana continues as the external sphincter. So for the rectum, the anal canal, the internal sphincter is continuation of the bowel wall. The external sphincter is continuation of the levator ana. The same thing in MR. all the muscles you see as intermediate to low signal intensity on T2 weighted images. So this is your pelvic diaphragm. This is the internal muscle. This is the internal sphincter inside. In between the two sphincters, you can see a white thin layer. That white layer is the fat. So this is a T2 weighted image. So fat appears bright. The thin layer is in between. This is the intersphincteric plane. The outer dark T2 is the external sphincter. The inner dark is the internal sphincter. And there is some air, so that is also appearing black in the lumen. The same thing on sagittal image. This is the puborectalis sling. So this puborectalis sling, you can see it at this level. That is where you get the anorectal junction actually. And this is the axial image. This puborectalis sling is seen as a continuous elongated fiber on the other sides of the rectum. This thing is the puborectalis sling. This is the internal sphincter, and the fat in between the both, the bright layer in between both is the intersphincteric space. Outside this is the ischiorectal or ischioanal spaces. These both are the ischiorectal, ischioanal spaces. Since this is T2 weighted image, the fat appears bright. Okay, these are the bones here, and since there is a bone marrow, it appears little bright. Okay? The next, what you need to know is the rectal areas, low, mid, and high rectum. In high rectum, there is both peritonealized part and non-peritonealized part. The anterior and lateral halves are the peritonealized part. Only the posterior aspect is the non-peritonealized area. Whereas in lower rectum, the entire rectum is surrounded by CRM, that is non-peritonealized layer. So this is how it looks on a T2 weighted image. This is the internal sphincter. This is the rectal wall, external sphincter. The thin T2 hypointense layer is the mesorectal fascia. Okay. So this is what we are seeing. This mesorectal fascia is this mesorectal fascia here. Thin layer. This is the prostate and seminal vesicles which are outside the mesorectal fascia. So the CRM which we talk about is this layer exactly. This is a very well-built patient. So you have a lot of fat in between this. Not every case is like this. You cannot identify the mesorectal fat in every patient like this. Here what you see, we are in the superior aspect of the rectum because we already see the bowel loops. So there is some peritoneum here. So this is the peritoneal lining, and which has a seagull appearance. The same thing which we can better identify on a T2 weighted image, on a sagittal image. So just above this is the urinary bladder. We are seeing the sagittal image. Okay, this is the urinary bladder. This is the prostate. This is the rectum, and just above the rectum and urinary bladder, this thin black layer is the peritoneum. The why we are focusing so much on peritoneum is once peritoneum is involved, it becomes a T4A disease, and if it is not involved, it's a T3 disease. The peritoneum is almost identified in almost 80 to 90% of the patients, but whatever we do in 10% of the patients, it's not clearly identified. In such situation, what we do is if there is some infiltration at this location, we give it as peritoneal involvement. If there is some amount of fluid, we are very lucky, then we can clearly see the peritoneal layers. Even a minimal amount of 10 cc is enough for us to see the peritoneal fluid. So what images, what you need to see, these are the basic things. So this is an axial image. In axial image, the outside dark layer which we saw was the mesorectal fascia. The star is represented by the fat layer, that is the mesorectal fat. This is the inner bowel wall. So these three things we need to see on an axial image. One layer down, we are here at the level of rectal wall. Here you can again see this this is the coronal image now. Here you can see that these are the levator and external sphincter. Okay. Next we are seeing the sagittal image. In sagittal image, the things we need to identify is the retrorectal space, because that is how the dissection plane goes along in the CRM, complete dissection of the margins here. We also need to see the anorectal ring, which is the junction of the rectum and the anal canal. This is the anorectal ring. And then the length of the tumor from the anal verge. So this is the anal verge. I'll try to show you one case so you can identify the anatomical structures in that case after this. This is the coronal image. You can see that this is the external sphincter, internal sphincter once again. In this case, you are able to clearly identify the mucosa, submucosa, and muscularis propria, but this is not the case in all the patients. If there is some amount of submucosal edema, then the layers are very clear. Then even the T1 versus T2 disease is clearly identified. But otherwise, T1 versus T2 is not very well made out. And then coming to T3 disease, depending on the amount of invasion into the mesorectal fascia, you have the T staging. So 1 to 5, more than 5, more than 15. If there is involvement of peritoneal, it's T4A. If there is ingrowth into any other organ, it's T4B. What about the CRM status? So we call CRM positive if the tumor is within 1 mm of the MRF. It need not invade it. If it is almost within the 1 mm, we call it positive. If it is less than 2 mm, we call it as negative. In between, if it is 1 and 2 mm, we call it as threatened. Okay. Try to show one normal. So someone would like to read the, this is just a normal anatomy we are trying to read here. Anyone is interested, please? So we are in the lowermost section because you can see that there is penis and scrotum anteriorly here. There is scrotum sac. So we are in the lowermost section. Now we are going up. So what is this structure here you are seeing? What is this outer layer? This is the external sphincter, right? This inner one. And this is at the level of anal canal. Okay, this is the anal verge and we are at the level of anal canal. Now we are going up. This hyperintense layer in between these two is the intersphincteric fat. These bright areas along both side triangles, these are the ischiorectal or ischioanal foci. Okay, right. This is the lateral pelvic wall here. These are the both the pubic bones. So along the lateral walls, you see the lateral pelvic wall, side wall. The reason I am telling you this is if involvement of the side wall is there, it's a T4B disease. We are going 2 sections up now. At this section, what is this anterior structure? It's the prostate. This one here, this is the rectum. The inside dark is lumen with air. Okay, this is this one. Okay, fine. What is this structure here? Puborectalis sling. Okay, great. We are going 2 more sections up. What is this? This is the mesorectum, right? This entire thing here is a mesorectum. This is the levator ani. They are little oblique, so that's why I am not seeing it as a clear-cut circle. The anterior is the seminal vesicle. And 2 more things you need to identify. This is the bladder here. And coming out of the bladder, you will see the ureters. These are the ureters. These are the ureters on the other side. So any involvement of these anterior structures is again T4B. Yeah, peritoneal reflection is better identified on sagittal image. There I will try to show you. Then you can come to this side. So here the thin layer which you see here. So in this patient, so what happened? There is some, basically he is a patient of primary infertility and there is some abnormality with the seminal vesicles and all. So, peritoneal reflection is not very well made out in this patient actually. So in such situation, what we do is if there is involvement of the posterior bladder walls just above the seminal vesicles, if there is involvement of the tumor, we call it as probably involved or threatened peritoneal involvement. Okay. Can anyone read this? So two things you need to remember. CA rectum is most of the times is not very hyperintense. It's a moderately hyperintense lesion. And if it is very hyperintense, it is mucinous pathology which we are thinking of. And then if it is definitely more than 50% of the involved lesion, if it is more bright, then we call it as mucinous, probably mucinous pathology. Okay. So anyone would like to read this? It's very simple case. It's a straightforward case. So what is this wall you are seeing here? Sorry? Oh, you're not in. So what is this layer here? What about this one? How is the intensity of this growth? It is not hypo, it is a moderately hyperintense. This is hyperintense. You should not compare with the fat. Fat is always hyperintense. Okay, you should be comparing with the wall of the rectum, because wherever you see MR, the comparison should always be with the muscles, not with anything else. Okay. So the muscles you see here, this is the muscle. Okay. Any other muscle. Also, you can see the rectal wall is nothing but external sphincter. So this is the external muscle. So compared to this is little on the higher side. It's hyperintense, but it's not severely hyperintense. It's just mild to moderate hyperintense. This is how a typical CA rectum looks like. Okay. So we also need to know whether it is involving the entire circumference or it's partly involving, and if there is any extent outside this. So here you can see that the muscularis hypointense layer is completely covering this. So the lesion is confined well within the walls of the rectum. So this is a T1 bar T2 lesion. We need not mention whether it's a T1 or T2. We can just write it as T1-T2 lesion. There is no mesorectal involvement, so definitely there is no T3. Okay, the same thing. Next, one more case. Here you can see this is a very well maintained muscularis mucosa, but here you can see the margins are fuzzy. So there is some involvement into the mesorectal fascia here. So it means that the lesion has gone into the mesorectum. So it is a T3 disease. So what T3 is it? Just you can measure it and we can write whatever T3 it is. Okay. Okay, here what happened? This is the mesorectal fascia. This is the tuberorectalis sling. This is the mesorectal fascia. The lesion is extending and it's almost involving the mesorectum. So you need not see the mesorectal fat or MRF exactly, but it is, since it is reaching till the wall, it is MRF positive disease. One more thing we need to identify is tumor versus desmoplastic. The signal intensity is same as this. The whatever is extending into the mesorectal fat, we call it as tumor, and tumor versus desmoplastic is still a topic of discussion. I think it's needed only for radiology students. Next, coming to T4 tumors. So here you can see that the lesion is completely well outside the walls and it has gone into the peritoneal deflection. Here you can see that this is the peritoneal deflection. So once there is involvement of the peritoneal deflection, it becomes a T4 disease. Same thing here. What is this bright thing? Bladder. We are seeing a SAG image. So this is the bladder. What about this middle layer? Yeah, this is the uterus and this is the vagina here. This is the rectum. Okay. So this growth is anteriorly going and involving the vagina. It becomes a T4 disease, T4B disease. The same thing we can see here in the SAG image. It's involved in the posterior wall of the vagina. As I said, two prognostic factors you need to identify. One is EMVI. So for EMVI, if you see a very well defined, clear cut, some linear structure which is coming out of the tumor, so we say that the tumor has involved the vessel and it becomes EMVI positive. The reason we call EMVI is it's a very bad prognostic factor, and also there is a chance of recurrence. The same thing we are seeing, the vessel here is the inferior mesenteric veins or superior rectal veins, whatever. Coming to end staging, in rest of the body we go with the size criteria, that is 10 mm SAD as the size criteria, but in rectum it is different. Size is not very important because we also have other characteristics which are important. So above 9 it is always suspicious. So whatever is above 9 is definitely positive. Whatever is below 5 is mostly benign, and between 5 to 9 we also need to see the other characteristics. If it is a very well defined round node, we would not be suspicious, but whenever there is some heterogeneity within the node, or there is some, if the tumor and the node are of same signal intensity, we can think that it is probably involving the node. Okay. What about the nodes? All the mesorectal nodes are regional nodes, local nodes. Including that, after that we also have superior, middle and inferior rectal nodes. inferior mesenteric and superior mesenteric nodes, lateral sacral node, and recently even the internal iliac nodes. All these are grouped under regional lymph nodes. The reason we call it as regional is any node out of this is metastatic. It becomes T4B. So here you can see this is the primary tumor. See this signal intensity. There is a one large node. See the signal intensity. Both are same signal intensity. You can always suspect that this is a positive node. Here you can see the same thing again. And also we need to mention the topmost node size because radiotherapy people need to include it in the field of radiotherapy. So compulsory we need to identify the highest most node. Okay. What is this lesion here? How is the lesion first of all? It's a circumferential growth, polypoidal, nodular, whatever. How is it? It's a polypoidal. What is the signal intensity? It is very hyper, it is diffusely hyperintense. So in such a case, it is always a mucinous tumor. Okay, a mucinous tumor is very bad prognosis. And one more thing is mucinous tumors, even after neoadjuvant chemotherapy or chemoradiotherapy, probably will still be positive. They will never become normal. This is the normal tumor. You can see this is not very bright. This is the mucinous. How do we identify low, mid, and upper rectal tumors? We measure from the anal verge. So our measurement is little different from what you do surgically. So it is from the anal verge, and if it is within 4 to 5 centimeters, it's the lower rectum. It is 5 to 10 is the mid, and about 10 to almost up to the 15 centimeters is the higher rectum. How do we identify rectal and the sigmoid colon? So the exact point where the rectum becomes horizontal, that is where we call as rectal takeoff or sigmoid takeoff. That point we consider as rectosigmoid junction. It has nothing to do with the length. Wherever it becomes horizontal, that is where we call it as sigmoid colon. Any tumor involving both rectal and sigmoid tumor, if it is within the first 2 to 3 centimeters, we call it as sigmoid tumor rather than rectal tumor. These are the few veins. Every time we can identify the superior rectal vein, that we need to identify because of this EMVI. Okay, all this has been for the upper, mid, and lower rectum, but there is some difference in the lower rectal staging compared to mid and higher rectum. The reason being, the lower rectal tumors also involve the sphincter complex. So once there is involvement of the sphincter, your surgical planning changes. How do we stage the lower rectal tumor is, if the tumor is involving the internal sphincter, if it is confined within the internal sphincter is 1. If it is not going into the intersphincteric space, it's still 2. Once it reaches the intersphincteric fat, it becomes 3. Once it reaches the external sphincter, it becomes 4. This is one way of staging the lower rectal tumors in addition to the normal upper and mid rectal tumors. However, if internal sphincter is involved, so the new criteria, radiological criteria says that if internal sphincter is involved, you just stage whatever the disease was previous. But if there is involvement of the external sphincter, it becomes a metastatic disease, T4B. How do we assess the sphincter complex? So since this is the internal sphincter, this is the external sphincter, the inner wall is the internal sphincter, the tumor continuation into the internal sphincter is involvement. So we need to see the signal intensity basically, if this and this are the same signal intensity or not. So this is how a normal wall should look, hypointense. But here you can see that this growth is continued into the rectal canal. There are few components. How do we divide it on exentration? This is anterior, central, posterior, and infralevator. So this is basically on the division of the puborectalis sling, which is also anatomically identified by drawing a line from lower end of the pubis to the lower end of the coccyx. I would like to show 1 or 2 images. Just try to identify what they are. Do you see any growth here, or is it normal? First of all, what is this? External sphincter. What about the lesion? Any lesion? So signal intensity. Okay, I'll show you one more image. Now, mucinous, non-mucinous. That's it. Non-mucinous. Involving which wall? Anterior, lateral, posterior. Anterior wall. Going outside the confines or within the confines? Within the lesion. There is no involvement of the mesorectum. Definitely CRM is negative because there is no involvement of the mesorectum, mesorectal fat itself. This is still no. Okay. I'll show you one more image. So what happened here is, this is the puborectalis sling here. You can see very clearly on the right side. What about the left side? Yes. So what happened is, the lesion in the lower rectum And in the anal canal, it has infiltrated the puborectalis sling on the left side. It has not gone into the ischorectal fat because the sling is still maintained. So it is not T4B disease, but it's a T4B disease because it has involved the sling at least. EMVI. Here you are not able to see the veins. Veins we normally see in the mid and higher rectum. This is the lower rectal tumor, anal canal tumor. The same thing we are seeing again on the coronal and sagittal images. You can see that the tumor has clearly gone into the anal canal. So once it is involved in the anal canal, we need to mention the sphincter complex and also the involvement of the various sphincter complex. Where is the growth? 6 to 12. What? This is 6 and this is almost 3 o'clock. Almost 6 to 3 o'clock position. Okay. Anything else you see in this patient? Okay, that is fine. CRM is involved. Okay. Anything else? Yeah, there is a nodule here in the bladder. So it's a metastatic disease. Okay. And the signal intensity very well matches with that of the primary tumor. What happened here is the involvement of the sphincter, and it has completely clearly involved the external and internal sphincters on the right side. Okay. Sometimes you notice such large cystic areas. These are nothing but the primary nodes. So there is some mucinous deposit in the nodes. The same thing again, you can see the involvement of the sphincter complex and involving the internal sphincter, external sphincter. So it's a T4B disease again. Okay. This is at the level of, where is this level? Yes, this is the anal canal. You don't see the bladder or prostate, anything here. So this is at the level of anal canal. So is there any lesion here? Yes, anterior there is hyperintense. So it is a possibly mucinous etiology. Okay. The wall is very well maintained outside sphincter. Here you can see that in the sagittal image, this hyperintense lesion has actually involved the vagina. I mean, prostate. Okay, this is the prostate here. It is actually involved the prostate. What about this? What staging would you? Yeah, T3, A, B, C depends on what we measure. Okay. This is the, we need to know the exact site also where it is. So it is at around 4 o'clock position. This is again one more case here. Do you think this is normal or this is normal? This is normal. Okay. You mean to say this is some amount of mucinous component, some hyperintensity. We'll go to the next image. Actually, this is the tumor here. What happened is this is a wall edema actually. So that is when we need diffusion weighted images again. So not only T2 weighted images. Now here actually even a radiologist should be confused whether this is normal or this is normal. So then we see the diffusion weighted image. What happens is this area will be restricting. Matlab it will be bright on diffusion weighted images. That is how we identify that this is abnormal and this is normal. Then we see that the rest of the rectal wall is some hyperintensity is there and it's just wall edema. This is what we call as EMVI positive. You can see there are two vessels which are coming out of this and they are clearly same signal intensity, wide and also linear. Okay. Okay. One more thing. Sometimes there can be unknown complications. So this is a small perianal abscess. How do you identify abscess? Bright on T2. But even a cyst is bright on T2. So how do we differentiate? Yes, that is where we need diffusion weighted image again. Since abscess is made of pus cells and the pus are tightly packed, there is diffusion restriction on abscess, but there is no diffusion restriction on cystic areas, cysts or fluid. Okay. What about this lesion? First thing, what is this? Rectum, anus, what? Lower anal canal. This is lower rectum. What is this here? Okay, there is a mucinous tumor. Anything else? Something abnormal in this patient? So this is the anus, this is the rectum. Where is the rest of the rectum here? What you are seeing here? You need to see sigmoid or rectum, something, right? Some bowel, but there is no bowel visualized here. So what is happening here? So what about this? See, here you are able to make out the entire wall clearly. There is a growth inside with some vessels inside. So what is happening? Yes, exactly. So this is a sigmoid tumor with intussusception. So what is happening is this sigmoid tumor with intussusception into the rectum. Okay, and this is a mucinous etiology. So such a large tumor is causing intussusception. And how do you identify this intussusception? Is because you are able to see the outside clear-cut rectal wall with inner wall. This is the intussusceptor and intussuscipiens. Okay. In such case, what we should do? How do we identify the T staging? Because this entire thing is a mesorectal pan. So the area where there are vessels, which is supplying, this is called the leading edge of the tumor. So this is where how much amount of extension is there into the mesorectum. That is how we grade it, not the rest of the tumor. Because this rest of the tumor is within the lumen and you need not identify the MRF. Same image, you can see here now clearly the sigmoid colon with rectum. It is intussusception into the rectum. Okay, what about restaging? So staging is very easy actually. The entire problem comes with the restaging. So I want to just few images. So this is how tumor looked on a pre-treatment image. This is the T2 weighted images and you can see the intermediate signal intensity. This is how the diffusion restriction looks. So see how bright it is. Everything is dark on diffusion. Anything bright is abnormal. Very simple. Okay. Everything is dark on diffusion. Anything bright is abnormal. So the bright here is the tumor. And what happened after that treatment is entire diffusion is lost. So it has become less, just like other tissues. So this is very good response. It's complete response actually. Okay. So these are the various modalities you use. I know you are all good with it. How do we grade the tumors? How do we grade the response? So we have something for grading. The 5 is complete, no response at all. 1 is complete response. The T3 is the intermediate response. Okay. Few examples here. So you can see the growth is along the left lateral wall. It's intermediate signal intensity, and after that treatment, there is no intermediate signal intensity. There is only hypo or iso. So what happens is if the signal intensity becomes hypo, it means that it is replaced by fibrosis. If it becomes hyper, it means that it is replaced by mucinous degeneration. Mucinous degeneration is not same as mucinous tumor. Mucinous degeneration is in fact a very good sign after treatment. Okay. Same thing here, you can see the thickening with intermediate signal intensity and completely replaced by fibrosis. Okay. For you to identify, this is what sequence? Yes, diffusion weighted sequence. The entire bright thing here is the tumor, and this is the post treatment changes. Okay. Post treatment, what happens is the entire thing is completely replaced in the few patchy areas. So this is a very good response with some leftover viable tumor. Okay. This is what I wanted to show. This is how a primary tumor looks, and after response, the before sequences you saw, they were completely becoming dark. That is, matlab they were replaced by fibrosis. But here what happens is it is replaced by mucin. This is also a very good sign. Okay, it becomes T2 bright. So don't think that this is tumor, leftover tumor. This is just non-viable tumor. If there are this intensity lesions within this, then it is some part is leftover. This is again complete response. Here you can see the tumor and it's completely replaced by fibrosis. One more example where this anterior wall is replaced by fibrosis. Some patchy areas are left. So this is very good. One more example in the diffusion sequence. Okay. So what about the PET-CT? So PET-CT is basically useful for the distant metastasis. And also sometimes if MR is not able to identify any recurrent tumor, but still your liver, enzymes are increasing or the tumor markers are increasing, then we can probably think of PET-CT. The latest which we are using is the PET-MR. It is not available here very frequently, but PET-MR is very good since you combine the spatial resolution with identification of the localized staging with distant metastasis. You can identify with the PET. So this is PET-MR. So what are the things we need to report? I think the location, the distance from tumor to anorectal junction, the entire length, the morphology of the lesion, the T staging, involvement of the any areas. For lower rectal tumors, we should also identify the sphincter involvement. And CRM is present or not, and if any mesorectal nodes, regional nodes, or distant nodes. Future, there is nothing. It's a dynamic contrast MR. This is not very useful for now. Only we can differentiate between the tumor area. Thank you. PET is not very good for identifying. It is only good for recurrence. Even an inflammatory, malignancy, or any other thing, it will appear positive. There is no cutoff as such for SUV values. So it is for primary identification, PET is not useful. PET MR is better resolution than PET. But for recurrence, you use PET. There is of no use of that. Matlab, only if you are suspecting any abscesses or if you are suspecting any fistulas, you need to enter. T2 sequence in all the 3 planes is good enough. Hello.